Ladies and gentlemen, welcome to day 2 of the 2025 Taipei Valve Summit. I'm Cha Hao Hong, second-year cardiology fellow from Chengxin General Hospital, and it's a true pleasure to be here with you. Today's program highlights the cutting edge of valvular heart interventions, from TAVR live cases to debates on prosthesis mismatch, brand protection, and transcatheter repair techniques. We're proud to bring together an outstanding group of speakers from Taiwan and abroad, representing both surgical and interventional perspectives. This afternoon, we'll continue with interactive case discussions on tricuspid and mitral valve therapies, as well as real-world TAVR in complex anatomy. And now, to officially open today's summit, it is my great honor to invite a leader who has played a key role in advancing cardiovascular care in Taiwan, Professor Chen Wei, Superintendent of Chengxin General Hospital, to deliver the opening address. Please join me to giving him a warm round of applause.
Ladies and gentlemen, distinguished faculty, esteemed guests and friends, good morning and welcome to the 2025 Taipei Valve Summit. It's our great honor to gather once again in Taipei for this premier annual event that brings together the brightest minds and hands in the world of structural heart diseases. The year's summit is designed not only as a forum of education, but also as a launchpad for the future of heart valve surgery, disease therapy, And across the 2 days and multiple parallel tracks, we will explore as a rich and diverse program, including the latest innovations in TAVR, from small annular stent management and redo procedures, to lifetime strategy and valve explantation. Advancements in transcatheter mitral and tricuspid interventions, such as mitral valve in valve, mitral valve in ring, T-tier, and the EVOQUE system. In-depth sessions on post-procedural conduction disturbances, coronary re-access, and patient prosthesis mismatch. Hands-on learning through live surgical demonstrations, imaging analysis, electrosurgical techniques, and even porcine heart anatomy. And a special focus on the future of heart valve therapy, featuring sessions on AI integration, robotic surgery, high-performance biomaterials, and emerging trial results. We are privileged to welcome the world-renowned experts from across Asia, Europe, and North America to share their insights, innovations, and most importantly, their experience at the bedside and in the operating room. We extend our deepest gratitude to all speakers, moderators, institutions, and sponsors who made this summit possible. And to all participants, thank you for joining us and making this event a living, breathing engine of progress. This year's conference came together on a tight schedule, so we apologize in advance for anything that might be not perfectly arranged. Now I would like to invite our co-chairman, Professor Jian Ye, to deliver some words of inspiration. Dr. Jian Ye.
Can you hear me?
Yes.
Thanks, Professor Wei. Respected Professor Wei and Professor Yin, distinguished colleagues, friends, ladies and gentlemen. Good morning. I think here is a good afternoon, but I think in Taipei is still good morning.
Good afternoon.
Welcome to the 2025 Taipei Valve Summit. It is truly an honor to speak with you today, even if, unfortunately, I have to do so remotely this year because of my knee injury. I'm really grateful for the hybrid format that allow me to remain connected and engaged from afar. As many of you know, I have had the privilege to attending this remarkable person for over a decade. It has always been one of the highlights of my professional years, not just for the depth of learning and the quality of the program, but also for the opportunity to reconnect with my friends, colleagues from around the world. Taipei Valve Summit has always been a unique and vital platform because the Valve Summit brings together cardiac surgeon, interventional cardiologist, imaging expertise, anesthesiologist, and many other specialists to explore, debate, and refine our approach to treating valve heart disease. Taipei Valve Summit has been a place where lifelong friendship are forged over shared dedication to advanced valve care, and also a place where innovation meets a collaboration. I have seen the Valve Summit growing from a regional to a global gathering for cutting-edge valve interventions. As always, this year's program is rich and looks fantastic with high-quality lectures, expert presentations, roundtable discussion, debating, and live case demonstrations. This year's agenda continues a tradition of fearless dialogue and fruitful discussions. Whether you are joining us from across the globe or online or gathered in the conference room in Taipei, I encourage you to actively participate, sharing your insight and asking questions. Whether you are a cardiac surgeon or cardiologist or other specialist, your expertise will shape the future of valve care. I want to take this opportunity to thank the organizing committee for putting together such an outstanding program and for their tireless work in making this summit accessible to so many people, regardless of location. And thanks again. Welcome once again to the 2025 Taipei Valve Summit. I hope it will be 2 days of full of learning, meaningful conversation, new ideas, and friendship. Enjoy the summit. Thank you, and I hope to see you all in person next year.
Thank you, Dr. Jianye. Now we have to proceed to our first session. That's the keynote lectures from experts from that will be on your schedule. Okay, so please, our moderators to come upstate to the stage, and our moderators will be Dr. Jianye, Dr. Park Du-Wu, and Dr. Cai Jian-Song. Okay, and the participant experts will be Evandito Canjoro, Dr. Lin Ziyuan, Dr. Ke Hongyan, Dr. Lin Jiaping, Dr. Lin Maoxin. Okay. So the first topic we're going to have Dr. Jianye to talk to us on the topic of prospect in heart valve surgery. Let me have a brief introduction to Dr. Jianye. Dr. Jianye is a clinical professor and instructor of cardiac surgical research at the University of British Columbia. He's also a cardiac surgeon and the director of surgical mitral and tricuspid valve program at St. Paul's Hospital and Vancouver General Hospital. His subspecialty is complex mitral and tricuspid valve repair and transcatheter heart valve therapies. Dr. Ye is a pioneer in the development and the clinical application of transcatheter heart valve therapies, and he has performed many first-in-human transcatheter heart valve procedures for aortic stenosis, failed bioprosthesis, pure aortic regurgitation, mitral valve, and the tricuspid valve regurgitation. He has educated many physicians and surgeons in TAVR and the surgical mitral and the tricuspid valve repair, and supervised many transcatheter aortic and mitral valve procedures around the world. So please, Dr. Jianye, let's give him a very quick welcome to this topic. Thank you.
Can you see my slides?
Yes.
Oh, okay. Oh, it's not moving. Okay. Thanks, Professor Weir, for your kind introduction. Introducing, sorry. So, good morning, everyone. And I was asked to give a talk on the prospect in heart valve surgery. So when I received this title, I thought what I should talk, put into the slides and talk about it, about the prospect in heart valve surgery. But I look at the program. I think there's many other leaders will give a talk on the TAVI. So my talk will more focus on the surgical part. So the cardiac surgery, has the three stages. The first stage is we call the closed heart surgery. That was in the very early years. So the first closed heart surgery as performed by Dr. Cuddery in 1923. And he performed a blind mitral valvulotomy. And in his discussion, paper, and he mentioned that he really don't know when which valve he put in, the knife he put into the heart, and so that there's probably is a mitral valve or could be the aortic valve. So it's purely blinded, and then relieved the valve stenosis, and patient survived. So this was the first case, successful case in heart surgery. And following that, so in 1925, Dr. Suiters performed the first finger fracture for mitral stenosis. I think this is more controllable compared to the knife blindly in the heart. You don't know where the knife located. Particularly at that time, there's no echoes or no imaging technology, and you put a knife in the heart, you really don't know where you're cutting. But the finger, I think, is much controllable in this kind of blind situation. So this was the first performed with the finger in 1925. And then Dr. Harkins and then performed the true closed mitral valvuloplasty. And in 1973, he reported over 1,500 cases with a closed mitral valvuloplasty. So this was the early stage of the cardiac surgery. And I put this as a closed heart surgery because at that time, there's no oxygenation or heart lung machine available. So there's no choices. You have to perform closed heart beating heart surgery. And but not much really you can do except for valve stenosis. So you're trying to relieve the stenosis, but not much can be done with valve regurgitation. So the next stage was open heart surgery, and this is because the Dr. Gibbon developed the oxygenation and the heart lung machine in 1953 and performed the first open heart surgery, true open heart surgery in human. That's in 1953. So this is really advanced and broadened cardiac surgery. So in terms of valve surgery, true valve surgery, that was performed in 1960, the first aortic valve replacement by Dr. Harkins, and used his ball caged valve. And then in the same years, as everybody knows, Dr. Starr performed another mitral valve to replace them with a caged valve in 1960s. So, and of course, since then, many open heart surgery has been, developed, advanced, and now in the 2022, the new era
also become a closed heart surgery, but this is compared to the earlier stage as a different closed heart surgery. And as you know, the first closed heart surgery transcatheter approach was performed by Dr. Quibier in 2002. So since then, the many advanced in transcatheter therapy has been established and developed. So in terms of prosthetic valve for valve replacement, the first valve I think everybody knows in 1952, this was first valve implanted and for aortic regurgitation. And I'm not sure everybody's seen this valve. This is actually the first artificial mitral valve developed by the first actually certified woman cardiac surgeon in the States. And but this valve never be commercialized, but did implant in the human. So this is the first artificial mitral valve. Of course, since the 1950s, many valve has been developed, such as bovine valve, porcine valve, mechanical valve, and then later on in the transcatheter era is transcatheter valve, and also the surgical sutureless valve. So there's a many different type of valve, and different material has been used in the artificial valve. So in terms of surgical technique, and also has been involved over the past many years. And as everybody knows, sternotomy is a standard approach for all the cardiac surgery, suitable for all the cardiac surgery, but is a relatively invasive. And of course, follow a new minimum invasive procedure approach has been developed, and particularly for the aortic valve, such as Himes sternotomy or the mini-thoracotomy, and also mini-thoracotomy for the mitral valve, and more advanced for the robotic assistant approach, and with multiple keyholes incisions. And now it's nowadays there's no incision. It's basically a needle puncture for the valve replacement. So as you see that this development is really from a massive incision to the almost no incision. So the current landscape of valve surgery and prosthetic valves, so is one is a surgical valve replacement, as everybody knows, by prosthesis and mechanical valve, and also the Ross procedure, that's an autologous valve. This nowadays has been quite a hot topic, and many surgeons started this procedure. So I will give a reason why this is becoming popular. And second type of surgery is a surgical valve repair, and this also now is expanded to the aortic valve, mitral valve, and tricuspid valve. And transcatheter valve repair is there's many devices, but the most popular one is still the clip device, and this has been very successful and expanding rapidly over the past several years. And of course, transcatheter valve replacement now can be used for all cardiac valve, like a pulmonary, aortic, mitral, and tricuspid valve. So one question is about the mechanical valve versus biprosthesis valve, because that's also that has been debating, and there's more data came out whether the mechanical valve still has a room for the aortic valve and the mitral valve. So for the aortic valve replacement, there's a data has clearly showed that the mechanical valve provided survival benefit, particularly in the young patient less than 60 years old. And I think that quite a publication and supported this. Of course, there's no definite randomized trial to confirm this, but overall, this mechanical valve provide a survival benefit. In terms of mitral valve, there's also have quite a publication recent years. And this is our study. We matched a patient at a different age, less than 65 as a 225 matched, and 6 to 75 years old, we matched 170. And for the isolated mitral replacement, as you clearly see, the mechanical benefit actually is up to about 65 years old. So as you see it on the first picture here, is up to about 65, and it shows the benefit of mechanical valve. And also in the less than 65 years old, the group mechanical valve definitely provide survival benefit. So we matched about 20 to 30, I think, I don't remember the factors. So 32 factors. So we are propensity matched and clearly show the benefit in the young patient. So about the tricuspid valve replacement, the mechanical versus biprosthesis, this is still debating, and there's a limited number, of course, available. So this is a recent publication as show the mechanical valve actually also provide a survival benefit for the tricuspid valve disease compared to the biprosthesis valve. So overall, so for that particular for AVR, mitral valve, and tricuspid valve, there's a show this mechanical valve provide a survival benefit. Of course, there's a disadvantage of the mechanical valve I'll mention later. And in terms of loss procedure, nowadays is quite again, interesting and promoted. And many cardiac surgeons now want to do the Ross procedure, and not really young patient, but even like some 50s, 40s, and people trying to do a Ross procedure. The reason is because everybody believe Ross procedure really can achieve normal life expectancy. For any other aortic valve replacement, they cannot achieve the normal life expectancy. As you see, this is a paper. This is a paper published, and they show the age and sex matched angio after loss procedure. Actually, the survival is very similar to the general population. But of course, I just need to be a caution, because after the 15 years is a number, and the particular 20 years, the number is extremely small in the Ross group. And of course, these kind of patients are very young patients. So eventually, these patients will require second aortic valve intervention, as you see here, up to about the 15. Oh, sorry. About 20 years is up to about 40% of patients will require reintervention, but these patients are 40 years, so definitely in their life they will require a second operation. And I will try to say a caution to promote the Ross procedure, as this will create some issues I will mention later on. And the TAVI, in turn TAVI, I will not talk too much, but this is as a recent 8 years follow-up from a Notion trial, and basically TAVI versus surgical valve in young, in low-risk patient, but not young patient. There's age is over 75. So as you see, the basic in terms of all-cause mortality and cumulative basic valve failure are very similar between the surgical and the transcatheter valve. So this is the longest follow-up from a randomized trial, but as in low-risk patient, but not young patient. So the overall, I think in the future, the TAVI is a standard for high, intermediate, and low risk patient, and expanding now to the young cohort, and also expanding to patients with AI. And the durability in young patients, of course, is still under investigation. And this is a TAVI now is becoming now the day surgery. So before will be a next day discharge, but now very healthy and good anatomy, this kind of patient we now is trying to discharge same days. So the becoming day surgery, of course, will improve in cost effectiveness. And so nowadays, the TAVI cost actually is much less than surgical cost because is no hospital stay or one hospital stay. So I think the TAVI will continue expanding, even if the durability, long-term durability, is slightly worse than surgical valve. I think that TAVI will still be accepted by majority of patients because of less invasive, quick recovery. And in terms of valve replacement, there's a major concern and barrier is mechanical valve. Of course, we know there's data show there's a survival benefit, but the problem is that mechanical valve require open heart surgery. As you know, there's no transcatheter option if failed. And the long-term warfarin, of course, that's the major concern. And some patients also cannot tolerate noises. In terms of Ross procedure, as I mentioned, probably suitable a very small group of patients. But the issue is from simple AVR to a complex aortic root procedure, also convert a single valve into a double valve problems. And potential aortic autograft dilatation, and another thing, pulmonary autotic allograft failure. That's still the issue. I don't think this is resolved, and the challenge reduce operation probably is a much challenge for the simple aortic valve replacement. So that's why I think we should caution. Another thing is experience very important in terms of perform this procedure, not just a finished procedure, but for the long-term outcomes. And every surgeon will perform very few cases per year, and you really cannot reach the same outcome as a person who perform like 100 cases. So that's why it's very important be carefully to expand this kind of procedure to like a large patient. And the TAVI, as you know, is undetermined long-term outcome in young patients, still not yet increase the risk of surgical redo AVR, the concern. Bicuspid aortic valve still suboptimal compared to surgical aortic valve replacement. Also, the reports has been controversial. And another thing is that I think that the left bundle branch block and the PVO still an issue compared to surgical valve. So there's some issue, but as I said, the TAVI will be the standard for majority of patient. I think that transcatheter mitral and tricuspid valve, I think, is very limited experience and also facing anatomic and anchoring challenges. So future aortic valve intervention, I think, as I said, because of the less invasive quick recovery, and TAVI will be accepted by majority of patients regardless. And the surgical valve replacement or repair, I think it will become a very limited indication. Probably still will be offered in the young healthy patient with aortic root anatomy, not suitable for repeated TAVI. And the patient's preference of mechanical valves, or patient require concomitant cardiac procedure, and the patient with failed TAVI and unfair anatomy for repeating TAVI. So I think the indication probably will continue for surgical aortic valve replacement, but most of the aortic valve, aortic stenosis patient will undergo TAVI. And the Ross procedure, I think, should be cautioned. I think only offer for young patient. So the next one, I'm going to talk about the repair and the replacement because this is also that, is quite a discussion about the repair replacement. And this is regarding the mitral valve repair replacement. And this is our reason the publication, and we matched the 415 patients, the propensity match, and undergoing isolated aortic valve or mitral valve replacement and repair for degenerative mitral valve disease only. And you can see that the freedom from reopen mitral valve repair is 96.6% at 10 years. So it's very durable. And the survival, there's a survival benefit compared to the replacement. So this is also confirmed by the other state group when they matched MVR with MV repair, so in matched patient. And in terms of tricuspid valve repair versus replacement, this is still debating. There's a limited data available. As this paper is actually from California, they did a propensity match and it showed this tricuspid valve repair actually provide survival benefit and also less reintervention up to 20 years. So this is a propensity match study from California, and the numbers are pretty big. So this shows the repair is better. But of course, this is still as the debating and whether the repair is better than replacement. So the challenge and barrier for the mitral and tricuspid valve interventions is a mechanical valve, as a mitral valve repair. Of course, we know there's better survival across all age. Actually, our studies show regardless age, the valve repair actually is better, even in the 80s. So the problem is a very limited number of specialized valve repair surgeons with a repair rate of greater 90%. So there's lots of repair surgeons, but in order to achieve greater than 90% repair rate, the study show the annual number of mitral valve repair per surgeon should be 40 or 50 cases per year. But the majority of the surgeon actually is, they don't reach this number of the mitral valve repair per annual, particularly in the States, very limited the surgeon actually reach that number. So I think that the valve repair surgeon is still limited. And another is the reimbursed system and the referral system that make a repair is still very low. In the United States, and the repair rate is still around 70, less than 80%. So the reason is because of the reimbursement, as a repair as a replacement same. So our situation is same. So as a repair take a much the complex repair take a longer, and the replacement quicker and simple procedure. So referral system is the individual referral, so the most people probably will be replaced valve. So I think that's still the barrier and challenge. And another thing, the conventional versus the minimum invasive. I think yes, we are all like the minimum invasive, but the situations when you do the minimum invasive, you should not compromise the long-term outcome of the mitral valve repair. That's the key. So if you can achieve the similar outcome of the mitral valve repair, minimum invasive is a better approach. And the robotic assistant, I think the cost effectiveness is still an issue. And in terms of tricuspid valve repair is really not determined as superiority over replacement. And this even worse compared to mitral valve repair surgeon, because they really have few special tricuspid valve repair surgeon, and no standard or standardized repair techniques for tricuspid valve. And therefore, it's very difficult to do any clinical study or random trials, repair versus replacement, because it's a center is very limited and the surgeons are very limited. And another issue is that most surgeons are afraid to operate on patients with isolated tricuspid valve because of historic high operation mortality. So this is still in mind. So many surgeons are afraid to touch an isolated tricuspid valve patient. And in terms of tricuspid replacement, I will not going to discuss it too much, but this is still in a very early stage, and I think TEERS is most common procedure and widely accepted for mitral, particularly for functional mitral regurgitation. For the degenerative will be more like in high risk patient. So I think the surgical repair remains a primary intervention for degenerative mitral regurgitation until transcatheter anatomical repair technology is established. So I think that's probably in the next 10, 20 years, I think probably the surgical valve repair probably will be still the primary method. And more comparative study, I think, needed on tricuspid valve repair versus replacement, and also the surgical versus transcatheter tricuspid valve intervention really have limited information to support either. And TEERS, I think, will be a primary catheter repair for functional MI in the majority of patients, and tricuspid repair degenerative MI is probably in relatively high risk and elder patient for now. But I think this will expanding because of the low procedural risk. And the TMVR, TTMVR, I think is probably will be still an alternative option for high risk patient. But I think that's probably take quite a years to broaden the indication. I think compared to TAVI, probably this will be a much slower because the challenge of the anatomy and the anchoring systems. And I think a future transcatheter valve repair, I think it would be a combination procedure to achieve anatomic and a complete repair. So I think that in the future will be not just a simple like single procedure. I think it will be combinations such as the neocords or the annuloplasty ring. That's kind of a transcatheter repair technology. So emerging technology in the future horizon, I think this is really interesting. So there's one mechanical valve actually without need of anticoagulation. It's called a TriFlow heart valve. This valve actually designed for the aortic and the mitral position, and they did extensive animal studies, and also now have a implant like 10 valves in human aortic position and without anticoagulation. So the preliminary result are quite encouraging. So if this is confirmed to be the true, the mechanical valve doesn't need anticoagulation, this will change the game in the future, and whether will be open valve surgery will become popular again, because a major mechanical valve disadvantage is anticoagulation. So if the valve doesn't need anticoagulation, probably this will be the future for the valve replacement. And other things for, of course, the tissue engineering and other smart biomaterial, such as a RESILIA valve. So this is a RESILIA valve now has reached 8 years of follow-up, and the freedom from SVD, structural valve disease deterioration, is 99.3%. And from reoperation, 97%. So by 8 years, this number is very, very encouraging, and is much better than the Magna Ease and Magna series. So this is also encouraging. 8 years still remains, very, very few structural heart valve failure. And of course, other technology is also developing. And I think, as mentioned, the AI technology will be the role in the decision making and the patient selection and the device selection or these kind of things. I think AI and the 3D printer and the imaging technology, I think it will play a major role in the future valve intervention. So. And also, I think training will evolving, and I think a surgical training will be not just surgery. I think a transcatheter technique, and also the surgeon will become the surgeon imagers and the surgeon interventionist. I think imaging is extremely important for surgeon to understanding the echoes and CTs. I think this is crucial for the future for cardiac surgeon, and familiar with all the technologies. And I think as a true collaborative heart team, and is very, very critical. It's not for the TAVI, but I think for the transcatheter mitral and the tricuspid valve intervention is so critical and more complex compared to the TAVI. So I think I put the true collaborative heart team is so crucial. So this is my last slide. I think heart valve surgery is entering a precision-driven, less invasive, and more patient-tailored era. True collaboration among different specialties is the key. The future lies in smart biomaterial, AI-guided decision-making, and robust outcome data. So I think the future will change. It's not just the operation. I think there's involved many other areas and the collaborations. Thanks.
Thank you, Dr. Ye. Thank you for your good overview of the past and present and the future, the therapy of the heart valve diseases. Since the time strain and we have to proceed to the next topic. Thank you, Dr. Ye, again. Okay.
Thank you, Dr. Ye. And I'm Jian Songcai from Triceps General Hospital. It's my honor to be here under the invitation of my mentor, Professor Wei, and the committee. Next speaker will be Professor Bernard Prendergast from London. Before his talk, I briefly introduce Professor Prendergast. He is the chair of cardiology at the Cleveland Clinical London and maintains NHS activity as a consultant cardiologist and at the St. Thomas Hospital in Westminster. Professor Prendergast is a national and international key opinion leader and infrequent demand as a lecturer and speaker. He has been honorary secretary of the British Cardiovascular and the Cardiovascular Intervention Society and the chairman of the European Society of Cardiology Working Group on valvular heart disease. Professor Prendergast also is the principal course director of the PCR London Valve and the senior member of the PCR board. Professor Prendergast, please start your speech. His topic is latest update of aortic stenosis.
Me to join you remotely for this important session. It's always a great pleasure to link with you, if only virtually, and I'm only sorry that I cannot be with you in person. My name's Bernard Prendergast. I'm a cardiologist based in London, and I'm also heavily involved in the PCR organization. And I thought it would be helpful to share with you some highlights from the recent EuroPCR meeting held in Paris, France, just 2 weeks ago, with specific focus on the subject of TAVI, which I know is a rapidly growing enterprise and a rapidly growing procedural activity for all of you in Taiwan. Just for those of you who've never had the good fortune to come and join us in Paris, EuroPCR is now the world's largest intervention meeting. And here is a picture from the main arena in the opening session of the meeting, which gives you some flavor, some feeling of the high level of activity and the high level of interest in the educational program that is on offer in Paris. This year we had over 12,000 attendees, a near record attendance, including 1,000 faculty members from all around the world, and over 3,000 original submissions of original research, abstracts, and cases. And importantly, colleagues come to join us in Paris from all around the world, as represented by this slide. You will see, of course, that 50% of our colleagues come from Europe, but we recognize increasingly the very important relationship with Asia, with very large numbers of colleagues coming from China, from Taiwan, from India, from Australasia and Japan, truly giving a worldwide flavor to the meeting and a very strong sense of belonging to an international community. So I told you that there were 3,000 submissions of original research and cases, and one of our TARSUS course directors was to sieve that down and to create sessions which highlighted the most original and most clinically relevant research. And I want to start with two of the late-breaking trials which were presented in a special session, two of these related to TAVI out of the complete number of 3. The first addressed the very important clinical question of stroke protection at the time of the TAVI procedure. an important meta-analysis presented by Raj Kharbanda, my UK colleague from Oxford. You will doubtless be aware of the protected TAVR trial that was published in the New England Journal of Medicine in 2022, led by colleagues in the USA. And more recently, in 2025, we had an even larger study published in the New England Journal, which described the outcomes of the BHF Protect TRAVI trial. In sum, these trials randomized over 10,000 patients to strategies of either conservative treatment or stroke protection with the Sentinel cerebral protection device inserted via the right radial artery. You will see that each of these individual studies was negative in terms of the primary endpoints of major stroke protection, and this meta-analysis set out to combine the data sets and conduct a patient-level meta-analysis. You can see that when you pool the data, there are over 5,000 patients in each arm, and that the patients randomized are very representative of everyday TAVI practice in Europe and the USA. Patients in their early 80s, 40% of whom were female, and approximately 10% of whom had a bicuspid aortic valve. Perhaps unsurprisingly, the meta-analysis of two negative trials confirms that there was no statistically significant benefit in relation to the primary endpoint, the combined primary endpoint of stroke and disabling stroke at 72 hours following the procedure. Intriguingly, a secondary analysis, according to the per protocol analysis, whereby only patients who had successful deployment of a Sentinel cerebral protection device were analysed, demonstrated a small but statistically significant benefit in relation to stroke prevention. And this was confirmed in the further secondary analysis focusing on disabling stroke. So whilst these were not primary endpoints and not within the original statistical design, perhaps an intriguing suggestion that failure of Sentinel deployment may be associated with minor net harm, or alternatively, that successful deployment is associated with a very small statistical reduction in the incidence of stroke. And this intriguing hypothesis-generating question is subsequently undergoing more detailed analysis by the investigators. But for the timing at least, a very clear signal from these major randomized controlled trials and the associated meta-analysis that systematically there is no reduction in periprocedural stroke or disabling stroke associated with the use of the Sentinel cerebral protection device compared with control treatment. Moving on, the second important late-breaking trial presented within this main arena session focused on the combination of coronary artery disease in TAVI patients and specifically addressed the role and the importance of functional physiological assessment of intermediate coronary lesions as compared with an angiographic determined treatment strategy when it comes to percutaneous intervention as an adjunctive treatment to transcatheter aortic valve implantation. In this study, led by Flavio Rebecchini and colleagues based in Italy, the primary aim was to compare the clinical benefit of FFR-guided PCI in these challenging patients with coexistent coronary artery disease and severe aortic stenosis versus an angiographic-guided strategy. The results of this trial are demonstrated here in terms of the primary composite endpoint of the clinical events, and you can see an important statistically significant benefit associated with use of systematic FFR to evaluate these patients. Breaking it down, you can see that there were important reductions in death, important reductions in ischemia-driven revascularization, and important reduction in the incidence of stroke, suggesting that FFR-guided strategies in aortic stenosis firstly are safe, because this has been an important question with concerns relating to the administration of adenosine in these patients, And secondly, very important clinical benefits associated with an FFR-guided strategy in patients with intermediate coronary stenoses and associated aortic stenosis, suggesting that we should use FFR more frequently in our everyday practice to guide these interventions. Moving beyond the late-breaking trial sessions, we also had multiple TAVI-related research abstracts presented in hotline sessions dotted throughout the programme. I've picked out a few key highlights for you, the first of which is the 5-year outcomes of the UK TAVI trial, an all-comers trial, non-industry sponsored, led by investigators in the UK and encompassing all TAVI centres in the country and funded from public government funding streams. This trial has already published its 1-year outcomes, suggesting equivalent outcomes after TAVI and surgery in patients with aortic stenosis deemed suitable for either strategy by the heart team. And the 5-year results were also very encouraging, demonstrating complete overlap of the Kaplan-Meier survival curves in relation to the important outcome of death of any cause, or also cardiovascular death. Importantly, however, there was an intriguing signal relating to a higher incidence of stroke at long-term follow-up in the TAVI arm. And you can see that this separation occurred during the first year of follow-up and has become slightly more amplified over time. The mechanisms of stroke and the underlying clinical explanation remain uncertain, and this question is undergoing current analysis in relation to the coincidence of atrial fibrillation, for example, the dependency on antiplatelet or anticoagulant strategies, and also the differentiation between embolic and hemorrhagic stroke. And this information will clearly be of importance as we go forward. Demonstrating the data here, confirming the higher incidence of stroke in the TAVI arm, and also, unsurprisingly, a higher incidence of conduction disturbances requiring permanent pacing, reflecting the fact that a high proportion of patients in this trial receive self-expanding valves. And importantly, as we conclude the outcomes of this 5-year follow-up, it's very important to reflect on the fact that this is a pragmatic trial funded by the UK government with no industry association or support. The findings are consistent with those of previous explanatory trials in relation to the important endpoints. And as I've emphasised, this small increase in the incidence of stroke after TAVI, which requires further investigation and comparison with other studies. This year at PCR, we also saw several important trials comparing different TAVI devices in head-to-head trials. The first of these was the 1-year outcomes of the Landmark trial, a randomized study comparing the MyVal valve from Merrill in India with the far more well-established Edwards Sapien valve from the US. The 1-month outcomes of this study have already been published in The Lancet, but it was a great privilege to see the 1-year outcomes presented in Paris 2 weeks ago. The findings, as you will see here on this series of Kaplan-Meier curves, confirm the equivalence of the 2 different devices in relation to a variety of different endpoints, confirming the integrity of the MyVal valve and good hemodynamic performance compared with the competing balloon expandable Sapien 3 platform. Similarly, colleagues in Denmark have been undertaking a non-industry sponsored series of studies, undertaking similar analysis comparing the 2 valves in one-to-one fashion in over 1,000 patients in the Compare TAVI trial. Again, we saw the 1-year results of this study presented at PCR London Valves last November, and in Paris we were able to see the 3-year results for the first time. As you can see here, again in relation to the primary endpoint of death, There were equivalent outcomes in the SAPIEN and MyVal treatment arms, and similar outcomes looking at the different subgroups of the primary composite endpoint in comparison. The perhaps only important signal to point out a slight increase in the frequency of moderate or severe aortic regurgitation associated with the MyVal device, although this difference did not reach statistical significance. And finally, in relation to these side-by-side comparisons, a pooled analysis of the two randomized controlled trials at 1 year, in other words, the COMPARE TAVI trial and the Landmark trial, again comparing the MyVal and Edwards devices, showing equivalence at 1 year in relation to mortality, and equivalence also in these important secondary endpoints, the only exception being a higher incidence of new pacemaker requirement and a higher incidence of newly diagnosed atrial fibrillation, again observed associated with the MyVal device. So favourable outcomes for the newcomer valve from India, perhaps with some important clinical differences at 1 year, but no important differences in relation to the very robust primary endpoint of mortality and valve hemodynamic performance. Not such good news, however, for the ACURATE self-expanding valve. Data from the ACURATE IDE study were presented by Raj Makar and Mike Reardon from the US, demonstrating some of the hazards associated with this valve's underexpansion associated with poor clinical outcomes over longer-term follow-up. And many of you will know that subsequent to EuroPCR, within the last week, the ACURATE device has been withdrawn from commercial usage due to failure to reach approval by the FDA in the USA. So despite many attractive features associated with this valve and good clinical outcomes in many, many patients, this, I'm afraid, is another device which will be removed from the clinical arena. Finally, I wanted to focus on the question of bicuspid aortic valve disease and some important results that have come out of a large propensity score comparison led by colleagues from Marseille in France. We know that bicuspid aortic stenosis is increasingly common in the younger patients that we treat, and I know that in Taiwan you also see a high proportion of patients with bicuspid aortic valve disease. These patients have been systematically excluded from the pivotal randomized controlled trials, the only exception being the NOTION 2 trial presented and published in The Lancet 1 year ago, which did demonstrate some important warning signals in relation to inferior outcomes of TAVI associated with this particular anatomical subset. The results of this meta-analysis were therefore of importance and direct clinical relevance, pointing out here that this was a population derived from a very large overall geographical distribution from 18 countries across Europe, involving an overall analysis of well over 100 million patients. And from this very large geographical network, 12,000 patients with bicuspid aortic stenosis undergoing either surgery or TAVI were identified, and then propensity matched with over 1,000 patients, propensity matched patients in each arm of the study. And the essential results are illustrated here, confirming that some of our concerns regarding the application of TAVI in bicuspid aortic stenosis are well-founded, because in this meta-analysis you can see that there was a clear signal that surgical aortic valve replacement was associated with improved outcomes compared with TAVI in relation to the important outcomes of all-cause mortality and post-procedural heart failure. So whilst the use of TAVI in bicuspid aortic valves remains appropriate in selected elderly patients, there is perhaps an important signal here that as we offer TAVI or surgery to younger patients with aortic stenosis with more prolonged life expectancy, that we really do need to consider very strongly whether surgery is a better treatment option, particularly in those patients with complex anatomy, with higher risk of paravalvular leak and the possibility of coronary compromise. Finally, just to outcomes, to report to you some other studies which featured. I won't go into them in detail, but to illustrate some of the themes that came out of the EuroPCR meeting. A lot of interest, as I've already highlighted, in the outcomes of TAVI in patients with aortic stenosis. Important interest in relation to the availability of specific dedicated devices for the treatment of aortic regurgitation using transcatheter technology. And a lot of focus on the outcomes of the early TAVR trial, which has already highlighted the benefits of earlier treatment of aortic stenosis in the absence of symptoms, and the high jeopardy associated in these patients in relation to decompensation in so-called acute valve syndromes, and association with the very high healthcare costs associated with hospitalization and urgent or even emergency procedures. So I hope that summary of the TAVI highlights from EuroPCR is of interest. I encourage you all to visit the PCR website for more detailed presentations and a summary of all that happened in Paris. And I thank you very much for listening to this summary presentation. And thank you very much for inviting me to present to you today.
Thank you very much, Professor Prendergast. Now we proceed to the next speech, moderated by Professor Park. Please.
Hey, thank you. Thank you. I'm D.W. Park from Asan Medical Center, South Korea. I'm very happy to introduce the next speaker, and Dr. Kendra Grob. And she is a well-known cardiac surgeon, and she had, looking at the education, they achieved the Doctors of Medicine in the University of Southern California and the Master of Science clinical trial in the Oxford, England. And she is now Vice President and the Chief Medical Officer and the Structural Heart, the Medtronic. Dr. Kendra, can you start your lecture?
Yes, are you able to see my slides?
Okay, we can see where.
Wonderful. Thank you for the kind invitation to present today at this meeting. I really appreciate this opportunity. Although 6 months ago I did make the transition to Chief Medical Officer at Medtronic, I'm going to try my best to really discuss this from a balanced perspective about where we are in terms of durability. I am a surgeon and an interventionalist, and I've only been in this position long enough to have a little bit of bias. So let's talk about the current evidence. Here are my disclosures. And of course, these thoughts from this presentation are mostly from my clinical practice as a professor of surgery and medicine, as a cardiac surgeon, and as a structural heart specialist. So why do we worry about durability at all? And the reason being is that most of these transcatheter valves, as the last two presenters were alluding to, were designed for high risk or inoperable elderly patients, where one valve was all that these patients were going to need. But as we see from the TVT registry, patients are getting younger. And the trends in the United States are quite profound, where younger patients, less than 65, are rapidly becoming treated with TAVR, with 50% of patients in the California registry and 50% of patients in the New England registry under the age of 65 being treated with TAVR. And so we have to think about the long-term lifetime management of these patients. And so valve durability, how long will the first valve last? And what can we do to maximize that durability has to play into our valve planning. And right now today, I will say that we don't know enough about any of the valves to be able to definitively say how long a valve will last. So let's talk about what does define durability and what should we be thinking of in our heart team discussions. We had our first presenter talk about the surgical options for transcatheter aortic valve replacement. And then we had our second presenter talk about all of the new data and some of the brand new valves who have only very short-term data. And so for our young patients with long life expectancy, what are we thinking about? Well, first, let's talk about the definition. And here's the Capodanno definition that was released in 2017. And thinking about the 4 buckets that define bioprosthetic valve dysfunction: structural valve deterioration, non-structural valve deterioration, thrombosis, and endocarditis. These same 4 areas were then carried into the VARC-3 definitions. And if you think about this, valve dysfunction starts with identifying the etiology of the dysfunction. Is it intrinsic to the valve, being SVD? Is it non-intrinsic, being patient prosthesis mismatch, pannus formation, something that's not to do with the leaflets? Is it thrombosis or endocarditis? Assessing the gradients and central regurgitation, and then is there clinical sequelae where the valve has actually failed? And this is what we're trying to avoid. And as we look at the stages of deterioration, we can then think about, why did this particular valve fail this profoundly? And why did this patient end up in the operating room? As we look at this valve, we can easily see those leaflets are not coapting normally. In fact, if we were to look at those leaflets, they'd be pinwheeling. For the surgeons that are watching this presentation, you can see that that surgical instrument barely fits into the sinus. And so I will assume that the implanters were thinking, I'm going to try to get the biggest valve in possible to prevent patient prosthesis mismatch in this small woman with a small annulus. And in doing so, took a few cc's out of this balloon expandable valve, believing they were doing the right thing, but left an under-expanded balloon expandable valve that only lasted a few years and ended up with early valve deterioration, thinking they were doing the right thing, but leaving a patient with patient prosthesis mismatch and then early valve failure. So let's talk about patient prosthesis mismatch, because these small valves, and especially women, are at particular risk for early valve dysfunction. In the surgical literature, we've known this all the way from the 70s. And so effective orifice area over body surface area. So PPM occurs when the valve is physiologically too small for the size of the patient's cardiac output. And essentially, for surgical valves, all replacements can be considered stenotic, and intraannular valves, or any valve that's constrained, is going to have the same problem. Pibereau also did work on this, and he reports in this particular publication, this is like putting a mouse's valve in an elephant. And I think the visual is so profound when we think about PPM, putting a mouse's valve inside an elephant. In the surgical literature, we have seen that this is really size dependent on the surgical valves, and this plays out in the TAVR literature, and it's very much valve specific. And so it's not necessarily a class effect. It was not a class effect in the surgical valves, and it's not necessarily a class effect. So when we talk about TAVR versus SAVR, well, which TAVR valve and which surgical valve? There's a difference. But regardless, any degree of PPM significantly decreases long-term survival and increases readmission rates and heart failure reoperation for AVR. So valves fail earlier and patients do worse. Meta-analysis, again, showing that moderate or severe for SAVR, and it turns out the same is true for TAVR. So I'll step away from that one way that valves deteriorate and fail. Certainly, we're being pushed as surgeons to do root enlargements and put bigger valves in. And as implanters in the TAVR world, we're trying to do the same thing and put the largest valve in for the patient, create the biggest platform for the next valve, but we have to be thoughtful with what combinations we use. And we don't have a tremendous amount of data to help guide us. So let's talk about what durability data and what data in general we have right now today available to us. And I'm not going to focus so much on propensity matching, because my problem with propensity matching is we don't necessarily know what the people in the room were thinking when they made that choice of that valve. And that's the problem with the bias that goes into propensity matching real world studies. Just like that failed balloon expandable valve that I showed, I'm going to assume that the implanters of that valve truly believed they were doing the right thing when they put that valve in, not recognizing that an under expanded balloon expandable valve was in actuality not going to last as long. They thought they were doing the right thing. So I'm going to really focus on the randomized controlled trials and what we know today in 2025. So the low-risk trials. These two studies are providing the largest body of evidence in regard to low-risk trials. The PARTNER 3 study with the SAPIEN valve and the Evolut low-risk trial. Both incredibly well-designed randomized controlled trials. But we have to remember what valves we're talking about. So let me be clear. The patients are very similar. The trials are designed differently, but the patients are 73 to 74 years old. The STS scores are right around 2. So low risk as defined at the time when these trials were enrolling. Okay. In this particular study, the valve used was the SAPIEN 3. This valve is no longer being used in the United States. We're 2 generations beyond this. So we have to think about this valve and the limitations of this technology at the time when we're thinking about the patients in this trial. And it may be that the valves that we use today will perform better than this particular valve. So with that knowledge, let's look at the data. At 5 years, death, stroke, or rehospitalization, no different between surgery or TAVR with the SAPIEN 3 valve, no different. All-cause death, no different. Hemodynamics, the same, and maintained through 5 years, which is an important distinction because they were stable and maintained through the 5 years. Now, they're numerically different with a p-value that favors surgery, but the number is so small, whether or not that's clinically relevant, I would say that the difference between 11.7 and 12.8 is probably not clinically relevant, but maintained. Here's the important thing. Stage 2 to 3 structural valve deterioration based on the VARC definitions that we started this presentation with out to 5 years, no different between the surgical arm or TAVR with SAPIEN 3. So both options performed well, and SAPIEN 3 holding up very well compared to surgery out to 5 years. BVF, so failure of the valve to 5 years, also no different than surgery. Until recently, we did not have the answer for the Evolut low-risk trial. And so I'm going to present a little more data because this is new to many people, because this has all been presented this year. And so I apologize for this being somewhat biased. It's just that I'm trying to catch everyone up. The PARTNER trial data has been presented a couple years ago. Again, older generation valves, no longer in use in the United States. The PRO still in use in some parts of the world. No difference in all-cause mortality or disabling stroke, a different primary endpoint than PARTNER. Hemodynamic valve performance, better for TAVR than surgery, but numerically not dramatically different. I'm going to highlight regurgitation here. As you see that regurgitation was different for the Evolut valve early, but over 5 years actually improves. And that's a unique finding for nitinol frames. And I bring that to your attention because that's something that was new to me. And so whether or not that is something where the nitinol continues to expand, remodel the annulus, that's the work that is ongoing, and we'll see if that plays out over time. But BVD through 5 years, with death as a competing risk, no different between Evolut and surgery, similar to the no difference in the PARTNER 3 study. I'm going to skip that slide. But the association of BVD with 5-year outcomes didn't matter if it was a surgical valve or a TAVR valve. If you had bioprosthetic valve dysfunction, the outcomes were worse at 5 years. So similar to what I showed in the surgical data, we want to try to avoid this if we can. So BVD, worse outcomes. BVF, actual valve failure, no different. So very similar results to that in the PARTNER study. Reinterventions, extremely low for both surgery and Evolut. Now, we don't have randomized controlled trial data out to 10 years other than NOTION. And as a reminder, this is first generation CoreValve in patients who are 79 years old on average, randomized to TAVR or surgery. And there were no difference in the primary endpoints, good hemodynamic results for both, moderate structural valve deterioration, the same. However, as you noticed here, very small numbers of patients made it to 10 years. Severe structural valve deterioration favoring TAVR in the small number of patients who made it out to 10 years. Severe BVD favoring TAVR, but no difference in bioprosthetic valve failure. Can we extrapolate that the modern devices are going to perform as well? We're going to have to wait for the trials to finish their 10-year follow-up. And I believe that this is why we need to really continue to follow the data out to 10 years and continue to be very critical of the results that are presented. So I'm going to take a little bit of liberty and talk about a presentation that I gave when I was at Emory in the fall last year, and use this as an example to go back to that valve that I showed that was being surgically explanted. And I think that when we talk about patients and we talk about durability, there are a few things that we need to remember. Not all TAVI valves were designed the same. And we have to be thoughtful of the patient's anatomy and selecting the right valve for that patient's anatomy. And then also the implant technique. So when we choose TAVI for a patient, we're making one point in the decision tree. We heard surgical results, and surgery provides a wonderful solution for the right patient. But when we select TAVI, we also have to choose which valve. And there are now many valves. The field is getting more and more crowded, as Dr. Pendergrast explained to us. More valves, more data, and it's going to get more and more confusing. So we now have 5-year data to help us decide which valves, but both of the major platforms look pretty good at 5 years. So patient anatomy and some of the technique types of things that we can do to make valves last. So here's practical considerations to ensure best long-term outcomes. Quickly, 75-year-old patient, low risk, typical patient. But when I'm thinking about this patient, I'm thinking about probably a 2-valve in her lifetime. Severe aortic stenosis, high gradient, not a lot of calcium, but some calcium, small annulus, probably, 23 SAPIEN, a larger Evolut 26. Certainly could go either way. We only had both commercially available in the United States. She's low risk. Not a lot of features. She, could be a surgical candidate, but in the U.S., 75 she wanted TAVR. Not a lot of high risk features, so she's going to do well either way. And that gets us to the SMART trial. I'm going to just talk about the 2-year results that came out this year. These are the 2 valves that were in the SMART trial, more modern devices. And in the SMART trial, this patient is going to be exactly in this type of consideration, 23 versus 26. I'm quickly going to go through these. At 2 years, no difference. But hemodynamically, we could be making some very different choices for this patient. Am I going to leave her with patient prosthesis mismatch, that non-structural valve deterioration? Is she going to end up with a higher gradient? I have to be thinking of these things. Higher risk of thrombosis in this particular study, all of the things that I'm thinking of. Is her valve going to fail earlier? And I don't know the answer to this. This trial is going on for 5 years. So as I'm considering what am I going to do to optimize this patient, we ended up selecting an Evolut, and we're going to use the cusp overlap technique to use best practices. I'm going to skip through this slide. So using best practices, making sure that we follow the steps. We're using the cusp overlap technique, allowing the valve to be positioned properly, confirming depth in the non-coronary cusp, deploying to 80%, checking our depth, no more than 3 millimeters, using the markers on the new valve, if you have the new valve available, checking depth in 2 positions, and then slow final release, and then our final depth assessment of no more than 3 millimeters, and ending up with a well-positioned valve in a low gradient. And hopefully a valve that if it does fail, I'm set up for a second valve and coronary access and all the things that we need. So for this particular patient, based on her anatomy, selecting the valve that I and the team believed was a 2-valve solution for this particular patient's sinuses, coronaries, and all the things so that we could optimize the first valve and then prepare her for a second valve if this valve doesn't make it, as long as the patient makes it. And so with that, I thank you for your time. I do think that we're in a bit of a data-free zone. We have another 5 years till we're going to have the conclusions of the low-risk trials. Until then, we're going to continue to rely on what the data that comes out annually from the studies. I'm hopeful that we'll hear a 7-year result from PARTNER that gives us a little bit more insight. And we will have 6-year data from the Evolut low risk trial next year.
Okay, so thank you so much, and we would like to proceed to the next topic. And I think the time is up for all the program, but we try to see if we still have time for discussion after the last topic. That will be given by Dr. Yinmao Xin. His topic will be the minimalist TAVR, NTUH experience. And Dr. Yinmao Xin is the attending physician, Department of Internal Medicine of National Taiwan University Hospital. And he is specialized in the following areas, like hypertension, angina, coronary artery disease, heart failure, valvular heart disease, and the peripheral arterial disease. And he received his MD degree from National Taiwan University, and also he completed a PhD program in the Institute of Clinical Medicine, also National Taiwan University. So Dr. Lin, please.
Thank you, Professor Wei. A pleasure to share our experience of minimalist TAVR in NTUH. I'm trying to complete the lecture within 10 minutes because I know time is very limited. When talking about the TAVR, we should never forget for the contribution with Alan Gribier. Without him, I think we will we would stand here, gathered here together to talk about all kinds of transcatheter heart valve intervention. But he is not only the one give the birth to the TAVR. I think he dedicates his life to make it better. So in the 2017, Professor Yin and Dr. Lee, we all ever joined his workshop in Rouen. And at that session, I remember that he spend most of the time to promote that the TAVR become less and less invasive, let the general anesthesia to become the conscious sedation. At that time, 60% of them, their procedure would proceed with the conscious sedation, and would no more have to have T on demand and the closure device. And also, they at that time they still need ICU, but can early discharge patient within 1 to 3 days. And so back to our NTUH, this is the picture I shot 15 years ago in NTUH. That you can see that there's CoValve invention, the first one in Taiwan. And some of you can remember that the device looks like very original. Huh? And the surgical cut down and the general anesthesia, T support. I think most of the TAVR center in the whole world start from this setting. And then after 2 years, we switched our procedure from surgical cut down to closure device with 2 ProGlide. And we not have a ProStar till now, but so we use 2 ProGlide. And then 1 year later, we switched the general anesthesia to the local anesthesia, conscious sedation. So we ever compare our result from first 50 case with general anesthesia and data 50 case with local anesthesia, and data more than 100 case with local anesthesia. You can see that the procedure, such minimalist strategy can lower the patient with use contrast median, low procedure time, and reduce the ICU stay and hospital stay, and will not have more parallel leak. And also, you can see that when we reimburse hospital fee can be reduced also. And so also we modify our procedure some different, because like the nerve block, the patient can be done the procedure under awake status, that such like this very old, extremely old gentleman, 101 years old, and he can be receive the TAVR procedure under fully conscious status. And also we implement some stepwise pacing in some selected cases with very low risk of the conduction disturbance, and also can avoid the risk of the inserting a temporal pacemaker. So, and then we, after further 1 year practice, we found that there's some drawback of the 2 ProGlide closure device. You can always see in the aged population that patients, after we close the wound, they will have a stricture and also inefficient hemostasis. So we developed a new hybrid method with 1 ProGlide and 1 Angio-Seal to combine with suture-based and collagen-based procedure to stop the bleeding, and I found that it's more effective in the hemostasis and less artery contraction. So that's the retrospective registry. So we conduct a new randomized study in our center to compare this concept, and we finally proved that such new procedure can lower the risk of vascular complication and some modified vascular closure device value. So this is not only approved by the Taiwanese, but also by the Europeans. 1 month later, after the publication, another multi-center study like ACCESS-TAVI, the same design, same result, published in the European Heart Journal. And the population a little bit more than ours, but it's published in the European Heart Journal. Okay, so I think that it's a good way to close the wound, definitely. And also, we streamline our pre-TAVR evaluation. In the Western country, in Asia, in US and Europe, I think most of them, they need a long admission for the pre-TAVR evaluation and the TAVR itself. And in Asia or in Taiwan, most of the center using 2 admission to evaluate and to do the TAVR procedure. So we cooperate with our radiology. We want to integrate their image from the coronary tree to let the patient only have 1 admission to do such TAVR procedure. So we cooperate with our radiologist to have a new imaging protocol for TAVR CT, and anyone in our hospital can, for the AS patient, can arrange the pre-TAVR evaluation. And our radiology not only provide information for TAVR like the annulus, sinus, coronary high and the iliac artery, but also provide all the detail in the aortic valve calcing, coronary calcing, and the severity of coronary artery disease. So accounting for this information, we can start our protocol from 2015. February that we using the cardiac CT alone for the pre-TAVR evaluation. If the patient without have obstructive CT, the information get from the CT, and that the definition is that the main trunk or dominant branch have more than 50% stenosis. If the patient have such obstructive CAD, the patient can go direct for TAVR. And if the patient really have such information get from CT, we can do the invasive coronary angiogram concomitant with the TAVR, index TAVR procedure, and to decide whether to concomitant have PCI during the TAVR procedure. That's our result from 2015, 2022. We have 288 patients. You can appreciate that more than half a patient don't have to do the invasive coronary angiogram, can do the direct TAVR. And then only 44 patients, we found that you have a obstructive CAD from CT, and we do the invasive coronary angiogram during the TAVR procedure. And 30% of patients, finally, we found that really have a significant CAD. So we do the TAVR alone. And some of patients, 2/3 of patients, we have really have a obstructive CAD, and we 37 patients, we do the concomitant procedure. Most of them had low syntax goal, and most of them we do the PCI prior to TAVR. So you can see our result that the result is that the patient cardiac days rate is limited, ischemic-driven, limited, and interesting that there's no myocardial infarction for these patients in 1 year follow-up. Okay, so I think the next step will be to streamline the post-TAVR care. It's not easy to proceed. Right now, our routine is to one night in ICU and then another night in general ward. Most of the patient can discharge within 48 hours after the TAVR procedure. But we should appreciate that this post-TAVR, streamlined post-TAVR care we follow the rule from our pioneer in Vancouver, Dr. Ye Jian and Dr. John Webb. They have a 3M clinical pathway, and then not only they're dedicated to streamline the peri-procedure, but also to streamline the post-TAVR care, try to reduce overall length of stay in the hospital. So they have set up their procedure, clinical pathway, and criteria for discharge, and that we can follow. So they can finally have a next day discharge, or even a same day discharge for after TAVR. So for this goal, I think we ever revisited some center in Chicago to see how they work for the post-TAVR care, how they streamline their post-TAVR care. I have to say that, and we back to the Taiwan, we try to set up our clinical pathway for the patient, even a checklist to the post-TAVR care. I have to say that for me, to send the patient without ICU operation or without discharge next day is not very difficult for myself. But the most difficult one is to persuade and educate our colleague, and also to persuade and educate our patient to accept this concept and demonstrate that that is the right way for the patient. So this is our result from last December. We start our clinical pathway, try to let the patient without ICU and observation and the next day discharge. So in these 26, from last December to now, we have 62 TAVR patients. Most of them can be discharged within, that's our routine, even before this clinical pathway. And right now, we have 12 patients, 20% patients without ICU observation, and 6 of them can be discharged next day. And none of these 12 patients had unexpected ICU admission and readmission, and most of them received the balloon expandable valve. So I think in final conclusion that in NTH we, in the past decade, we provide great effort to streamline the TAVR procedure start from the peri-procedure practice, then pre-TAVR evaluation. Now, right now, we step into the post-TAVR care. So for myself, that minimalist is not just streamline the TAVR or peri-TAVR procedure. I think we base on the patient the best interest. That is optimization measures. And don't forget that right now, every hospital, we now facing the issue of budget limited or health insurance, also the shortage of the nursery manpower. So I think also the lecture from Dr. Ye Jian, I think the minimalist TAVR could effectively save more medical resource. Also, it's very cost effective. Thank you.
Thank you. I'm trying to look at the next session. That's the live demo. Is there any that case already prepared for the live demo? Yeah, I'm wondering if we still have a little bit time for discussion. Since I'm sorry for the time strain, because seems to be there's no time for us our panelists and our moderators to discuss. Also, Dr. Group is you're still on the line, yeah. So so is there any question or any discussion from our moderators and our panelists? Okay, that's the time.
Maybe first question for Dr. Lin from Taiwan University Hospital. Thank you so much, and congratulations for your initial outcome for your minister TAVR. I think if we talk about our NHI reimbursement, actually it is a very critical issue. But if, for your clinical practice, how about opinion of your patient? They want to stay in hospital more 1 or 3 days, or they like very much, or we can discharge next day. I think in the Asia country, it's very controversial. Yeah.
I think it's not easy to persuade patient to to let them discharge next day. I have to say that but always I would tell him that. Like no ICU observation, I think it's a little bit easy because because I always tell the patient that I think stay in the ICU is not a good way after TAVR, because the patient, if he lying for more than 12 hours, that very old elderly patient, sometimes they cannot sometimes they have delirium in the ICU, and you will agree that sleeping in the ICU is will not have a very good sleep quality because a lot of alarm. So I always tell them that we will setting up our general ward with a very intensive nursing system, and then they move to the without the ICU, they go to the general ward. They will have a very good sleep quality at that night, and also we will let them mobilize earlier. 4 to 6 hours after TAVR. I think it's really benefit for a patient. And next day discharge really challenging for the patient. So I still try to educate them that if everything is fine, we don't have to stay more days in the hospital. So that's why we are trying to enroll more and more patients.
Thank you very much. Thank you.
So are there any questions for Dr. Group and also Kandjoro? And Dr. Ye? Yeah. So Dr. Lin, yeah, okay.
Professor Ye, nice to see you on the screen. This is Dr. Lin from Tri-Service General Hospital in Taiwan. Thanks so much for your presentation. It's always wonderful as usual. I have one question for you. It's about the Bo-Yang procedure. Now we are trying to discuss more about the lifetime management of aortic stenosis. So What's your perspective about Bo-Yang procedure to enlarge the LT root and input a larger valve in surgical practice? Thank you so much.
Is a question for me?
Yes.
Okay, thank you. Thank you. Just quick answer. Yeah, I think the root enlargement is important, and there's all different method. Bo-Yang's a large way to enlarge root. So there's I think the one is a little bit misleading because this is a Bo-Yang's root enlargement actually is it's not really enlarged the annulus. So that's really important point. It's enlarged the root, but not the enlarged annulus. So therefore, yes, you can put a very large valve, but the one thing you need to keep in mind, this valve usually tilted, and tilted towards the left and the right commissurals, because your valve actually put in the supraannular. Second, you put a large valve, and the subvalvular, this actually is not enlarged. So your limitation actually is a subaortic valve area still not enlarged. So there's two things, two concerns with that technique. So I think it need to be cautioned because the large valve you put in not necessarily the annulus enlarged, and then in future you do the valve. Still, there's a limitation at the subannular area because the annulus is not enlarged. So I'm not so encouraged to perform this procedure for most of patients. And another thing is when your valve is tilted towards the left side, you probably have more chance to have a coronary obstruction down the road when you do the valve implantation. So that's why you tilt it towards the left and the right. It's not a great idea. You towards the non-coronary sinus area, that's probably is better because away from the coronary sinus. So that's why I think I want to say just precaution to do this low root enlargement with a traditional the annual enlargement is different. Sometimes I actually there was one case I did two enlargement. The one is on the right, left commissure, and another one in the right or non-coronary commissure. That's only two ways to enlarge the root. That's you potentially can prevent the future coronary obstruction during valve implantation, because you also enlarge the left side and right side. You also enlarge the non-sinus area. So that way to prevent this kind of only enlargement at the non-coronary side. So that's my comments about this technique.
Thank you so much, Dr. Ye. Well, I think it's about the time to move to the next session, because the Zhongshan Hospital, China, is already. I think they are already prepared for their live demonstration. So we have to move to the next session. Thank you. Thank you.
Thank you.
First live session. I'm Dr. Yin from Zhenxing General Hospital. Together with me is Dr. Lin Ziyuan, the superintendent of the National Defense Medical Center. And we also have distinguished panelists, Ivan from Singapore, and Chu Zheng-An, Dr. Li, Dr. Chu, Dr. Wu, another Dr. Li, and Dr. Lin from Taiwan. Okay, this case will be a K-clip case. K-clip is a novel annuloplastic device to treat severe tricuspid regurgitation. We are really honored and happy to have this live demonstration from Fudan Zhongshan, Shanghai Zhongshan Hospital, China. Today the imprinter should be Dr. Zhou Daxing and Dr. Pan Wenzhi from Professor Ge Jinpo's heart team. Can you hear me, Daxing? 周教授，
可以吧？
Professor Zhou, yeah.
进去了，进去。来，准备照影，准备照影，左前斜40度。哦，赶到我们这里了吗？对，已经转过来了。哦，好的。哦，已经转过来了。OK。
Can you hear me?
对，我们打个招呼。
张教授吗？
哦，殷院长。
哎，
殷院长好，不好意思，我不知道转到这里了。
Thank you. Can you show us the case and introduce the device to the audience?
Okay.
Thank you.
Thank you. Oh, sorry, I may come close to the screen. Okay. This is old. 院长，我就用中文吧。
好，
不知道有没有翻译，
OK，
因为我前面他们没有准备英文的东西。
OK。
是一个83岁的老年女性哈，这个重度的三尖瓣反流，有轻度的肺动脉高压。那10年前呢，因为二尖瓣的重度反流呢，这个做过一个外科的二尖瓣的瓣环的成型。当时呢也是因为房颤这个瓣环的扩大，他的房颤的病史呢不详，那至少呢有10年以上。高血压呢，这个也是10几年。曾经开过一个甲状腺肿瘤，以前有过脑梗，那目前呢后遗症的情况还可以。那目前呢这个临床的心功能的状况大概在2到3级，活动后呢，相对来说比较大的一个活动量呢是不耐受的。我们看到 TriScore 评分呢是6分。经胸的跟食道的超声呢，我们后面会介绍。EF 是好的 ，TAPS 呢也是正常的22毫米。FSA 当时没有测，三尖瓣反流是一个重度。那在前隔呢会有一点栓隙，大概在11个毫米。心功能的状况是 OK 的，但是肝还是有些淤血，所以胆红素还是偏高的。当然我们已经进行了一些调理，药物的调理。药物呢方面就是一个利尿剂的治疗，还有抗凝药的治疗。好，下一页。那这是他术前的一个心电图，我们可以看得到，这就是一个慢性的一个房颤，基本上房颤波跟房扑波呢都不明显了。那心脏我们也可以看得到是这个2个心房都很大的一个胸片的影子。往下一页走。这是术前的情况。二尖瓣呢，我们看到它有做过成型之后有少量的一个斑周漏。那现在的反流是个轻中度。三尖瓣呢是个这个反流，然后瓣叶有一定的栓隙。来源呢是在这个中央、前隔、后隔都有一些前后交界我们敢看也是我们在这个60摄像头可能要调一下。那个在前后交界，我们这个三维的前面可以看得到，在7、8点钟的方向是我们前后交界，其实前后交界也有一些这个反流。那当然麻醉状态下可能会不一样，我们等会儿请我们超声的这个孔德宏教授也给大家再看一看现在的实时的这个超声的图像。往下一页走。这是我们来源，这个人还是很广泛的，主要是中央前后交界、前隔、后隔都会有一些，因为后隔有栓隙，所以后隔的也比较长。 隔瓣呢是比较冗长的。往下一页走，超声等一会儿我们孔德宏教授会介绍。下一页，对，术前呢我们做了一个 CT 的一个分析，全实像的一个分析。3节半环的周长呢，是扩大的，但不是说特别的大。周长是141毫米，面积呢大概在15这个平方厘米。右冠到这个3节半环的距离呢，在收缩期的时候呢，都是这个大于3个毫米的。那舒张期呢，有部分的冠脉距离大概在2.8，在后半环的中点的位置。所以整体来说是符合我们的一个术前的一个冠脉的一个安全距离还是够的。往下一页走。那我们从这个后隔交界到冠状静脉窦开口，我们这边地方呢，我们也测了一下距离以及整个后瓣的长度。我们模拟了一下这个半环缩环的一个尺寸，大概我们从覆盖前后交界到后隔交界呢，大概需要2个夹子，2个夹子呢，第一个夹子在后隔的位置，它可能会有这个地方会比较短，我们可能先放一个相对小一点的夹子。那在前后交界呢，我们预计可能会放一个略大1号的夹子，当然我们还得看它冠脉的情况。所以整体来说呢，是这个人的半环呢，我们不管是从他的机制，还是从这个他的解剖的状况，我们可能还是需要2个夹子才能够对这个病人呢有一定的缩环的效果。当然这个人有隔瓣的栓系，所以我们更多的是通过减少它的反流，然后让心室呢进行一个重塑，那栓系呢会减少。那这个人因为有比较严重的栓系，而且呢会有这个 gap 也比较大，反流也比较散，所以又从他的机制来看，应该是个防性的一个病人，所以我们整体策略还是先缩环。那后续呢，我们看他的栓系的改善情况，以及反流的改善情况，以及心功能的状况的变化，我们再看后续需不需要我们再进一步进行原对原的这个处理。当然我们第一步目前没有这个条件，他没有这个解剖条件进行这个第二的一个治疗。所以在中国，尤其在这个我们大陆呢，会有很多这样的病人，就是房产几十年他都没有很好的一个治疗，那其实整个心房都没有什么功能，然后房性的一个反流的程度也比较明显，2、3节瓣都会存在有合并这样的状况那可能拖到心衰的程度的时候呢，那只能是手术来治疗。所以介入手术对于我们这类的病人呢，会有很好的一个帮助。尤其有过开胸手术病史的这类病人往下一页。所以我们根据这个国家药监局呢，我们对这类手术病人的一个术前的评估要求呢，这个病人还是合适的。我们T2的等级、3节半环的这个扩张程度，以及这个瓣叶的形态，还有右心室的一些功能、左右心的功能来说，以及肺动脉压力的情况呢，我们觉得这个病人解剖上还是适合我们先给他进行一个缩环的一个处理。右冠呢也是在安全范围内的。下一页。我病史的情况资料汇报就是这么多。殷院长。
Okay. Thank you for the case presentation. This is a 83-year-old lady, has history of mitral valve repair, but developed tricuspid regurgitation, severe tricuspid regurgitation due to atrial regurgitation. The patient also have pulmonary hypertension of 60 millimeter mercury and chronic AF. The LV function was preserved. However, the patient still have functional 3 symptoms. As you can see from the echo, the tricuspid regurgitation was really severe. And the patient is currently on diuretic therapy, but she is refractory to the therapy. So I would like to ask the panelists, what's your opinion? In Taiwan, we only have TTIA. We don't have any annuloplastic device. So this is something new to us. Maybe Dr. Li Qingwei, would you please to comment on this? Will you go direct to the TTIA, or do you have any idea about the K-clip? Because you visit China very frequent.
Yes, thanks. I think the imaging totally analysis is quite relevant. And because I have a very limited knowledge about the K-clip, so I have one question about when we do the TTIA procedure at the septal anterior region, we will markedly shrinkage the annulus size. We will make the annulus cause some annuloplasty effect. So how about the K-clip? When we clip in the posterior and the septal, and will it reduce the gap between the septal anterior, and we can maybe if there is a residual TR, regardless of the cost, and then we can do the clip procedure for the septal anterior.
张教授，李教授在问说，如果你做了 annuloplasty K-clip 的 annuloplasty 以后，什么样的情况？还是说你们有多少的病人会同时需要做 clipping？ TTIA I mean， 就是3斤半甲。
对，圆对圆的这个修复
是。
现在因为TTIA 呢在大陆呢并没有上市，那我们更多还是这个临床研究，所以这类的病人呢，我们两者都做的病人呢不是那么多，但是从中国的病人人群来看呢，他的一个三尖瓣反流的情况来看呢，我觉得我们有相当一部分的病人可能需要。比如讲，我们入组的K-clip的病人呢，大概目前在中国一共入了有200例，就包括这个肺母，也包括确诊的临床。那这200例病人呢，我们能维持在中度的病人，可能中度以内的病人1年的时候呢，大概在80%左右，还有20%的病人其实还是有中度以上的反流。那他们有改善，但是依然有比较多的反流，有可能从6个加到4个加到3个加。那这类病人我们看呢，大部分也是这个房性的病人，以及有一些左心瓣膜术后的病人，这部分病人需要的。所以我觉得这个比例大概我们从入选的病人来看，大概在1/4左右1/5这样，还是需要我们两者结合的。因为中国的病人病史拖得太久了，瓣环太大。好，医院的。
Thank you. Because of the delay treatment, so about one fourth of the patient may need combination. That means to do annuloplasty to reduce the ring size and better approximation of the leaflet than clipping of the leaflet with TTIA in combination. So I think that might be the similar situation in Taiwan. So we'll try multiple clipping for tricuspid and instead of annuloplasty.
Yeah.
Now we usually in that kind of patient with such severe tricuspid regurgitation, we just go direct to Lux valve implantation in Taiwan. We have already done 5 cases up to now. What's your comment from TTVR and the combination therapy of annuloplasty and TTIA? 张教授，就是说您对这个置换跟这个修补的这个概念跟选择。
刚刚院长也讲得很好，这个病人呢，我觉得另外一个适合的病人，适合的治疗方法呢，就是我们的置换，我们的 Lux 的置换在中山医院呢也是目前也是在常规做啊。那我们怎么来选择你不太适合 TTIA 的病人，你是 选择我们复杂的半环成型加 TTR 呢，还是选择 Lux 瓣膜的置换呢？这两者对于我们病人怎么选呢？当然我们从 Lux 的我们中心大概做了有将近70-80例的 Lux 了，从早期的临床到现在的 RCT 的对照。那有一些病人，比如讲相对年轻的病人或者不耐受抗凝的病人，可能对 Lux 的瓣膜的耐受度或者它的耐久性的考虑，我们可能并不是作为首选。那当然开呢还有一些瓣环太大的，但现在 Lux 呢在设计大瓣环的这个瓣膜，有一些瓣环太大的，超过55-60的瓣环直径，那可能也不太适合。所以我觉得几个方面，从临床来看，他如果不耐受抗凝，因为我们发现 Lux 的病人呢，术后的血小板会下降，然后有一些凝血需要高凝，一直要抗凝的。那我们3尖瓣的病人很大的一个死亡原因就是在抗凝出血方面。我们不管在 Lux 随访还是在开的随访，他1半以上的病人都死于出血。那所以我们对于这类病人，临床上对于他需要高强度抗凝的患者，我们可能就不，或者血小板很低的病人，我们就不会选 Lux。第二个呢，我们从这个心脏功能的情况来看，比如讲有一些病人TAPS 太低了 ，FSC 太低了，右心呢很大很薄弱的病人，那我们也觉得一下子突然关闭，他在微手术期的一个过渡状况呢，他不是太能耐受。那这种病人呢，我跟陆芳林教授呢也探讨过，我们其实做过2例这样的病人是什么样呢？很大，右心功能很差。我们先做了开的缩环，环小了以后，我们再做了 Lux。那比如讲，他可能没有好的条件，半夜的条件去做 TTR， 那开加 Lux 的一个治疗，对于他心功能微手期的一个过渡，这2例病人的情况到现在也很好，就是说你可以作为他最早期心功能不耐受的情况，我们先用开 clip 做一个过渡，让他心功能改善一些，他能够耐受。第二个呢，把它环缩小了，便于我们选器械跟操作。那第3个就是看这个解剖的条件，如果这个病人并不是这个不是缩环，比如讲冠脉也有一些问题，瓣环呢它的机制也不是以瓣环扩大为主的，那可能会有一些左心功能的问题，或者是换过瓣的病人，高压的一些病人，可能 Lux 瓣膜也更适合。它的机制上来看，解剖上来看，所以从这3点来看，我们来这样来区分我们的选择。好，谢谢。
Okay, thank you. For those patients with high risk of bleeding and younger patient, consider that the long-term durability of the tricuspid valve replacement. So this kind of patient should be avoid to receive a TTVR procedure. So I think for those with advanced or severe right heart failure, putting a tricuspid valve replacement valve may acute decompensate the right heart function. So in this kind of patient, Professor Zhang recommend to use a combination therapy with a K-clip for annuloplasty and in combination with TTR. So any other comments from the panelists or Dr. Lin? No, if not, Professor Zhang, would you please proceed the procedure? And before that, can you introduce the device, I mean the K-clip device, because we are not familiar with this device.
OK， 我们有那个吗？小姚，我们有器械吗？他们要想展示一下我们的器械，我们的 device 给他看一看。术前有新的吗？好。院长，我看看我们如果有多的器械，我们给大家看一下那个样子。
谢谢。
然后我们就切到我们的DSA 的图像跟超声的图像给大家看一看。
好。
那个我们哪一个器械好？这样，因为呢，我们抓紧时间，这样
你先做 procedure 也可以，没有问题。
对，我们看看 procedure 的进度。
Yeah。OK。Please。
今天呢，我们的这个团队呢有这个超声的孔德宏教授，因为潘翠珍教授呢有其他的会议啊，那孔德宏教授跟栾丽娜教授呢来做我们的一个超声的引导。我们这样，那个孔老师，我们可不可以你先那个把前面的超声的图像给大家简单做一个介绍，包括我们的半环的测量，以及我们反流数的一个位置的判断，以及它的这个我们如何来引导我们的一个 procedure 的一个步骤，简单给大家讲一讲。
好的，谢谢小陈，谢谢尊敬的大会主席，各位专家，大家好。我们这边心超的这个特点呢，主要是就是心房这个病人的心房扩张比较明显，然后三尖瓣反流，我们还是评估下来是一个重度的三尖瓣反流，然后主要是考虑是心房增大，然后瓣环扩张导致的。然后我们这个反流的来源呢，从3维上还有2维上，我们也留了一些图。然后呢，我们可以看一下它的3维的反流的方向。主要特点呢，就是来源还是比较广的这个反流口。我们可以看到主要来自于后隔交界，那么前后交界和前隔交界也有不少的反流，所以我们觉得这个反流还是比较多的。然后瓣环的情况呢，我们3维上显示这个瓣环的情况是这个样子的，这是我们3维的瓣环的形态。瓣环的周长是3维测量是14厘米，瓣环的这个隔侧径是38，然后最长的径是47。其他的我们超声的特点暂时是这些，谢谢。
好的，因为呢，我拿了一个新的器械哈，这个
不
知道大家能不能看到？我们的这个外鞘呢，我们是有一个经过颈总静脉下去的一个外鞘。那我们把这个摄像头对着我们的这个这一个系统一个鞘管，对，大家能看得到这个鞘管吗？
So it's a transjugular vein approach.
Yes. 18 French.
18 French, yeah.
Yes. 然后过来，这样过来。OK。这是我们的一个操作的一个器械的系统，一个 device。这个 device 呢，包括我们的前面的夹子，我们可以打开它，我们可以打开这个夹子。你扶着，给他看。我们打开这个夹子，我们这个夹子可以最大打开到接近180度，我们大概在160度左右啊，160度左右。
可以对焦到那个夹子。
然后我们对焦能够对焦它，放大对焦这里，对，很好，可以这样啊，白的布 OK。然后我们可以打开之后呢，我们可以看得到这个前端有
焦点
螺丝，
好像还是模糊的，
模糊的，你看看能不能聚焦清楚一点，调整一下聚焦，可以吗？
还是不够清楚，
不清楚，还是模糊，对，模糊，再调整。
OK， 现在好多了。
好，那我们的这个夹壁上呢有这个各有一排呢有5个倒刺，这个倒刺呢是抓住瓣环的。那我们的这个宽度呢，夹子的宽度在3到4个毫米，那跟我们人类瓣环的这个3尖瓣环的这个宽度呢是差不多的。中间的这个螺丝呢，我们大概有3圈， 3圈，这个长度呢，我们这个长度进去的这个长度也是3、4个毫米。我们整个半环的这个深度到我们的瓣膜底部，到我们的心外膜呢，这个深度也差不多，所以这个是跟我们的心脏起搏器的电极里的那个它的样子很像，只不过说它是刚性的啊，这个就比较坚韧一些。扎进去之后呢，我们把这个半环给拎起来，然后两边的夹子夹上，我们再收紧这个系统。那我们这个系统上呢，看看后面啊，这里对焦这个后面的这个功能区，这是我们的这个系统的功能区。这个弯呢，第一个弯清楚吗？
可以
，OK，可以啊。这个蓝色的是我们的控弯，就是我们可以把对小鞘进行一个打弯。这个弯呢，我们可以打到超过90度啊，我们可以看到可以控很大很大的弯，我们可以控到反的弯。所以我们这个系统呢，我们也正在做筋骨的一个改进。所以我们这个对于我们这个系统而言，我们可以做到很大的一个弯。所以你从筋骨上去呢也是没问题的。然后这个呢就是我们一个跟 Match Clip 一样有一个 telescope， 我们就等于可以让夹子呢在不动系统的情况下，它有一个大概有2公分的一个前后的一个走行一个距离。那后面呢就是我们的这个开夹关夹的一个系统以及释放的系统啊，这是我们把它关上的一个过程。好，为了我们不浪费呢，所以我就不展示这个释放的过程了，我们就这个夹子还是可以用的，给大家就看到这么多。好的，不知道还有什么问题，谢谢。
So there is a screw in the mid of the device and the 2 grasper from either side. The screw is for fixation and the localization, and then grasp the tissue by the graspers. So please show us the procedure. 张教授可以做给大家看一下。
好的，那我们那个。这已经夹住了吗？好的，那个，这样我们先那个 DSI 的图放一放，那个文涛，帮忙在外面放一放 DSI 图。我们经过这个颈静脉呢，外面能看得到吗？往第一幅从前面开始放，从前面开始放。对，我们前面会测一个这个压力，包括肺动脉压力啊、右心右房的一个压力、上下腔的一个压力，然后我们会做一个右冠的冠脉造影。冠脉造影的时候呢，我们一般来说都会做一个 IVUS 的一个检测，因为在我们缩缓的过程中呢，会有一些右冠的牵拉，这个牵拉呢，到底是它变狭窄了还是变形？管腔面积是变小了还是不变，所以我们会用 IVUS 呢在术前术后做一个区别。第二个呢，我们可以如果这个螺丝呢损伤到了冠脉的血管壁，会有一些血肿或者是一些痉挛扭曲，那所以我们在术前呢会进行一个 IVUS 的一个检测。那在术后呢，我们在夹子攻的时候会进行一个比较。那下面我们请周游医生给大家看一看这个IVUS 的情况。那个探头对着 IVUS， 我们走一遍好了。文涛能不能把那个 IVUS 走一走？
放一下 IVUS。
文涛，那个朱文涛。叫一下朱文涛那个 IVUS 的图像，
放一下 IVUS，
放一下 IVUS，
先拖到最左边再开始放。好，
位置怎么样？
这个各位主任，我们可以看到这个在心血管内超声的这个图像上呢，可以看到这个病人还有一个比较弥漫的病变，然后有一个这个都是纤维脂质斑块，但是呢，这个血管的残余直径或者是最小管腔面积呢，对这个病人来说还是够用的，所以呢。目前我们主要是这个还是要观察术中对这个血管有没有进一步的影响。这个病人本身的这个冠脉呢，暂时是不需要一个介入治疗。但是术后呢，这个患者这个在降脂或者其他方面可能还需要继续一个强化药物治疗。快一点。
你这个位置对吗？
往右。
你把它。
对，我们可以看到这个血管内是一个弥漫性的这个。斑块，但是呢，这个对它的这个最小管腔面积进行测量，这个面积呢最小呢也有3.98平方毫米，这个对患者来说，都是这个可以供给它正常这个一个功能。再往右抽。
对，你再调一下。它那个有根导丝在那儿是会说。
一直戳到头就行。好，就是这样。
你觉得有点偏吗？你这样吗？
好。
Okay, the IVUS seems to be okay.
好的，那我们那个下一步的那个 DSA 给大家看看，就是超声吧。孔孔把前面我们就是导丝呢会送到下腔静脉，然后我们就顺着这根佳音导丝呢把这个系统送下去，送到这个超声的图放过去了嘛？对，往前，对，往前。对，把这个 procedure 的过程给大家看一看。OK。对 ，OK。我们一般这个鞘管呢会进到心右房的中下部，然后呢我们进行一个控弯，因为它在右房侧啊，房侧它离半环还是远，所以我们控一个弯呢，让它。这个我们从人躺过去控弯之后呢，它就指向我们的3尖半环，尤其就正对着我们的后半。所以我们当时设计的时候呢，从颈下去呢，就会对着我们后半3尖半环的后半，因为上面是前半，这个后方呢是隔半，那它的下方呢是3尖半，是后半啊。那在后隔的位置呢，这边是冠状静脉窦，而在前后下面呢。在它的外侧呢是下腔，所以我们一般来说呢，我们的策略会是因为隔半呢，我们的空间很小，它比较固定，我们夹到哪里就是哪里，所以我们要求呢就是第一个夹子呢，螺丝打在后半上，但是它的夹壁张开的时候呢，会有一部分会要跨过这个后隔交界的这个 commissure 的位置，那我们把它夹起来呢，就不会导致我们的 commissure 会被拉大。第二个呢，这个就等于在这里会先打一个铆钉，让这个半环呢先固定在这儿。当然，它对整个半环的缩小呢不是那么明显。那我们再在它的外侧，在后跟前的位置呢，这个位置再打一个相对大的夹子，这两个等于连续的去缩，从前后交界一直缩到后隔交界。那这样的话，对我们缩环的效果就会比较好，而且呢这个也能够减少我们的隔侧镜跟周长。所以这是我们预先的一个策略。那还有我们也要看它的这个反流数的情况，比如讲它在我们后隔的位置会比较多，那所以我们也要尽量兼顾到这个位置。当然它因为还有一些栓系，所以我们看看它心脏如果能缩小，那栓系也会减轻。还有就是我们这个前隔的位置呢，我们等后隔做好了之后呢，我们再来测量它能。它的一个长度，比如讲我要从后半一直要跨过前后交界的位置，再放一个大一点的夹子，可能会效果更好一些。那这是我们的过程啊。过程呢，我们进入这个切面之后呢，我们先把夹子呢会在3维下通过控弯到达我们的一个目标区。目标区就在我们这个后半偏后的位置，这就是我们螺丝要走的位置。那螺丝要走的位置的时候，我们就会打一个 multi-view 的一个超声的切面。那调整好了这个我们的所有的角度， 我们都已经对齐了之后呢，我们就会在右上角的图像上看到一个铰连区，铰连区的左边呢是半叶，是半根部，那右边呢是冠脉，所以我们在这个切面下呢，我们会看到中间会有一个平台的地方，这个地方就是半环。那我们在这个半环的地方呢，我们超声引导好，我们标记，我们就把这个螺丝给它拧进去，拧到头。好，这个过程 OK， 我们下一个。对对，好，对，我们到了之后呢，我们就会在 DSA 下放一放那个内容。我们也会看看在三维下，我们在有 CT 模拟的那个角度，就是我们左前斜，这是我们3间半环的短轴。这个短轴情况下呢，我们看看夹子的位置在哪个位置。好，这个时候透视一下好了，我们透视一下。我们在后三叉的位置啊，这个跟我们 CT 上分析的位置接近啊。裁板在我们脚下啊，移一下床那个内容，把那边暴露，整个右冠暴露出来。图像不是那么清楚啊，我不知道是什么原因。好，左前斜再打大一点。我们的刚刚的那个短轴位是多少角度？小姚，那个 CT 测出来是短轴的切面是左前斜多少度？3度，但我们的夹子你看不正啊，你看夹子位置不对。
对，现在我们也在考虑夹子刚才在关的那个推断的过程中，可能有点推测变了。
有点变了，好的。对，我们的这个然后夹子打开之后，我们就把夹子下去的过程中呢，有可能 orientation 它会转，对吧？确实变了，对吧？所以我就把夹子打开我们重新调整我们的那个 orientation。这个呢跟做对啊，稳一下这个螺丝，对，很好，拧住它 OK。我们超声的图像啊，不是，你把那个超声的图像切上去啊，主要看超声。那我们对，不用 DSA 不太要看 OK。那我们对，那我们这个时候呢我们来看看它的那个夹子的方向啊，你把这个螺丝再回到那个转过来，我看看螺丝，回到 Multi View， 我先确认一下我们的螺丝的深度是不是对，我把夹子慢慢撤回来啊。
那个很好。
再往回走啊，不，这里要扶着啊，螺丝一定要拧着顶着。
我就往里再勾一点，现在前
好，不会，没关系。
张教授，这个是
调整一下，
直接这样子很直觉的就下去，有没有什么技巧要操作的？
对，其实我们往下推的时候呢，还是会有一些我们的小的技巧，就是你直接推的时候呢，它会有一些弯度啊，它并不是完全直的，所以我们刚开始下去的时候呢，从很高的位置下去的时候呢，我们得要拉一拉我们的这根铆钉，拉住它呢，这样的话它会顺着它走。那到了我们这个夹子快到半环位置的时候呢，我们希望它能够那个夹臂呢尽量往半环伸得远一点呢，我们就会把这个螺丝在这个位置下，我们又会往前推一推的目的就是把半环推远一点，然后我们的夹臂呢往这个半环更靠的多一些，然后我们靠到半环了，我们超声跟 DSA 都能够看到这个夹臂呢已经贴着半环的时候呢，我们这个时候再把螺丝提起来，提紧，一定要提到头。那我们在收夹子的过程中呢，就跟我们做match clip 一样，就是你在往上提的过程中，甚至有的时候要调整位置的时候呢，它也会有一些转动 ，orientation 会转，尤其我们在用这个 telescope 的时候，它也会转动。 所以我们始终都要保持我们的这个夹臂呢，两个夹臂都在半环上，这样才能让我们的夹的效果更好。OK，
所以它的夹面夹的方向应该是垂直还是平行半环？
平行的。
平行嘛，
就是半环是这样，我们的夹子就要这样。
是。
好，这是我们的这个multi-view 的几个切面，我们可以看得到，我们拉一拉这个螺丝，看看位置。好，这个时候呢，我们可以冒一点造影剂，看看冠脉会不会有影响啊？我把半环提起来的时候，因为我们的这个半环呢，因为我们的冠脉呢，一般在跟半环比呢，它在半环的外侧，它也是偏房侧的。如果我们的螺丝弓的位置呢，你靠近心房了，那这个冠脉影响就会比较大。当你来我提的时候，有没有造影啊？
可以把造影放到主荧幕。
好，把那个造影的屏幕看到吗？刚刚。
谢谢，看到了。
来，我们来造个影，来。对吧？那这个地方好像有点痉挛啊。刚刚呢，前面呢我们看了一眼，它是有点痉挛，因为你刺激我们冠脉周边的位置呢，它会有一些这个，尤其牵拉的过程中这一段的冠脉，我们会有一些痉挛，所以我们有一个 IVUS 做一个基线，然后我们术中万一遇到什么情况，我们有一个比较啊。那我们后面会用一些痉挛的药，这个在我们做3尖瓣的过程中呢，还是比较常见的几个冠脉的一个改变，一个是痉挛、扭曲、血肿啊，这几个会这样。当然，我们如果看到它扭曲的很厉害，那肯定是你这个要不冠脉太近了，要不你的螺丝呢这个离冠脉很近啊，我们就要往心室去一点点，我们往内侧要去一点点，所以这是我们需要去评估的一个重要的一个步骤啊。好，那螺丝我们看看它是不是，我再加固一下，出来一点啊，没问题啊，对吧？好，可以了。OK， 那我来调 orientation， 好吧？3维，再回到3维。那我们因为冠脉呢，为了更清楚呢，有时候为了保护呢，会有放一根导丝。那这个时候在我们的超声上呢，就会看到有一条白白亮亮的。我们早期也吃过一些亏，其实这个很多时候是这根导丝的关系，所以它的半环呢是在这根导丝的内侧一点点。那我们需要去在3维下呢，我们去转这个方向啊。那我感觉是。我们下方的夹子臂呢是偏房侧了，对不对？所以我得要逆转一点，我把它转过去。OK， 好，这样来看，对吧？这反了，再竖起来一点。对，好，是不是过了一点啊？过了一点，上缘呢又偏房了啊，我得要再顺时针回来一点点。OK， 好，把这个屏幕拉到 DSI 拉到屏幕正中间。好，这个时候看你在我看看夹子能不能再高一点点啊。telescope 已经用到头了，对吧？来稳一下夹子，推住它，稳住它。对，我会往回撤一点夹子，这样呢，对于下方的半环更容易看。OK， 这个地方是半环还是里面的那个是半环？我感觉是里面的那个，是吧？好，你再找一下前面。其实超声上要辨别半环呢，还是相对来说跟 TEER 来说呢，我觉得还是相对容易一些。当然也有一些病人呢，他的瓣环呢，因为这个心房呢房颤太多年了，瓣环也会纤维化。瓣环的纤维化也是这个房性的病人，三尖瓣瓣环扩张的一个重要的一个机制。那瓣环纤维化以后呢，它就没有那个很明显的一个凸起，那就是它也一样扩张，也一样变平坦。所以有的时候这种病人呢，你就不像我们动物实验看到正常的这种动物上的瓣环那么明显。过了一点啊，我觉得，对，扶的啊，对，我转过来一点，OK， 我觉得这样，就刚刚挺好，对吧？我觉得这差不多，是吧？我再看一下 DSI 图像，这比较正了，是吧？好，那我慢慢往下走，这里要提着它。对，你给到那个 NPR， 我就慢慢往下走。这个时候呢，要提紧一点螺丝，这样螺丝它就不会打弯。那这个时候我们下去的时候呢，希望两个鞘一起走啊，一起走，同步，这样它的轴向才不会变。那个孔老师，我就等你的那个图像，我再走，好吧？对。站反了，对，很好。
小春教授，您可不可以先在这边专心做一下？
对，我们先继续做。
对，
你们切到。
我们先去切到另外一个手术室啊，谢谢。
好，谢谢。
请切到振兴的导管室。那个导播。OK。You're on the air, Professor Cao.
Yes.
And Dr. Lin. Yeah, you're on
the
air.
Professor Yin, can you hear us?
Good morning. Yeah, we can hear you very clear. So would you please present the case and tell us what you have done?
Okay, before the presentation, I would like to introduce our team. I'm Dr. Dianping Cao from Jianxin General Hospital. This is Dr. Lin Huanqiu, and our chief technician, Jin Xuan Jialin. Okay, so Dr. Lin will present the case, please.
Thank you.
And today our image physician is Dr. Junting and Liu Junting.
Could you please show us the slide? Yes. Okay, so today our patient is a 74 years old lady who suffered from dyspnea insertion and chest tightness for several months. Her height is around 152 centimeters, and her weight is around 65 kilograms. She has been diagnosed with severe aortic stenosis, which area is only 0.7 centimeters square, and also moderate aortic regurgitation with functional class 2 heart failure symptoms. Her comorbidity including rheumatic heart disease history, and underwent the mitral valve replacement with a mechanical valve, which is a 33 millimeter valve, and also tricuspid repair with the Vega method. She only has a mild myocardial bridge over the left anterior descending coronary artery. Her STS score is 6.6, and her kidney function was normal. So next slide, please. Now you can see her transthoracic echo. This patient has a severe aortic stenosis with moderate calcification. They only mild to moderate aortic regurgitation and with preserved aortic ejection fraction. The mean gradient of the transaortic valve pressure gradient is 41 millimeter mercury, and the peak gradient is 68. Next, please. So this is her multi-slide CT analysis. As you can see, this is a small annulus patient, which area is only 332 millimeters square. And the parameter is 66, and the diameter is 20.6.
Sinus valve diameter is in the normal range, which is around 29 to 30 millimeter. And also the diameter of the STJ is a borderline case, which is around 25/27. Next. So we put two valves for simulation. The first one will be a 26 millimeter Evolut FX. Her coronary height is 10 millimeter for the left main coronary artery and 12 millimeter for the right coronary artery. The membranous acceptance, according to the Midas method, is around 2 and is around 4 millimeter for the coronal method. So if we use the 26 millimeter Evolut FX for simulation, the VTC for the left main coronary artery will be 5.4. And the VTSTJ will be 1.3. And for the right coronary artery, the VTC will be 5.5 and 1.1 for the VTSTJ. So next, please. So this is 23 for simulation, 23 Evolut FX. As you can see, the VTSTJ will increase a little bit, which is around 2.8 for the left main coronary artery, and VTSTJ for the right side will be 2.1. Next, please. Next. So because this patient, if we use the patient prosthesis mismatch evaluation, the SAPIEN 3 will have a borderline moderate patient prosthesis mismatch for this patient. So according to this calculation, we like to use the Evolut FX system for this patient. So next, please. The calcium is around only moderate calcification, around 330 millimeters square. And next, please. The peripheral access is a borderline size for the right common iliac artery, which is around 5.5 in diameter, but there was no significant calcification or tortuosity. Next. So our plan to do, we would like to access the main access will be the right common femoral artery, and the temporal pacing will be common femoral vein for the left side. The supporting wire will be the Safari wire, and we will use the cerebral and body protection device for this patient. Because of the borderline size, the parameter is 66, so we would like to ask every expert to give us some advice about the valve selection between 23 FX or 26. Because this patient was 74 years old, she may has chance to encounter the second TAVR procedure. So we have to consider the VTSTJ for this patient in the future. Thank you.
So this is very interesting case. Can we ask Dr. Liu Junting to explain the TE finding?
Okay. Can you see the echo image on the screen?
Yes, please.
Okay. This is the patient's lung access view before the procedure. You can see it's a thickened aortic valve with aortic stenosis and mild AR. And here is the X-plan to show that the small opening of the aortic valve in the short axis plane. And after we implantation the Evolut 26 valve, you can see that the valve thing.
Are you report the result?
Okay. Okay. Because time is limited, so we do the procedure, have done the procedure. But we can discuss because this is a case very interesting for discuss because this is a very small annual line between the 23 and 26. And if as we know, the superannulus self-expanding valve have the advantage of improved hemodynamic, like EOA is bigger and hemodynamic is better, pressure gradient is better, and better PPM. So if we choose 26, the VT STJ, just like Dr. Lin's slides show the very small VT STJ, it could be for the if future redo TAVR, that would be a problem of sinus sequestration. But we can use different modification. That's our consideration. And if we use the 23, that would be a little bit small. I want to ask all the experts' opinion about this point.
Ivan, can you hear me?
Yes.
Ivan.
Oh.
Hey, hi.
Hi. Can you comment on this patient? This is a typical SMART trial case with a borderline 23 or 26 FX. What's your opinion?
I guess, this is definitely a borderline case between 23, 26. You mentioned about this patient is rheumatic. The LVOT is a little bit bigger, if I'm not wrong. I think your LVOT measurement is a little bit bigger than the annulus. So that's also my concentration. So overall, I feel like there's also a concern about, the short membranous septum and the short VTJ. But I think in this case, I probably will go with 26 F-LUT FX. In my experience, a patient with rheumatic, they don't have that much calcium, so I need a little bit more oversizing. Although, of course, when you choose 26, that's the concern. Short membranous septum, increased risk of pacemaker, and also the short STJ. But I think overall, 26 will still be a reasonable option here.
Yeah, because the distance between the aortic and mitral was short. So what's your implantation test to go? To go? I mean, Dr. Any comments from the panelists on how to control the implantation test in such a short distance? Dr. Cao?
Yes. So because the mitral prosthesis, the distance of aortic annulus to the mitral prosthesis is about 3 to 4 millimeters. So it's also fit our plan. We plan to implant the valve 3 millimeter. So I think the distance is okay for us.
Yeah, in old days, the optimal implantation days was considered to be 4 to 6. So during that period of time, I remember a case planning. They stopped the procedure because the distance was less than 4. So I think nowadays the implantation days was considered to be 3 or less than 3. So I think this case is still doable. What's the comment, Dr. Lee?
Yes, even though we know the result, but I just have a quick question about if we have to choose the bioexpandable devices with Sapien devices, would like to prefer to underfill with 23 or you want to overfill or with a 20 millimeter Sapien valve? How to decide how to, in borderline case, you prefer to underfill or the overfill?
Yeah, Dr. Cao.
Yeah, because this is a small annulite. So based on the SMART trial, we prefer to use self-expanding valve. But if we choose balloon expandable valve, I would consider to use 23 underfill. Yeah.
Okay. Then please show us the result.
So this is play the. Firstly, we place the Sentinel device. We place the Sentinel device for almost all of our TAVR case. Next one. And this is closed valve. Next one. Finally, we choose 26 millimeter. Because if we choose 23, the oversize is only 8%, and the calcium is quite less. The calcium is not much calcification. Therefore, we choose 26. That for the future redo TAVR, the neo skirt will be very high, and the VT STJ is very short. But at that circumstances, we probably can use leaflet modification and to solve the problem. And this is a 26 millimeter valve. Next one. So this cross the valve. And then we start deploying. The whole procedure of the deployment is quite stable. the valve stay quite stable. We only use a control pacing, 120 ppm. And the interaction of the evolute valve with the mechanical processes is okay. It's not so much interaction. So this is angiography before the deployment. Next one. So this is complete deployment. Next one.
Next one.
So this the final. Then can Dr. Liu show the result of valve deployment, the before BAV, before post-dilatation?
Okay.
Yeah, you can show the result now.
Okay. So I apologize for a mistake. So this is a picture after we deploy the Evolute 26. You can see that the explant of the valve, you can see the valve is not very round shape. It's a little bit, the maximum is about 1.6 centimeter and the short diameter is about 1.2. So we decide to post-dilate the valve. And here is the procedure of the dilatation. The valve is well expanded during the dilatation. And after the dilatation, you can see that it's obviously improved of the EOA of the Evolute valve. The maximum diameter is 1.8 and the short diameter is about 1.5. It's not only the shape become more circular, but also the diameter is improved. And that's the results. There is no paravalvular leak at the check at transgastric view. And the pressure gradient is good as well. And that's about the patient. Thank you.
Okay, thank you, Dr. Liu. So the invasive hemodynamic show the pressure gradient is 3. Can you show the monitor? 就拿出来好了来。
Which balloon did you use? True flow or
nucleus?
Nucleus
20 millimeter.
20 millimeter.
Don't you worry about the interaction between the balloon and the mitral device?
Yeah, I think. Can you show the image of post-dilatation? The final image. Because the implantation depth is about 3 to 4, and I always worry about the pop of the valve during the post-dilatation. So I always push a little bit during the balloon dilatation. And the interaction of the balloon and the mitral processes, I think, is fine.
I think you demo a very good procedure because you keep the shoulder inside the inflow part of the device.
So I do the final angel. And that's PowerX. So this is final. Oh, sorry.
May I have a quick
question?
question?
Yes, please.
Yes, I think the result is perfect. You don't have any conduction disturbance with this kind of proper depth of the THV. I have just a quick question about the, even though we know that the smart tri is from the supraannular design and the self-expanding THV, will you consider if you use the Davitor intraannular design, you have a similar hemodynamic performance, or you think it cannot be applicable for this small anatomy?
Dr. Cao?
Yes, sorry.
Have you ever considered a Navitor for this anatomy?
Navitor, yes, we can consider it, yeah. Because the cancer
25.
就曹主任想请教一下，就是你觉得 Navitor 它是 intraannular， 所以它会跟 Evolute 一样，有就是这个 mainly driven 这个 mean pressure gradient better hemodynamics driven from the self-expanding devices or the supraannular, the position of the annulus, or both.
Actually, I don't have too much experience of Navitor. Yeah.
And what's your comment?
What's the comment of Dr.
Yin? This question. What's your answer?
There is no evidence, but I think maybe both. But even though IDE tried showing the Navitor have a better lower gradient as comparing to the Sapien, but comparable with the Evolute. But I think, yeah, if you have the supraannular position of the valve, maybe the expansion is much better because the valve is not constrained within the annulus.
Well, I see Dr. Michael Reardon is on the air. Dr. Reardon, can you comment on this case?
Yeah, Evolute and Navitor will have the same hemodynamics. There's a difference between balloon expandable and self-expanding. Both the intra and supraannular valves seem to have comparable hemodynamics. But, again, for the small annulus, if you want to get the best hemodynamics, no question that you're better off with one of the self-expanding valves. We tend to use Evolute. We've got the most experience with that. But I ran the Navitor trial too, and I'm running the Navitor Envision trial right now in the U.S. So we have a fair experience with both of them. We don't worry about the mechanical valves. It's more of a problem if you have a tissue valve because of the post can interfere with your balloon. But for the mechanical valves, it's almost never a problem.
Mm-hmm. Okay.
Thank you.
Thank you.
So an excellent result. Thank you. Congratulations.
Yeah, beautiful result.
Thank you.
So, should we go back to Shanghai, Fudan? Can Double let us know the result or the progress of the case? Or we come back later? Okay, then we finish this session, and maybe we can go back to Fudan Zhongshan later if the case has been done. Thank you very much for your attention, and the participation. Thank you.
Thank you.
General Hospital, and we have some moderator for Singapore, Korea, and Hong Kong. We will chair this section. This section we will talking about a debate in patient-process mismatch, and I will introduce the first speaker. The first speaker is Professor Michael Reardon. Professor Michael Reardon is a cardiac surgeon, and he graduated from the Baylor medical school and received his resident training in Texas Heart Institute and fellowship in Harvard University. Now he is a professor of cardiovascular surgery and served at Methodist Hospital, Houston. And today he's talking about the view of supraannular design. Please, Dr. Riordan.
Well, thank you very much for having me. I'm sorry I'm not there in person this year. I'm going to have my 50th wedding anniversary in 2 weeks, and I was told if I would travel, I'd be in trouble. So we're going to talk a little bit today about patient prosthetic mismatch and supraannular design. This is some of my conflicts of interest for the transcatheter aortic valve world. I've been a national leader on a number of trials, so I'm pretty conflicted across the board, but I'm also a cardiac surgeon. This is what I do for a living. The supraannular design, as you know, is the Evolut valve, and it has a hourglass shape. It's wider at the inflow. The valve itself is constrained and it expands out. This allows several things. One, it allows the valve to sit above the plane of the annulus and fully expand. It allows the commissure post to be higher than the valve itself, leading to a parabolic arc of the leaflets, that spreads the stress out and allows it to open up more fully than if it was just conical. Now, patient prosthetic mismatch was first brought to us by Rahmatullah, a cardiologist at Cedars in Los Angeles in the 1970s. Rahmatullah first said that if a surgeon puts in a valve that doesn't give you a normal EOA, that was mismatch. Of course, that was all surgical valves at that time. So he then changed and said mismatch is if the surgeon puts in a valve whose EOA is not large enough for the physiologic needs of the patient. Now, that was further defined by Pibro and Dumasil in Canada, where they looked at mean gradient at peak exercise versus index effective orifice areas and looked for bends in the curve for gradients. And that gave us our current definition of severe patient prosthetic mismatch is 0.65 centimeters squared per meter squared or less. 0.65 to 0.85 was moderate. Above that, it's normal. And then there's been a variety of factors built in for obesity. Now, if you look at the balloon expandable valve and the self-expanding valve, Becky Hahn, who runs the Echo Lab at Columbia with Marty Leon, looked at the Core Lab, and what Becky showed from the Core Lab echoes from the randomized trials in the US, that the mean EOA for SAPIEN 3 was 1.66, and the mean EOA for Evolut was 2.01. Becky then made these graphs, these charts up, and for the SAPIEN 3, you see for a SAPIEN 320, an EOA is only 1.22, which is really moderate aortic stenosis to begin with, and it goes up to 1.89 and then 29. The mean gradient started at 16 and go down to 9. Most importantly, look at the Doppler velocity index, about 0.42. Same thing for the Evolut core valve. The EOAs are all larger. The gradients, mean gradients are single digits, but the Doppler velocity index is 0.61. Now, that's important because the Doppler velocity index represents the ratio of that patient's EOA to that patient's LVOT. And clearly, you'd rather have your valve open to 61% of your LVOT than 42%. Now, surgeons have known patient prosthetic mismatch is bad for many, many decades. This is Fallon's work looking at almost 60,000 patients from the STS database over 10 years for isolated aortic valve replacement for 65 or over. And what Fallon showed us that any degree of patient prosthetic mismatch significantly decreased long-term survival and increased readmission rates for both heart failure and reoperation for AVR. Howie Herman from Penn showed us from the TVT register that for TAVR, any severe patient prosthetic mismatch caused a decrease in survival even at 1 year. Raj Makkar has a similar paper coming out for his own experience with the balloon expandable SAPIEN valve, showing that moderate or severe increase your mortality. That paper's in press right now and hasn't come out. We also know from Fleming's work that patient prosthetic mismatch is associated with early biologic valve dysfunction. Now, there's several things that are associated with structural valve dysfunction, small body surface area, being female, small size, small EOA. But the only thing that's associated with poor survival and structural valve deterioration is patient prosthetic mismatch. So patient prosthetic mismatch kills you, it makes your valve fail early, and it keeps you from recovering. In the low-risk trial, if you got assigned to the surgical arm rather than the TAVR arm for Evolut, you had 5 times the rate of moderate to severe patient prosthetic mismatch at 1 year. And if we compare the low-risk trials for 30-day patient prosthetic mismatch between Evolut and the, say, S3 in the partner low-risk trial, there's a marked difference in the amount that occurs. The ballooning expandable valve has a much smaller EOA and a much higher rate of patient prosthetic mismatch. Now, Gorlin, when Gorlin was working out flow across the fixed orifice, showed us in the 1950s that if you plot aortic flow on the vertical axis, mean grade on the horizontal axis, it fixed orifice areas, the blue lines. The red lines represent fixed cardiac work, just to give you something to look at. And you find the line for 1. At rest, your mean grade is about 40, but at peak exercise, about 550 cc's a second across the aortic valve, your mean grade is 130. And you have to get to a mean EOA of about 2 before you can really increase your flow without increasing your gradient. And that's why the mean EOAs of 1.66 for, say, S3 and 2.06 for Evolut really matter for a younger patient or a patient who's going to be physically active. Now, we showed some time ago from the high and intermediate risk trials where we had over 2,000 patients that were randomized that there was more moderate to severe structural valve deterioration in surgery than there was in TAVR. And if you had moderate to severe structural valve deterioration, that doubled your all-cause mortality, doubled your cardiovascular mortality, and doubled your rehospitalization, whether you had surgery or TAVR. So structural valve deterioration, which patient prosthetic mismatch is tied to, is a bad thing. We also showed that if you looked at overall biologic valve dysfunction, which includes structural valve deterioration, non-structural valve deterioration, thrombosis, and endocarditis, was much higher in surgery than it was in TAVR, and it too was associated with an increased hazard rate of mortality, all-cause mortality, or rehospitalization. Just recently, I presented the 5-year low-risk biologic valve dysfunction at the AATS meeting in Seattle. This paper is now undergoing review, and what we showed is at 5 years, the rate for surgery was 14.7%, Evolut was 13.4%. So for low risk, there's no difference in the rate of structural valve deterioration and no rate in the bottom graph of biologic valve failure, which is death due to the valve, reoperation due to the valve, or severe structural valve deterioration. And if you had that, it markedly increased your mortality, your cardiovascular mortality, and rehospitalization. So again, these are all tied to patient prosthetic mismatch and all related to increased mortality, increased rehospitalization. This is the partner 2A, which is the intermediate trial. This is Philip Pibro's work. And what they showed is for the randomized XT versus surgery, XT had more structural valve failure than surgery did. But then if you look at the non-randomized S3 population, which they then propensity matched, it was 2.6 for S3, 1.3 for surgery, numerically better for surgery, but statistically no different, 0.083. But if you look back in the supplement to the paper, if you do an inverse probability treatment weighting statistical analysis, which gives you a better pseudopopulation, a better comparison, S3 actually has statistically more biologic valve failure than surgery. Now, we can't compare directly between these kinds of randomized trials, but one of them did do better than surgery, one of them did not. We do know from strange echo work in Australia, from their national echo database, if you go up by 0.5 meter per second in flow, going from no aortic stenosis to mild to moderate to severe, any level of aortic stenosis increases your mortality. So anything that decreases your EOA in the long term increases your mortality. And of course, that is what happens with patient prosthetic mismatch. So patient prosthetic mismatch increases mortality, it prevents patient recovery, it increases valve dysfunction. It's something that should be avoided whenever possible, particularly in patients with bad ventricles or younger active patients. And the supra-annular design minimizes mismatch. I thank you, and I'm happy to answer any questions.
Thank you, Dr. Liu, that we will discuss after complete the full speech. Now we will switch the moderator to Dr. Tay.
Thank you very much. So I'm going to introduce the next speaker. This is Professor Nuttall Wood. his good friend, excellent interventionist. He's an associate professor of medicine and director of cardiac catheterization lab at the Faculty of Medicine, Siriraj Hospital, Mahidol University, and is the vice president of the Cardiovascular Intervention Association of Thailand. Professor Nattowa is an expert in coronary physiology, imaging, complex coronary and peripheral interventions, renal nerve denervation, and is, of course, very well known in TAVI. So without further ado, I'd like him to start his talk on post-TAVR PPM long-term outcomes and implications.
Thank you, Eka, for a nice introduction. So let me give you some insight about the post-TAVI patient prosthetic mismatch, the long-term outcome and clinical implication. Okay. No? Okay. Okay. So I think the objective will first, I think we'll look at the definition and prevalence and some predictor and the way to make diagnosis and limitation and pitfall on each way of making diagnosis. And then we will discuss a clinical approach of the clinical outcome and application. So I think as Dr. Michael Radon have been mentioned, is the patient prosthetic mismatch. You put the normal valve, normal function, but the valve is too small. When it's too small, if the cutoff is less than 0.55, is that will determine severe. In the obesity patient, I think the cutoff will come down from 0.65 to 0.55. And it has been well known in surgical literature, in the patient undergoing surgical aortic valve replacement, if you have severe PPM, it impacts long-term mortality. And I think all the surgeons do and all the interventionists, I think we always look at, before putting any valve, we had to look at the patient BSA compared to what expect orifice area. And is this coming to the area of the severe PPM? I think we want to avoid that. So that's a predictor. I mean, it depends on how old the patient. I think if you put a younger patient, they're more active. I think they may have more problems with PPM. If you put in the patient with the smaller size, smaller valve with the large patient BSA, or patient with the valve in valve. So I think young age, large BSA, small annulus area. I think this is all the predictor, and especially the patient with valve. So I think before we can look at the outcome, we need to look at how to make diagnosis. I think as we mentioned, is EOA divided BSA. BSA cannot be changed, but EOA is depend on what you use. I think the gold standard we use is measure EOA, which used by echocardiographic measurement. And this is a very specific protocol that you need to be followed because each valve, like balloon expandable, may have some whole flow hemodynamic difference compared to the self-expandable. So I think this is each measurement will have some impact on the EOA measurement. We know that balloon expandable have some unique flow characteristic, like they have instant and precast flow acceleration. And this can be overestimate the gradient. We also that patient will have the pressure recovery in balloon expandable, which you put small valve, that can be overestimated. So I think that could be some limitation with you look at just hemodynamic. So we know that if you put the balloon expandable, they may be exhibit higher post-echocardiographic mean measurement, but invasive measurement is not different. So I think this is the key that when you look, you have to take this in consideration. Another study just recently published from the Pibalo and Rebecca have been shown that patient flow hemodynamic, if the patient with low flow, that can be happen about 30 to 40% of the case, can be effect on the overestimation of the of the PPM. So what it means, in the patient, they divide the patient by stroke volume index. If stroke volume index less than 35, that defined by low flow. When you have low flow, aortic valve not fully open, and that can be cause EOAs to be small, even though it's not a PPM. So this one, can you see this? Is number is higher in terms of the pseudo PPM. So I think the flow can be effect on the measure EOM in the patient with low flow. The other way we can look at, if we don't use the echo for measure ppm, we can look at the, so I think, so the measure EOA have some limitation, two limitations. It can be flow accelerate and instant inlet, and level of the cusp LVOT. So I think if you have the wrong measurement, you can miscalculate calculation. So I think to look at this, you have to use the echo collapse, and because it can be common early in the practice. And the second, when you have low flow state, this is valve can be opened. So I think you can have the pseudo ppm, and I think to differentiate from the true ppm, you have to use the dobutamine stress echo. The other way we can look at the EOA, making diagnosis, use the predict EOA. Predict EOA is like, you know what size, the type of the valve, certain specific valve that you could put at. Let's say we plan to put the SAPIEN, we know that EOA on this 20, 23, 26, 29 is this. And then you divide by body surface area. And that will have advantage because it will be, don't have echocardiographic measurement earlier, don't have hemodynamic effect of the low flow. We can also look at the CT, because sometimes when you think about putting expect EOA, but maybe you have some calcium, so we're not fully open. So CT may be more accurate, but we know that from the CT, the size of the EOA will be bigger than echo, about 15%. But the problem is we don't have any gold standard, what the cutoff. But when you look compared to CT derived EOA compared to the echo, the rate of ppm is coming down, both moderate and severe. So I think when you look for the outcome, making diagnosis, you have to know that this is measure EOA, predict EOA, or CT derived EOA to making critical approaches on the clinical trial. I think that will be the key message of limitation of each that I've been described about. So you can see from here, Dr. Tineco published in European Heart, if you look measure EOA, when you adjust for the obesity, the EOA coming down from 21 to 17. But if you use the predicted, the rate of severe ppm, patient-prosthetic mismatch is only 2%, and it's come down to 1% in clinical practice. And the predicted EOA, not the measure EOA, that explain the outcome in the severe ppm. Another paper just published in European Heart in 2023, you can see that they have some reclassification from measure to compare to predict, compared to CT derived. And again, predicted POM is actually the one that predict the clinical outcome. So I think looking this to define severe patient-prosthetic mismatch, you can start from the measure EOA by the echo. If the is fall into, if its number is more than cut off, it's not severe ppm. But if the number is below, you look at the gradient. If gradient more than 20, it's severe ppm. But if the gradient less than 20, maybe you had to calculate the predicted EOA. If the predicted EOA is fall into, then you in this category. But if it's not, you have to think is maybe your echocardiographic measurement or maybe patient in the low flow state. So now let's look at the outcome. What is the data have been shown? Dr. Redon have already been mentioned. The TVT registry involved over 60,000 patients. This one used measure EOA, and the rate of the severe ppm is above 12%, and it's actually had some impact on mortality. But this one is echo measure by site, no echo collapse measurement. But it gives us some information that severe ppm is not good. In Asian, I think from group from Taiwan have been shown that self-expandable ppm rate is about 1.5 and its impact on mortality and hospitalization. Dr. Abbas have been shown some interesting information. He looked at the partner 2 and 2A, and he said that when you have the severe ppm is about 9%. If you have the normal flow, he divide patient normal flow, stroke volume more than 35 and less than 35. The rate of severe ppm is only 5%. But if you have the low flow, is rate up to 20, and that could be in the patient with low EF or normal EF. But very interestingly, the PPM, severe PPM have no effect in the patient with normal flow. The effect is actually in the patient with low flow. And when he plot the curve, the cutoff of stroke volume index is less than 35. The lower of stroke volume index, the higher of mortality. And I don't know that is because of the severe PPM have impact, or because of the low EF or low flow state have some impact. Another study have been published in European intervention, also have shown similar. When you have severe PPM, if you have low EF, impact is more. The look at the large data in the Swedish heart registry involve about 8,000 patients. Rate of severe of any PPM is only 7. This one used the predicted EOA, not the measured EOA. And severe PPM only in 1 patient. And when you have this, it's actually no impact in mortality and no impact on heart failure. And the last data from IMPACT TAVI registry published in JACC intervention. Over 40,000 patients from international 26 sites. Again, prevalence of PPM, if you use predicted, is significantly lower than measured PPM. And it's can reclassification severe PPM from 4.3 to only 0.6. And when you look at the parameter like low EF, female, paravalvular leakage, neither of these actually can predict the outcome. Meta-analysis involved 80,000 patients, show that only severe PPM predict mortality. So in summary, is my last slide here. So when you see the PPM, I think you have to look in the patient model, prosthesis model, look at your anatomy, and then first you need to calculate the predicted EOA. If it fall into the severe PPM, you have to do the preventive strategy. Maybe get the valve with better hemodynamic, enlarge. If the valve involved, you might have to crack it. But if it's not fall into, but it's just only it fall into the moderate, maybe you have to look at your parameter, like a patient with young depressed EF, low flow state or not. If yes, preventive strategy should be done. And this is the protocol that we also always look at the patient with small annular ascirat. We look at the predicted POA, careful imaging, evaluation, balance risk of leakage, annular rupture, and maybe future TAV in TAV as the case discussed this morning in the live case. In summary, I think PPM definition is a valve normal function but too small for the patient body size. The rate in current TAVI era is, if you look for the measured EOA index, is about 10%. But if you use the predicted EOA index, it's about 1%. So it's quite rare with use the CT analysis in this current era. There's some predictor in the patient who is young, who female, very small size, that common in Asia. If this is a predictor for severe PPM, and the severe PPM can impact mortality, especially in the patient with low flow. There can be normal flow or low EF, can be normal EF or low EF. So I think procedural planning, meticulous CT analysis, calculated, predict EOA, and take preventive strategy need to be done before put the valve in. Thank you very much.
Okay, let's move to the next topic. Next topic is a view of a balloon expandable valve, which was presented T.W. Bach. As we know, Dr. Bach is the interventional cardiologist who working in the Asa Medical Center and is the course director of the several numbers of the live courses in the Asa Medical Center. And he was one of the main investigator, which was published in the New England Journal of Medicine and the Lancet in the Asa Medical Center. Dr. Bach, please.
Okay, thank you. So my topic is about some practical point of PPM and the view of a balloon expandable valve. This is my disclosure. And I'm going to start in question of a big debate and smart trial say supraannular self-expanding valve, always better than the balloon expandable valve, like Safian in Asian population in small annulus? I think yes, Medtronic always, and no, Edward Sapiens always. So PPM is absolutely issue, and already presented in the microreading, and this issue was initially concerned in the surgical valve. And the normal valve size is big, but the SAVA valve relatively small. There was a concern about the effective orifice area. And the definition of the PPM was supported by VAC definition, and the indexed EOA absolutely divided by body surface area. And some patients are showing the high residual pressure gradient and more than mean gradient 20. Some patients, although there is no pressure gradient in cath lab, echocardiography was normal, but if you divided by the body surface area, there was classified to moderate or severe PPM. It doesn't matter what the impact of the PPM. So, and the theoretical concern about the PPM and the small annulus, and the small annulus is associated high leaflet mechanical stress. There was some methodological issue, and the concern could be some mechanical stress. And so small annulus is associated high risk of severe PPM, and the severe PPM is concerned would be associated with the increase of valve degeneration. So, and we know a well-known risk factor of the PPM is based on a lot of the bunch of data, and the small annulus and the small prosthetic valve size. That is absolutely more common in the Asian population rather than Western population. So, and the first issue about the PPM prevalence in the Asian population, is it always true Asian population is higher prevalence of PPM compared to the Western population? And the Asian population absolutely smaller annulus dimension or valve size compared to the Western population. Is it true the incidence truly common, particularly relevant in Asian population than Western population? And as you know, the Asian population usually has a low BMI, low annulus valve area, low vessel, and the low device size. So, and looking at the clinical impact, this is already the presented in the many lecturer and the TVT registry. There was all-cause mortality, but there are many unmeasured confounder, and there is no dedicated evaluation about the unmeasured confounder. And this is very nice data, TP-TAVR registry combining Asian and the Western population from our center AMC and the Stanford University and the Northwestern University, two major TAVR centers in the United States, and the TP-TAVR registry. We evaluated overall proportion and impact of a PPM. So looking at the PPM overall instance, left side the Asian, right side the Western population, and the moderate PPM in the Asian 27%, severe is at 7.1%, and the Western population moderate at 30%, and the severe 25%. There was absolutely contradictory our initial expectation. I think the main parameter, main decision determinant of the PPM is body surface area. So, and there are still some debate and question, and PPM only echo hemodynamic parameter, just the ratio of fallacy by body surface area. There is still debatable point. So, and although the follow-up duration is relatively short and just 1 year, and in our TP-TAVR registry, we didn't find any impact on the clinical outcome of the PPM is all-cause mortality, stroke, and the rehospitalization. And the second issue about the smaller TAVR valve and the presence of a PPM in Asian population is absolutely associated unfavorable long-term durability. We don't know yet. And then PPM during the TAVR, does a valve selection matter in the small annulus? And the valve type with a larger EOA, like a supraannular valve, always beneficial for Asian with a small aortic annulus. That was also not yet determined. And our intuitive mind and the Sapien valve is lower EOA compared to Evolut valve. That was true is another valve, and the Nabito and the Sapien and Evolut, there was a different
valve size and the different hemodynamic. And this is very interesting data and the evaluation of the overall prevalence of the ppm and in patient with the small annulus less than 23, and the Nabito and the severe ppm is 4%, Evolut is 3%, Sapien is 26%. That is absolutely true. But we don't know this is really influence of a true clinical outcome. And the SMART trial gives some hint of a message. This is a RCT and comparing the Sapien valve and Medtronic valve is mainly targeting small annulus area defined MDCT and the valve area less than 430 and the one-to-one randomization. Very interestingly, and this SMART trial adapted the two concomitant primary endpoint. One endpoint is a hard clinical endpoint like mortality, disabling stroke, and heart failure rehospitalization. There is the same primary endpoint of a SMART-3 trial. And another co-primary endpoint, less severe, and the functional endpoint combining and the hemodynamic structural valve dysfunction and the non-structural valve dysfunction and the valve thrombosis, endocarditis, aortic valve reintervention. There was mainly based on the VAC definition of a biprothetic valve degeneration and looking at the key component and the hemodynamic valve determinants and the presence of a PVL and the ppm issue. If without know about the valve dysfunction, if ppm exists, there was the absolutely regarded and the occurrence of the endpoint in the people starting SMART-3 SMART trial, and I think we guessed always supraannular valve win in this trial. So and as our expectation, hard endpoint was no difference. Mortality, disabling stroke, and heart failure rehospitalization is the same in between the two the valve device. And another co-primary endpoint, bioprothetic valve dysfunction, that was also our initial expectation. And the hemodynamic structural valve dysfunction much higher in the Sapien valve, and the non-structural valve dysfunction was much higher in the Sapien valve, but there was mainly driven by the presence of the ppm. So, and the hemodynamic function was better with the Evolut valve than the Sapien valve. There was also our expectation, but it's looking at the hard endpoint data, and this is a very interesting 5-year outcome in the published New England Journal of Medicine and the FATINA-3 trial. And looking at the primary endpoint, the hard endpoint, that was the same in the SMART trial. In the hard endpoint, all-cause death and the stroke, rehospitalization, and according to different size of the valve Sapien, no difference at all, and 23, 26, 29. And that means no difference in the hard clinical endpoint. There was some difference in the functional and the soft endpoint. And so two trial, and some findings is similar, some findings not similar. And the hard endpoint was no difference, but the functional endpoint was better with Evolut, and the hemodynamic structural valve deterioration also included isolated hemodynamic dysfunction, even without evidence of a morphological structural valve degeneration. So clinical applicability, SMART trial results should be strongly applied for optimal valve selection for Asian population with a small annulus size. This is a still debatable portion. And summary, and the PPM definition is still arbitrary, controversial, and we don't know there is a true pathologic finding or physiologic phenomenon, and the just ratio fallacy mainly driven by body surface area. And in clinical viewpoint, I think a more accurate, widely applicable definition of a PPM is required, and correctly classify patient with hemodynamic true flow limitation and the direct application of a SMART trial, and still controversial. And in the clinical viewpoint, and the further validated in the preferential use of the Evolut over Sapien based on annulus size is associated long-term durability. This is a more required data. And
this is still debatable. PPM is key factor of valve selection and require. Also, this is my last slide. And but this PPM, I think, is some issue in the relatively young generation and the elderly generation. Compared to the elderly generation, young generation, more active lifestyle, fewer comorbidity, requiring more long-term durability, and the clinical impact of a PPM could be greater in the younger patient compared to the elderly patient. Thank you for your attention.
Professor Tsai, please chair the last speech.
I will.
Okay, we have the last speaker, Professor Shioshi Kaneko. He is the assistant professor in surgery from the Brigham and the Women's Hospital. And he also is the director of the RT surgery at Brigham and the Women's Hospital. And today he will give us a speech about the TAVR experience, state of the art and the impact of the valve design. Okay, Professor Shioshi, please.
Thank you for the invitation to Type A Valve. I'm Yoshi Kaneko from Washington University in St. Louis, and I will be presenting prosthesis patient mismatch, surgeon's view. It's a very controversial topic, and I'm excited to present about the PPM from the surgeon's standpoint. These are my conflicts. So prosthesis patient mismatch was first proposed by Dr. Rahimtullah in 1978. Mismatch can be considered to be present when the effective prosthetic valve area after insertion into the patient is less than that of a normal human valve. And to make it very easy, it happens because the prosthetic valve that goes in has a much smaller effective orifice area compared to the native valve. This is, for instance, a bioprosthetic valve that is implanted surgically. We have to have a cuff in order for these valves to go in, and also there are some suturing material that goes in, and the effective orifice area becomes much smaller compared to the original size of the valve. Same thing with a mechanical valve. Mechanical valve is always said to have a larger EOA compared to bioprosthetic valve due to the smaller cuff and smaller material needed, but still you can see that there's a lot of sacrifice when these prostheses are implanted, and the internal diameter of the valve itself becomes much smaller compared to the native valve itself. So this PPM after surgical aortic valve replacement has been studied throughout the years. This is one of the largest studies looking at mechanical AVR in patients with severe mismatch. And you can see that patients with severe mismatch had significantly poor survival after mechanical AVR. And this has been studied multiple times. One of the reasons that is thought to have a long-term effect is the non-regression of the LV mass. These left ventricle becomes very hypertrophied, but they just do not regress because there is a persistent gradient in these patients. So surgeons have treated these PPM, and there are some techniques that we utilize, which are called aortic root enlargement. It really has been popularized throughout the years. The most simple procedure is called a Nix procedure, where the incision is gone into the non-sinus. There are Manugian that goes into the mitral valve, and then you can go anterior and enlarge, which is called Conno-Rastan operation. The concept is very simple. You have a ring and you cut it, and then you patch it and make it bigger. So this is the real concept of aortic root enlargement procedures that we tend to do. There has been a new aortic root enlargement technique called the Y technique, invented by Dr. Bo Yan, my good friend in University of Michigan. So what this procedure does is that you make an incision through the commissure between the non-cusp and the left cusp, and then you literally cut right above the right at the aortomitral curtain, right above the anterior leaflet of the mitral valve. So because this looks like a Y, it's called a Y incision. You place a patch where the Y incision is, and then place a larger prosthesis. Dr. Yang claims that he can put 5 sizes bigger, but typically 2 to 3, which allows a much, much bigger sizing. So there has been a resurge in the interest of aortic root enlargement, and I think there's 2 reasons for this. One is there has been interest in patient-prosthesis mismatch in the world of structural heart, and also the future valve-in-valve TAVR as a lifetime management. So there has been some warning about the PPM in the TAVR world. This was one of the largest paper published by Howie Herman in JACC looking at the TVT registry. He found that with all the TAVRs being performed in the US, this is back in 2018, about 12.1% had severe patient-prosthesis mismatch. And you can see that the mortality at 1 year, this is a short-term outcome, 1 year, there was a higher mortality with the severe patient-prosthesis mismatch. This paper has some criticism. There has been a lot of valve-in-valve TAVRs that were included, which probably is a little different from the native TAVRs. However, it did show that having severe PPM had worse outcomes at 1 year. And there's been multiple papers looking at the trial data, as you know, both balloon expandable valve and self-expanding valve, and both showed this is on the TAVR side, but on the surgical side as well, showing worse outcomes. This really has led to the SMART trial, comparing balloon expandable valve and self-expanding valve. The primary outcome, the first primary outcome, looking at mortality, disabling stroke, and heart failure rehospitalization, was no different between the 2 studies, between the 2 groups, looking at balloon expandable valves and self-expanding valves for small annulus. However, when the biprosthetic valve dysfunction was analyzed, self-expanding valve had much, much lower percentage compared to balloon expandable valve. And when you look at particularly looking at the severe prosthesis patient mismatch, the self-expanding valve only had 3% compared to balloon expandable of 9.8%. The second part is the valve-in-valve registry. This is an old paper published in JAMA by Danny DeVere, looking at the valve size and the outcomes. Again, if you had a large annulus or large valve implanted over 25, you had the lowest risk. When you had intermediate, which was between 21 and 25, the outcomes were okay. And when you had valves less than 21, the outcomes were worse. So this paper really provoked a concept that aortic root enlargement should be performed to place a larger valve, ideally over 25 millimeter when the future valve-in-valve is considered. But there's also a question whether 25 millimeter valve is needed for everyone. This is looking at balloon expandable valves of valve-in-valve registry in Partners 2 trial. You can see that having a valve size over 25 versus 21 didn't make a difference, meaning that for a certain population, that large size may not be needed, and therefore will not need that aortic root enlargement. So what is the outcome of aortic root enlargement? So this is from the Canadian registry looking at Ontario database. ARE is the aortic root enlargement, and the blue is AVR. You can see that the outcomes were similar between the 2, although aortic root enlargement had slightly lower survival. The operative time was longer with aortic root enlargements, but bleeding, pacemaker, and transfusion rates were similar between the 2 groups. The largest study that has been done using the STS registry is this paper, looking at surgical aortic root enlargement versus no enlargement. And you can see that in the recent years, the aortic root enlargement really has caught on. The most recent analysis have shown that the root enlargement has been growing over the recent years. And this is the survival outcomes. When you do a root enlargement, there is an initial penalty from the complexity of the surgery itself. But at about 4 years, the line crosses, and aortic root enlargement group has a better long-term outcome. So there's some survival benefit seen after 3 to 4 years after aortic root enlargement. So I do want to show a case before I finish. So this is a 61-year-old patient who had 23 millimeter magna, comes back with severe AI and possible endocarditis. Mean gradient was 16 millimeters of mercury. The patient was relatively big. His BSA was 1.9. And when you use the patient prosthesis mismatch table, this patient with a 23 falls into that red category. So we do want to place a larger valve and also make sure that the patient can get a second valve in valve. This was the echocardiogram pre-procedurally. You can see the severe AI. And you can see that the valve was placed relatively properly. The valve occupies the entire space, but not enough so that it will be on the green table. And this was the preoperative CT scan. You can see that the valve to coronary distance was relatively close on the right side, 2.6 millimeters. So what we did in this case was we did a redo surgical root enlargement. This is the old valve that you see here, and this is cutting out the old valve. And then I performed a white root enlargement in this particular case. You can see that right here, I went through the annulus there, and I'm cutting towards the trigone on both sides so that we can put a bigger patch in. And after we mobilize this, we suture the patch. I'm going to fast forward some of the patch placements. You do have to make sure these patches are placed appropriately. And after the patch is placed, we placed a 25 millimeter magnet. So we went up one size afterwards. And this is what it looks like. After the completion, this is the echocardiogram. You can see that the valve occupies a little larger area compared to what it was before. And this is the CT scan that was taken afterwards. You can see that after the root enlargement, the valve to coronary distance has increased because of the large sinus that we have implanted. And this will definitely be feasible for future valve-in-valve. So we will hear more about aortic root enlargement in relationship to the patient prosthesis mismatch in the future. And this will remain a very, very hot topic in our field. Thank you very much for having me.
Okay. Dr. Michael Lee, please chair the discussion. Oh, Dr. Xie, maybe you can handle this.
Okay, thank you very much for all four speakers' very excellent speeches regarding the PPM. So is there any comment or question from our moderators or panelists? Who went first?
Well, just remember that PPM is always bad, and surgeons have known it for decades, and the TAVR field will find out as we get longer-term data. And it just makes intrinsic sense. If I'm your surgeon and I send back every patient with a 19 millimeter valve versus a 23, you're not going to be happy. And the reason you're not going to be happy is because they have worse hemodynamics. So we all would like to get the best hemodynamics we can as long as it doesn't cost the patient anything. And again, you ignore the gradients because they're flow related, and look at the Doppler velocity index, because that gives you a ratio of that patient's EOA to that patient's LVOT. And so you want the best Doppler velocity index you can get. So patient prosthetic mismatch will always make a difference. And when you do studies like a BOSS, which usually looks at gradients, just remember that the low gradients often have low flow, and they have higher mortality because of flow. So you can't go on just gradient alone. Patient prosthetic mismatch is bad, and the younger you are, the more active you are, the more important it is to avoid it.
I have a question to Dr. Lidon and Dr. Kaneko. In the viewpoint of the surgeon, as we know, from the SMART trial result, the 1 year clinical outcome is similar, but the incidence of the bioprosthetic valve dysfunction is quite different. That study was done in the 1 year follow-up. What is your expectation, personal expectation, in the 5 year and the 10 year follow-up of those patients? I'd like to ask to Dr. Lidon.
Well, Yoshi Kaneko is not on because he's younger than me, so he had to go to bed. But Yoshi is one of our rising star surgeons here in the United States. He's actually the chief at St. Louis University now. I tried to lure him to Houston, but I couldn't do it. I think in the 5-year data, what you're going to find is that the lines are going to cross. You notice that the lines crossed halfway through the first year for the primary endpoint. And you remember in partner 3, the mortality lines crossed at 3 years. In partner 2, the mortality lines crossed at 3 years. In the intermediate and the low-risk Evolut trials, the mortality lines have never crossed. Started better for TAVR, stayed better for TAVR. So I do think that long-term hemodynamics will matter, and at 5 years, I think you're going to see the difference start to splay out. 1 year is just a little too soon.
Okay, so Professor Michael, I have one question for you that regarding the PPM. As all of us agree that prevention is more important than the treatment. So what's your opinion or any suggestion to have some regarding the prevention strategy for this PPM from current database and current evidence? Thank you.
Well, I mean, as Dr. Kaneko pointed out, in surgery, our option is to do an annuloplasty. And I do annuloplasties in about 30% of my patients now. So everybody that's coming for an AVR gets a CT scan like a TAVR, and we do an area-derived diameter, and we try to pick a valve that has an inner diameter, which is equal to that area-derived diameter. The inner diameter of a biologic valve is about 2 millimeters smaller than the external diameter. So if you have a 27 millimeter annulus by CT, you need a 29 millimeter valve in there if you really want to give them a match to what you're taking out. And so I think from a surgical standpoint, we do many more annular enlargements than we did in the past. And if you look at the low-risk trials, annular enlargements were only done about 4% in both of the low-risk trials, and that's because all we really had was the Nix and Manugian, which lets you go up 1, sometimes 2 sizes. With the Y annuloplasty, I can always go up 2 and usually 3 sizes. So it's really easy to take a 19 to a 23 or to a 25. And so I think that's how we prevent it in surgery. For TAVR, if you really are worried, the self-expanding valves all have better Doppler velocity indexes and better hemodynamics than the balloon expandable. And you just have to decide what's your trade-off there. Is it the optimal hemodynamics? Is it a slightly lower pacemaker rate you want with the balloon expandable? But the self-expanding valves all have better hemodynamics, all have better Doppler velocity indexes than the balloon expandable. But there's multiple reasons to choose a valve. If hemodynamics alone was the reason, you'd put in self-expanding in everybody. But there are other reasons that we choose valves.
Okay, thank you very much for your comments. Please.
Yes, I agree about PPM. I'm Gru Hong from Korea, and I'm imager. Yes. And I'm very interested about PPM. In the point of view of the imager, PPM exists. But I don't think that is really important, in the critical decision in the selection of a valve, and than expected, because severe PPM is always a problem. But in the TAVR era, severe PPM incidence of severe PPM is really low, and the problem is Dr. Riordan already mentioned about it in the Doppler measurement. Always have an inherent, limitation for the measurement. Yes. Echo measurement in the pressure gradient is always overestimated. If you compare with invasive catheterization, in the Doppler measurement, pressure gradient is always higher than the invasive catheterization because of a lot of factors. And the one data they shown about that, before TAVR or AVR, baseline concordance between the echo and invasive cath is very concordant. But after surgery, there is a TAVR valve or a surgical valve is totally discordant. The pressure gradient is the discordant between the pressure gradient measured by echo and the invasive cath. And because of the pressure recoveries or some other baseline factors, and all the factors can be affected those measurement. So I don't think in the PPM should be considered when in the selection of the valve. But severe PPM is always a problem. It's a 1% or 2%. But moderate PPM, every data, they didn't demonstrate any difference in the mortality in the long-term survivor. So, one thing is, don't deeply think about pressure gradient after self-expandable and balloon expandable. Always self-expandable looks better, but that is the inherent, there is a limitation and have some problems in the measurement. So do focus about other factors for the primary outcomes and safety and all the other things, and then consider about in the PPM.
So, Dr.
Well, I just have to
any
comment on pressure recovery, because I think pressure recovery is thought about all wrong. Pressure recovery comes from the first law of thermodynamics that says energy can be neither created nor destroyed, it can only change forms. So your ventricle gets a pressure higher than aorta, that's potential energy. When it accelerates through the valve, it changes to kinetic energy and your pressure goes down. Once it gets through the valve, it hits non-laminar flow or the walls there, it slows down and it gives back potential energy and your pressure goes up. Your echo measures the pressure at the valve tip. Your catheter measures it downstream where you have recovery. What the heart cares about is how much work it has to do. And work is force over distance, and force is mass times acceleration. And I can calculate the amount of work it takes to move every volume of blood from where it is past the aortic valve. Once it gets past the valve, that work is done. You will not get it back when the pressure gradient goes up. In fact, when the pressure gradient goes up, you're adding to afterload, which is a bad thing. So pressure recovery is nothing but a marker for stenosis, and it doesn't really mean there's less of a gradient. The echo measures, they each measure a different thing. Not one is not correct. They're measuring correct things for different areas. And so, this concept that pressure recovery somehow decreases the gradient and makes it less important is absolutely false, because it doesn't decrease the work the heart has to do. The work the heart has to do cares about the pressure at the tip of the valve. It's as if I gave you a box that weighed 50 kilos and said, carry it up 20 steps of stairs. I can calculate the amount of work you do. Now take 5 steps back and get some height recovery. You don't get any work back. You've already done your work. So don't misconceive that this idea that pressure recovery somehow lessens the gradient is a misconception. It's not the correct physics.
I agree about your opinion in the native valve, but I don't agree about that in the surgical or TAVR valve.
No, it's just physics. It's just physics in both valves.
Pressure gradient is derived from the modified Bernoulli equation. It's modified, simplified. That has more, problems in the measuring of the pressure gradient. So I don't want to say pressure recovery is all the things, but we need to consider about all the measuring parameters, and we need to understand some limitation of our Doppler-derived measurement.
Yeah. Okay, which is why I think we should do Doppler velocity index instead of gradients, because that's what really matters.
Yeah, absolutely. I 100% agree. And Professor Hong, he's an echo specialist, and the current PPM definition is mainly based on the echo, the measured EOA, but absolutely, I 100% agree. And the echo just measure flow, not pressure. And the flow is very, very dependent on the several factors. Also, inherent design of a Saffian valve much induced flow disturbance compared to the envelope valve. There is also impact on the flow. And so, and contemporary Bach 2 and 3 and use the measured EOA by echo. But I think in terms of true pathologic impact of the PPM, it could be concerned in the small annulus, but the moderate and bigger size annulus, it doesn't matter. Yeah.
Type it out.
Okay.
We will go back to the Shanghai Zhousai Hospital for their case.
可以。
中山医院里面这边可以开始了。
好的，我们给大家看看，因为我们放了2个夹子，在这个后隔交界以及前后交界的位置，把整个这个半环给它缩小了，然后 周长跟面积跟隔侧镜都小了，所以我想请我们的新超的孔德宏教授给大家把超声的图像结果我们做完了，这个给大家展示一下。好。
尊敬的各位专家老师，这是我们2个夹子放好以后，这个四腔芯，然后我们看彩色，彩色的话，现在我们看到这个彩色反流速的宽度是比术前是明显的缩短了，然后面积也是缩小的，然后我们看看其他的角度，
做一个 compare 前后的一个。
好的，前面的我们拉的前面有一个。我们看看术前的一个，这是术前的0度的反流。然后我们把这个放在这里，对吧？
对。
放在这里啊，实时比较。然后我们现在的0度。这是我们术前，左边是术前。对，是的，这是我们术前跟术后的0度的一个彩色的反流情况比较，就跟术前的相比，我们2个夹子放好以后，这个反流的量还是有一个比较明显的减少的。
然后再看那个流入流出道。
好的，我们再看流入流出道这个，我们再实时比较啊。这是我们在60度一个，64度一个流入流出道切面。这个是术前术后的彩色反流情况的比较，也是有一个比较明显的减少，反流速的长度和宽度还是比术前有减小的。
这应该是后格的位置，是吗？
对。前后格比较靠后了，这个，靠前的就不明显了，靠前的没有明显反流了。
对，靠前侧就没有太明显的反流了，然后后格呢，因为隔瓣还有一些栓系，所以它这个地方还有一点。那我们再看一下三维的图像。
好的。
术后3维的。
好，我们把这个去掉，术后的3维，我们来看这个术后的3维。这是我们术后的3维，可以看到2个夹子，然后我们彩色也可以加一下。我们可以看到来自瓣口的一个反流，还是比术前有明显的减少的。整个来说就是反流的方向，基本上集中于后格这个区域了。
好的，我们再看一看那个前后瓣环的周长、直径跟那个隔侧镜的一些变化。
好的，那我们先回顾一下这个术前的一个测量的情况。术前的测量，我们来找一下。这是一个术前的图像，然后术前的测量结果是，这个是面积。周长是14，面积是14.2。那我们再看一下这个术后的测量。术后的测量，稍等，在这个地方。这是我们术后的一个3维的图像，我们把它冻结了以后去测量这个瓣环。这边有个，
对，
我们测了不同的心动周期的一个实像的，然后，
后面的那个图，刚刚
后面，对，它基本上是在11左右的一个面积，周长11左右的一个周长。10的一个面积，
好的，那个基本上是按照我们之前的一个策略，我们这个进行了处理呢，就是在后格的位置跟前后交界的位置呢，各放了一个夹子，这样我们缩小了整个半环的面积跟周长，也减少了隔射镜。然后我们也可以看得到它的反流呢，从这个5个加下降到现在大概轻中度这样一个水平。冠脉呢，我们也做了术后的一个 IVUS 的一个检查，在我们的这个后三叉的位置呢，后三叉开口的位置呢，右冠稍微有一点点扭曲，并且呢有一点点原来是圆的管腔，现在有一点点这个椭圆形的管腔。那管腔的面积呢，稍微影响了一点点，原来管腔的这个面积大概在3.9，现在在3.6这样子。那整体来说呢，不影响冠脉的血流。这就是我们的那个整个的手术的结果跟情况。各位会场的专家，谢谢。
非常谢谢这个教授带领的这周三的团队啊。在座的有没有其他要问的？好，那谢谢葛教授。好。Thank you everybody to participate this section. We will move to next topic, keynote lecture. Okay.
And this is the keynote lecture TABA 2. I'm co-moderator and with Dr. Ng and Dr. Shai and me and Dr. Lee. And we are invited the participating expert panel and Dr. Lin and Dr. K and Dr. Lin. So and this session you're gonna start and Dr. Ng and feature the lecture about the valve choice of a first-time TAVR and consideration of a risk frame. And Dr. Ng.
Thank you, Dr. Park, for introducing me. My talk today is to discuss considerations for optimal device selection in TAVR. As we know, TAVR has become the mainstream treatment for younger patients, so we have to think about the second intervention if the first THV failed. Currently, there are many THV available on the market. All existing valve designs have inherited strengths and weakness. So there are several key points on consideration for optimal device selection in TAVR. We should weigh pros and cons of valve design to anatomy of the patient and the clinical outcomes. Firstly, hemodynamic function. As mentioned earlier, hemodynamic parameters, including pressure gradient, EOA, PVL, differ among devices. Of the currently available devices, it is shown that SEV has the best hemodynamic performance. Hemodynamic function of the paralytics have also been improved during the past few years, with newer degeneration transcatheter heart valve with outer skirt, the severe paralytics have been reduced to a single digit. Regarding the annular size, as mentioned earlier in last session, SMART trial 2-year outcome showing that there has been no clinical significant difference. However, the performance of SEV is much better than the BEV. In small annuli, SEV may result in superior hemodynamics and avoid PPM, although a composite clinical outcome was similar. Regarding PPM, we have discussed a lot in previous session. My concern is just the severe one. And as you mentioned before, the severe PPM actually is not that much in Asian populations. On the contrary, in very large annuli, TAVR devices have been used beyond manufacturer recommendations. That means for extremely large annuli, you can use both self-expanding or balloon expandable valve to achieve by oversizing and aggressive post-dilatation. We also have to think about the aortic valve and aortic root calcification. While TAVR device require leaflet calcification to anchor, but in patients with significant annular or LVOT calcification, TAVR may result in significant paralysis. This is an extreme case with heavy calcification, bicuspid aorta, and LVOT nodule. So in this patient, the pre-dilatation is showing that we cannot move the calcium at all. So we choose to undersize the valve. After implantation of the valve, even with post-dilatation, we still have significant paralysis because of the two holes just beside the calcium, the chunk of calcium. So after that, 7 months later, the patient came back with a heart failure because of the severe paralysis. So we have to put two occluders to seal the leaks. In patients with heavy calcification, if you use a balloon expandable valve, too aggressive post-dilatation will result in dissection of the coronary arteries and even annular rupture. So for those patients without aortic root calcification, there has nothing to, no calcium to anchor. So in this case, maybe a dedicated valve to grasp the leaflet so as to anchor, provide an anchor mechanism for the valve would be a better option. That means you may choose Yana valve or J valve in this scenario. Regarding vascular access and the vascular complication, with newer generation valve, the profile has been much lower. So the incidence of vascular access complication have been remarkably reduced. So it seems that no matter which valve you choose, the vascular complication can be under control. Even you have an unfavorable iliofemoral anatomy, you can try internal endocondyle or even use intravascular lithotripsy to treat the iliofemoral disease, and then pass a large bore catheter for implantation of the valve. Otherwise, you may choose alternative access, which can also be handled easily by experienced team. Regarding the conduction disturbance, two major factors, that is oversizing and the implantation death, matters. So in this scenario, if you want to reduce conduction abnormality, you may choose balloon expandable valve, M high, and you can also use a cusp overlap technique to implant a self-expanding valve to achieve a single-digit post-procedure pacemaker implantation rate. Coronary access is always an issue, no matter in native valve TAVR or in reduced TAVR or TAVR in TAVR. or TAVR in SAVR. Coronary access and the risk of obstruction is an Achilles heel for self-expanding valve in the past. However, with the newer generation FX Plus, as you can see, the coronary access will be much easier. If you use the commission alignment, not cast overlap technique, commission alignment technique, you can reduce the instance of commission misalignment to a single digit. For valve-in-valve TAVR in surgical, failed surgical bioprosthesis or redo TAVR, I think the most important is to address the coronary issue and the hemodynamic. In valve-in-valve TAVR and the redo TAVR, the mechanism of coronary risk is coronary occlusion or sinus sequestration. For first TAVR in native valve, the series curve height or the leaflet length determine the risk. In TAVR in SAVR, the incidence of coronary occlusion is much higher in those valves with external mounted leaflet. And for redo TAVR, the new skirt after implantation of the second valve determine the risk of coronary. As you can see, the outer external mounted leaflet will occlude the coronary arteries if the sinus is shallow, and in redo TAVR, the new skirt matters. So the coronary risk can be estimated pre-procedurally by CT. For VIV classification, you can determine the risk for TAVR in SAVR, and with another classification which is similar, you can evaluate or predict the risk of coronary obstruction after redo TAVR. So if the risk was really high, that means you have a low coronary takeoff in a very shallow and narrow SOV or STJ, then you may consider leaflet modification, coronary protection, or even surgical explant. This is also the combination of valve matters. This is a combination of toe-in-toe. And as you can see, the patient has commission misalignment, and the valve was put too high. So after the TAVR in TAVR, it is almost impossible to reaccess the coronary artery. In this regard, you can see a short combination will be much friendly to coronary reaccess. Now, more than 75% of the cases can recanalize the coronary artery easily. So we recommend not to use a toe-in-toe combination for redo TAVR, because up to 23% you will get a sinus sequestration, and up to 78% you cannot canalize the coronary afterward. If you do have a high coronary risk, you may try leaflet modifications such as Basilica procedure, as shown in this case. And in valve-in-valve TAVR in SAVR scenario, we also know that a small surgical annuli will compromise the long-term outcome. So in this situation, you should do balloon fracture of the surgical valve and then implant a bigger valve. In redo TAVR, different combinations have different hemodynamic performance. As demonstrated in this registry, the patient with a severe PPM after redo TAVR will mostly encounter in patient with a toe-in-short combination. That means if the first TAVR valve was small, even you put the supraannular SEV, the hemodynamic performance was not good. Regarding the bicuspid, I think bicuspid is anatomically challenging aortic valve disease. As shown in the many studies, the asymmetrical calcium distribution and avoid the shape, the opening of the valve, compromise or constrain the implantation of the valve. So sizing is really matters. Our center have developed a waist method. As you can see, we measure the intercommissural distance and the short distance and the average to get average diameters. We then compare that to the annular sizing and choose the smaller one. In this way, we can choose our sizing, the THV, and get a very satisfactory result, no matter balloon expandable or self-expanding device was used. Regarding long-term durability, as demonstrated in the last session, the first session of this meeting, we don't have too much data beyond the 5 to 6 years. In our own experience with a follow-up of more than 7 years with the first generation valve, that means the Sapien XT core valve or Lotus valve, we only seen significant higher instance of bioprosthetic valve failure with a Lotus valve, but the other two were similar. In another registry, they showed that even though the bioprosthetic valve failure was higher in intraannular design, but it was only for the early generation XT valve, not the Sapien 3. So in summary, taking all this into consideration, I think the first valve will be determined by the patient's anatomy and the valve design. You should choose the best one to fit the patient and consider the second intervention. I thank you for your attention.
Thank you very much, Dr. Yin, for your excellent and very comprehensive review of the first time TAVI. A second presentation is going to be covered by Dr. Qingwei Li from Taipei Veteran General Hospital. He is a key member of their structural team with special engagement in intravascular imaging. Dr. Li, please.
Dear Mr. Chairman, ladies and gentlemen, it's a great pleasure to be here. And this is my disclosure. And another important disclosure is that in recent years, I have served as both imager and implanter for the MTA procedure. So I know the conflict and the collaboration between the implanter as well as the imager. So before that, I have to confess that in the past year, I used this beautiful imaging on the left side to do the lecture, so that's why I'm here. But actually, in daily practice, this right side panel, the terrible imaging was also done by myself. I will not blame our fellow. Actually, this is done by myself. But luckily, we have two beautiful, successful results. But I want to emphasize that to optimize the imaging and the procedure, the imager and the implanter should work together, not to blame to each other. I think in all centers, we always work together, right? So I divided my talk into two parts. First is how to get proper imaging and what I have learned in the past years. As we know that the mitral from the 3D EMPHAST view, there are several cutting planes from the rotational angle of the mitral. We have divided to the 4-chamber bicommissure and the LV alpha tract view. And we also know that if we want to treat the medial commissure, we have to adjust our angle to less degree, like 30 to 50 degrees. If we want to lateral commissure, like 70 to 90 degrees. Except for the rotational angle, actually we can manipulate the probe. So if we do the turn the left, if we do the counterclockwise rotation, you can imagine that the T-probe is sitting in front of you. If you do the counterclockwise rotation, you are seeing to the left side of the structure. If you are turning your probe to the right, you are looking at the right side of the structure. So it's totally upside down from the CT. So usually I will, in recent years, I look at the CT more and more oftenly. And if we have the CT image in my mind, and I can think about how to rotate my probe to the region I'm interested. And also, we know that the lateral commissure actually is in the superior part of the heart, and the medial commissure is a little bit inferior. So even though it's like 0 degree, but if we pull our probe upward, and you will look at the lateral segment, if we advance our probe, it will move to the medial segments. We can also do the anti-flexion as well as the retroflexion. Usually we will use the retroflexion to bring the probe just on top of the mitral valve. But sometimes when we have a difficult imaging and a lot of metallic shadowing, we can view the mitral valve, we can advance our probe and do some anti-flexion to get rid of the metallic artifact from the valve. Okay, so except for that, actually the 2022, there is a JAS expert consensus suggests that you may also use the small wheel that will bring the probe to the right lateral flexion. You can see from the upper panel, if you do the right lateral flexion, you bring the TOE probe to the top of the left atrium. So you can see just on axis on top of the mitral valve. But in fact, in daily practice, I seldom do this kind of manipulation, especially when you lock the probe and you want to advance and withdraw, actually will cause a lot of injury. So it's always the relationship between the esophagus and the heart. So instead of do the right lateral flexion, you can also tilt the table to the left side, you will bring the heart to the left. So you will also can achieve this kind of effect. So this is a very illustrative publication from our Japanese colleague, and they found after they have consecutively 2 cases after MTA procedure, the patient had got severe chest pain in the ICU, and they do the CT scan and found the aortic dissection, type B aortic dissection. So what is the cause for that? Actually, you can see from the X-ray, you will see the excessive retroflexion. And when you push up and down, actually the relationship between the esophagus and the aorta is so close. So it will cause the aortic dissection by this way. And this is the patient we treated. The echo is done by myself. So you will see the scratch of the esophagus. I think it's quite inevitable, but we just try to minimize any damage, even though I think I'm very careful, but still may cause some damage. So by this kind of maneuver, how to improve this full chamber view to the right side? We see the aortic valve, so we know that we are a little bit higher. We have to insert the probe more, and we see a lot of right side structure, but we don't really interested of. So we have to do the left side structure. We counterclockwise rotate the probe, and we do some retroflexion. We can bring up the imaging like this. So how to improve this bicommissure view? And we know that we see too much left side structure. We have to see the right side. And we want to see a medial part. So we know that we have to advance the probe and do some clockwise rotation and do the retroflexion. We can bring the imaging like this. And is this image good? How to improve it? That's a very, actually this image is quite good. We see the leaflet, we see the clip arm, and we see the leaflet sitting well on the clip. But be practical, actually we do the explain through that. We have to understand that if we are not parallel to our device, then the leaflet is not exactly sitting well on the clip arm. We are cutting through a little bit lateral to the clip arm. So we can use that kind of maneuver. We inserted the probe and do some, to see more medial segments. So we need to see the right side structure. We do a clockwise rotation, and we inserted the probe, and now we can see the 4 segments, including the anterior leaflet, posterior leaflet, as well as the clip arm, and the sitting quite well. And that's also a tricky one. If we have this kind, sometimes when we have a dedicated imager, we're definitely not happy with this image, because there are so many artifacts. Not a good image. You have to do something to adjust that. But actually for implanter per se, that is a quite perfect image. I can deploy the valve. You see the leaflet is quite restricted well. And that's the difference between the image perspective, but as well as the implanter perspective. Because the imager always try to optimize everything. But actually, everything is not so important. You don't really care about the lateral artifact. You don't really care about the medial artifact. You just care about the leaflet inside. So don't be too obsessive with the image other than procedure per se. Another important thing is from the implanter perspective. You don't really want to advance a lot of your device inside the left atrium, do some M and do a lot of manipulation of the knob, because it will have a lot of metallic artifact. So during the peri-procedure imaging, I think it's very important to have integrated. So just like I mentioned before, I always check the CT in recent years, and as an implanter as well as the imager. Because CT can tell you a lot of things, to give you a spatial relationship, like a roadmap. When you visit CT, you always have a roadmap inside. So just like a giant left atrium, you know that you want to do the transeptal puncture, you have to clockwise more, like 8 o'clock, rather than the regular case for 5 or 6 o'clock. So I will always check the atrial septum relationship, and also the mitral annulus. If the mitral annulus is like vertical, you don't really need to do a lot of retroflexion as well. So actually, this is the imaging acquired from another experienced imager from our hospital, and she asked me how to improve the imaging. I think she already know everything, so there's nothing I can teach her. So I recheck the CT. You will see lots of artifacts within the medial segment. So if you see from the CT, this is the CT done just 2 days prior, and you will see the esophagus is located at like this location. So you will always look at artifact, especially from the lung, and very difficult to image in the medial segments. So the additional value for CT is to understand, especially when you have a challenging imaging issue. And another important thing is to understand that when we put down, why we tend to puncture at the mid to the inferior fossa, because the superior fossa is not only superior but also anterior. So you will probably have aortic hugging. So this is the concept we can learn from the CT imaging. Why inferior? Because there's a lot of will increase the length of septal length. So that's why when you puncture at the inferior part, you can have more posterior projection. So this is in the old days, we puncture at the very superior renal fossa, even though we think it is very, very posterior. But when we advance the device, it is aortic hugging. It's quite illustrated well from the 3D imaging. Another important thing is when we treat atrial secondary mitral regurgitation, why we always try to puncture very, very inferior. You can also learn from the CT imaging. Even though you puncture at the same level, but if you puncture superior, it will go a lot of distance between the interatrial septum to the mitral leaflets. But if you pull a little bit downward, and you will not get the aortic hugging. And we also learn from the simplified transeptal puncture image workflow. In old days, we used the bicavo and check mid or inferior fossa, and we turn to short axis to check the anterior, posterior, and we turn to 0 degree. It takes a lot of time, and you know the IC usually doesn't have a lot of patient. So we simplify with the bicavo view, we find the tension, and we direct go to the 90 degrees and cut through that, and you will see the mitral leaflet. Mitral annulus is usually at this level, and we can direct do the measurement. So just a single one stop. And sometimes you just can't get rid of the aorta, and you can try to 160. Actually, it's like negative 20 degrees, so you can use the 160 degrees. And always, when I do the implanter, I always make my transeptal needle anteriorly. Because when you when you pull down and you make your transeptal needle anteriorly, the imager is very easy to find the tentin. And then you go, when you find the tentin, and then you go posterior. Never go too fast. The implanter should let the imager find you, and then you do the next step. Find the tentin first, and then you clockwise rotate it. Not just see two drop, and then you directly go to the lateral, to the posterior. Because when the tentin is like here, it's the imager very, very difficult to find you. Okay. So another is the perpendicularity check. I always find a good aligned bicommissure view and get the proper size, thickness, and a little bit close to the valve, and then you will get a perpendicularity check. And all days we use the 12 o'clock for the Ultivalve, but we know that Ultivalve is not always located at the 12 o'clock. So we use commissure more oftenly. For this image, actually you see, even though the alta is the 12 o'clock, but you see the lateral commissure very clearly, but medial commissure is not so clear. So what we have to do is to make the unforced view, like roll the curve ball to the right, and you will show the medial commissure more clearly. And the grasping is always before the leaflet insertion, so just make sure the tip is within the clip arm. We must record this image very, very clearly. And you will see, this is we have 2 single leaflet detachment for the mitral position for the prior 250 cases. So this is one of the case we suffer from single leaflet detachment. But luckily we record everything. So we retrospectively examine why this happened, because you can see the posterior leaflet is curved. It's curved. So it's not flat. So that's why we only catch a bit of the PML. So that's why the single leaflet detachment occurred. Just record everything. And because of the time limits, I just want to show the final is check the leaflet insertion. In old days, we would do some mathematic measurement, but nowadays we tend to image the doesn't move. Okay, nowadays we just do the explant through the medial and lateral side of the clip to directly see the leaflet inside the clip arm and direct the major. That would be better than do the mathematical job. And also the power of NPR is quite important. Sorry, but this doesn't move. Okay. So, ladies and gentlemen, the summary is to get the proper imaging is to keep 3D mitral valve in mind and do retroflexion. Usually, you go to clockwise rotation of the probe to see the right side of the structure, and transeptal puncture, and see the tip of leaflets before closing. And I think CT reading is quite helpful. NPR is powerful, but sometimes implanter who does not know the image well, it always say, NPR, when they have a poor 2D image, they say NPR for NPR. But actually, if you don't get clear 2D image, NPR is like trash. So thanks for your attention.
Okay, and we introduced the last speaker, and Dr. Watson, and it's about the TAVI in the small annulus.
Thank you, the organizer of the Taipei Valve 2025 for inviting me and for the introduction. My topic has been touched upon and discussed extensively many times throughout the whole morning. So I'll see what I can put my own perspective into this. Okay, TAVI in small annulus, this is my disclosure. So what defines small annulus? Actually, there's no clear consensus what should be called small annulus. On the right-hand side is one good review paper that summarizes all the article that touch upon what should be called small annulus, and it could be from the surgical era. Bioprosthetic size has been used to call small. And the echo measurement of the annulus, perimeter, and the area. Now the area, the one that most commonly used is 430 or less, will be called a small annulus. But actually, we don't actually know what should be called small annulus. And if you look at our population, the 430 was from the Western world, and anything below the mean was called small. But for us, the mean is only 400. So, and that's one of the reasons why in the era of TAVI, the impact of severe PPM, we didn't see it as much as the surgical era. And then there are people with a very, very small annulus, you know, and there's paper that call them very small, extra small, tiny. I didn't make it up. This is real. And the cutoff could be anywhere from 400, 385, 300, and 280. And this is extremely small, okay? So small annulus account for about 1/3 of the patients that are coming to us, whether it's surgery or TAVI. And it's much more prevalent in female and Asian. And it's not just a small annulus. A small annulus is associated with other bad things. For example, they usually have higher SCS score, lower body surface area, higher comorbidity, for example, diabetes, obesity, CKD, and atrial fibrillation. And sometimes they have other things small as well, like the SOV, the STJ, the low coronary height, and small vascular access. And all these make it more difficult to do TAVI in this patient. In the surgical era, it was well documented that severe PPM happened a lot with small annulus because the surgical valve make it much smaller than the native annulus, and associated with bioprosthetic valve failure and also increased mortality. But in the TAVI, the impact of PPM is less. And whether it's the same for balloon expandable or self-expandable, that remains to be seen. So if you have other things small, like the SOV, STJ, and the coronary height, small access, there are potential complications that comes with it. You know, not to mention the PPM that we've talked about all morning long. You have higher risk of coronary occlusion. You have higher risk of annular rupture, especially with balloon expandable. PPM we talked about, and vascular complication. Now, back in the days we started TAVI, this is from the partner 1 cohort A. Small annulus was defined as less than 18 millimeter. And you can see a drastic difference between TAVI and surgery. You get a much better outcome with TAVI, even way back then. Okay. This is mortality. And people talked about stainless surgical bioprosthetic valve, which theoretically should give you a better EOA. But for a small annulus, you still have a much higher severe PPM compared to TAVI in red. Okay. For a larger annulus, that's not much different between the stainless bioprosthesis and the TAVI or transcatheter valve. Now, the randomized control trial comparing surgery and TAVI in small annulus called the VIVA trial. The annulus is less than 23 mm. The clinical outcome, whether it's death, stroke, hospitalization for cardiac cause, or the combination, are not different between surgery and TAVI, including hemodynamic outcome as well. Now, for prospective randomized control trial, everybody tried to do a good job. You know, that's why it's difficult to see the difference between the two methods. That's what I thought. And you saw this many times. Even in the TAVI era, we still see severe PPM from the TVT registry. And the strongest predictor of severe PPM is valve size less than or equal than 23. Valve in valve, female, and large body surface area. So in our practice at our hospital, when the analysis turns out that you either need a SAPIEN 23 or the Evolute or self-expanding 26. We usually go for a larger self-expandable if there's no other prohibitive factor. And then we started to see some difference between the balloon expandable and all these self-expandable in terms of ppm in the TAVI era. But despite that, we see the clinical outcome that is not so much different. Although severe ppm is related to higher all-cause mortality, and small annulus also a predictor of severe ppm, the clinical outcome hasn't been shown to be much different. And hence this SMART trial we've listened to many times. I think part of the problem with the SMART trial is that the cutoff is 430. So for us, in our practice, 430 is not that small. Okay, but regardless, we should look at the result with some perspective. It's confirmed that small annulus belongs to female, and the SMART trial, the average area is 380. As you can see, the two co-primary endpoints, the clinical outcome are not different between the two platforms. But the performance of the valve, you have bioprosthetic valve dysfunction much lower in the self-expandable valve compared with the balloon expandable. The other performance in terms of valve performance, the mean gradient at 12 months, EOA, hemodynamic structural valve deterioration or dysfunction at 12 months in female, and also moderate or severe ppm, is better with self-expandable. If you look at this only severe mismatch, WARC3 definition is only 3% in the Evolute arm, and it's almost 10% in the SAPIEN arm. If you look at the so many definition of bioprosthetic valve dysfunction or hemodynamic structural valve deterioration, whether ESC definition, WARC3, or the SMART trial definition, it's the same, that the supraannular self-expanding valve perform better. Now, the 2 years data was just presented recently, and it's aligned with the 1 year data. The clinical outcome is still the same, not different, and each individual component is also still the same, no different. And the performance of the valves also still favor Evolute compared to the SAPIEN valve, and it mostly belongs to the hemodynamic structural valve deterioration and non-structural valve deterioration, which is either the mismatch or the paraleak. Hemodynamic data, EOA and mean gradients remain unchanged from 1 year to 2 years. The mean gradient above 20, so it's still higher with the SAPIEN valve, and also the Doppler velocity index is different. Now, after the SMART trial came out, there are, at about the same time, there are several retrospective data from big registry. On the left is the Bern TAVI registry. On the right is the OPERA TAVI registry. Pretty much the same outcome. The clinical outcome not different for both registry, but the valve performance is different and favor self-expandable. Now, even the latest generation of both platform, the FX and the SAPIEN 3 Resilia, you see that the valve performance is a little closer or less different than the previous generation, but still same direction. The P grade more than 20 still favor balloon expandable. The leaks favor, the gradient favor self-expandable, and the leak favor balloon expandable. And the clinical outcome is not different. Now, the partner people went back and looked at the partner 3 and the partner 2's S3 subgroup and compare small annuli versus large annuli. And the finding is that there's no different whether it's a valve performance or the clinical endpoint. Trying to say that what we see in the SMART trial may or may not be true. Okay. Another single-center retrospective observation study looking at the balloon expandable from S3 to S3 Resilia between a small and large annuli. There's no difference between the small and the big. Now, except for the mean gradient more than 20. Now, if you look at the PPM, the small annulus has greater percentage of moderate and severe PPM. And the other thing I want to point out is that the number are very big. If you remember the number from the SMART trial, the small annulus, the moderate is not 39%, and the severe is not 8%, it's only 3%. So this is compared between big and small. So you just have to be aware of that. Two quick cases. This is a very young lady, unfortunately had to have radiation-induced heart disease, poor EF, and a thick everything, thick valve, thick myocardium. She had a very small annulus, area of 298, perimeter of 63. So this would fit either S3 of 20 and Evolut 29 of 23. But her SOV is also very small, too small for the Evolut 23. And the STJ is about the same size as the annulus. And the height is also not very high. It's 13 mm and 12 mm. Coring height is also less than 1 centimeter. So we elected to use the valve that's no longer available now because we think it's probably occupy less in least in the SOV and can accommodate the low coring height. And we got a pretty good result with no gradient and no leak. We're not going to know the long-term outcome yet. Now, the other patient, this is elderly. She had coronary disease and also severe AS, but it was surgical turned down because of the porcelain aorta. And her anatomy is also small everything as well. Like the area is 266, perimeter of 58. This is smaller than a lowest cutoff for any THV available in the market. Okay, and the SOV is also small. Small for the smallest self-expandable. The STJ is also almost circumferentially calcified and is smaller than the annulus. And the coring height and the STJ height is also not high. So if we put a SAPIEN 20, we have to take out a few cc's. But the balloon's also like borderline too long, and it potentially can damage the STJ. The valve itself also, if we take out a few cc, will be taller. But we have no other choice because the self-expandable will not optimally expand. So we put the S320 minus 2 cc coring protection with guide liner and stent. We mount the valve relatively towards the aortic side, and also we do a two-step deployment. The second inflation will be on the ventricular side, try to avoid damaging the STJ. So this is the deployment, and immediately after deployment, the blood pressure dropped. Contractility went down, so we pulled the stent back right away within a few minutes, inflated, and got the blood pressure back. And yeah, this leak looked to be more than it is, but it's mild on the echo, and the gradient is 5, which is considerably better than we anticipated for SAPIEN 20 in a small annulus. So in conclusion, small annulus is common, and maybe one important factor in selection mode of valve replacement, which including TAVI versus surgery, and also type of transcatheter heart valve. The supraannular self-expandable valve allows you to avoid moderate and severe PPM better than bioprosthetic balloon expandable valve, which translate to better intermediate-term hemodynamic outcomes. However, clinical outcome out to 2 to 5 years between the two platforms in the RCT and the large registry are not different. So valve selection based on careful anatomical assessment in patients with small annulus helps you avoid inherited complications that comes with it, which probably had to be considered first to get the procedure done safely. But long-term durability data comparing the different platforms are still not known. Thank you very much.
Thank you very much for watching. And we have before lunch, we're gonna have some discussion, short discussion time. And any question or comment for the lecturer?
Thank you. I would like to raise a question, consider the risk plan, and consider the possibility of the future TAVR in TAVR. And from the perspective of leaflet modification and a little bit shorter life expectancy in the patient with valvular heart disease, does anyone or Professor Yin still thinking that the risk plan is still a major concern when we considering the first TAVR valve? I'm just wondering everyone's opinion.
In our case, and the risk frame, coronary risk frame, we usually consider relatively young patients and the age in the early 70 and the late 60, and we consider risk frame. So, and in the elderly age, more than 80, it doesn't matter usually, and with the patients that doesn't require and the future coronary intervention. But in the young age, and we consider coronary risk frame, and then also expect in the 5 or 7 years later, and if you're gonna redo TAVR intervention, what are risks? And so, as you mentioned, in the relatively young age, the risk of coronary reaccess and the coronary plane could be some important factor for the valve decision making.
I mean, even in the young patients, but we can do the leaflet modification, even we got a very high coronary risk plan. So I mean that even in young patients, if we can do the leaflet modification, even we have some commercialized leaflet modification devices in the future, so it's still a major concern for the risk plan to choose the first valve.
Yeah, and frankly speaking, and currently, and the leaflet modification and I forgot the techniques. That is not easy compared the cut the wire cutting, and Basilica technique is not user friendly.
Basilica or Unicorn.
Yeah. But it's I know in the U.S. the shortcut is available in the sooner, and but it's one of the problem is the cost is very expensive, more than $20,000 in the shortcut. So. And I think if the leaflet modification technique is a much easier and a much wider application, and the valve selection is not much matter, but still until and before that, and I think we must consider the reason why Basilica technique is not user friendly and the shortcut is not widely applicable in the diverse country.
Can I raise one? My question is regarding the bicuspid LT valve with stenosis and calcium chunk, large calcium chunk, and what would you to do now after these clinical trials come out? Would you send these patients to surgeries, or you treat them with the TAVR? And in terms of TAVR, what kind of valve would you use? Would you like to tell us the Korean view?
Yeah, absolutely. This is a very important factor to decide the valve selection, and the calcium chunk, for instance, calcium, the amount more than 2,000, and that is a very difficult case, and relatively young patient, and we try to send the surgery, but this elderly patient sometimes combining very severe calcium chunk at that time, in terms of valve selection, we much prefer the Sapien valve. But the reason why, if you put the Evolut system, it doesn't expand it well. Even though put the valve, it does not expand it well, and the very eccentric the configuration and very severe PVL. So based on our experience, we much prefer Sapien valve, but it's a very careful in the sizing. We just usually in the normal anatomy, and we are try to the sizing is a 5%, 10% oversizing. But it's if patient is combining very severe calcium chunk, we try to the 0% or sometimes undersizing. Yes.
Thank you.
Although in smart trial, we can see very good result of the TAVR in both the balloon expandable and self-expandable, although they have some hemodynamic variation, but in a result outcome, they have no difference. But in Asian population, many of our patients are classified as the small artery root, and if they, especially in some small old lady, so like in Korea, do you this is any special consideration for this kind of low risk and with small annulus patient?
I think I'd like some comment, and then the watching also is for the comment. So, and we are adapted some smart trial, small annulus, for instance, and the patient is suitable Sapien valve 23 or 26, 29. Is for instance 23 is suitable. It's okay. We are put this 23, but patient would be indicated Sapien valve 20. But we can put the Evolut 23, much bigger size, sometimes 26. Is a very small case. We are much prefer the Evolut system rather than the Sapien. But it's a patient can be treated well. The Sapien 323 that is okay. We have put the Sapien 323. Some, adapted some part of the smart trial. Okay.
Hello. Okay. In the SMART trial, the clinical outcome is probably the duration observation has to be longer. Like at least 5 years, I think. We have to wait. And also, the cutoff of 430 may not be the right cutoff. I think the annulus that is small enough to cause problem with severe PPM has to be a lot smaller than 430 square millimeter. For example, in the surgical era, the surgical bioprosthetic that caused severe PPM had an internal diameter of very small, like 17, 18, 19. In the TAVI era, even with the smallest balloon expandable, these days the internal orifice area is bigger than before. So we didn't see a lot of PPM as much, and so that's what I think happening. Unless we see people with very or extra small, like I said, very small PPM, and that's when we prefer balloon self-expandable supraannular. So in general, at our hospital, if we end up with balloon expandable 23, we kind of hesitated, but not shied away completely. But 20 is something that we try to avoid and go with self-expandable bigger ones if there's no other contraindication.
Okay. Okay. Time is up, and we have some lunch time. It's a short comment. Okay.
I think that for small anatomy, the most important one is the coronary artery problem. So that's, I think now the two companies did not have any solution for low coronary artery or small STJ. that maybe in the future we have the limited multiplication over cut can do in the small areas, so that we can do implant a larger valve. I think that's compared to the surgical one. I think that's a limited multiplication is very important in the future.
So, and because of time, you're gonna finish this session. Okay, thank you.
Following a thought-provoking and intense discussion this morning, so it's time to turn theory into practice. So I'm sure you are all looking forward to seeing how these techniques are applied in the real world. So now we will begin our live demonstration session. So let us welcome our esteemed moderator to the stage, Dr. Cao Dianping, Dr. Nathawood Wongpraparut from Thailand, Mahidol University, Dr. Wang Qihong, and our dear friend, Dr. Michael Lee. So let's give them a warm round of applause.
Hi, Dr. Yin.
Hi.
Okay, can you start your case, the presentation first?
Okay, dear friend, today we will demonstrate the treatment of aortic valve involved case. Together with me will be Dr. Lin Huan Jiu, our chief technician, Ms. Xu, and our best assistant, Liao Jialin. 还有 Dr. Cai Jiaru, who prepared the vascular access today. Okay. Well, please. Yes. And Dr. Liu, our image specialist. Yeah.
So, thank you, dear, all dear expert. Today's in the afternoon, a live educational case is an 84 years old gentleman who suffered from dyspnea insertion and bilateral lower legs edema for several months. He has history with severe aortic regurgitation and underwent aortic valve replacement with a Paramount Magna 25mm valve and also concomitant CABG in 2013. And now he has diagnosed with prosthetic aortic valve regurgitation. His comorbidity, including triple vessel coronary artery disease and also gallstone and intrahepatic stone. His SDS score is 6.5 and his creatinine level was normal. So next, please. Through the transthoracic echocardiography, you can discover that his LV ejection fraction was preserved, which is 56%. The prosthetic aortic valve leaflet was tear and with a significant prosthetic aortic regurgitation. The mitral valve function was preserved, and there's also mild tricuspid regurgitation without pulmonary hypertension. Next. So through the multi-slide CT analysis, this is a 25mm Magna. The sinus valsalva was quite huge. The diameter is around 41 to 43. The inner diameter of the Paramount Magna 25 through the CT analysis is around 22.4, and the area is 389mm square. Next, please. Because the patient has underwent CABG several years ago, so there's no risk of coronary obstruction during this aortic valve involved procedure. And also, if we want to measure the valve to coronary distance, it's quite huge for this patient because of the aortic ataxia change. And next, please. So according to the valve involved at the Magna 25, the true ID is around 23, and the valve height is 17. So if we like to break this valve, the true balloon size will be 26. However, if we don't do the balloon valvular fracture for this patient won't suffer from the patient prosthesis mismatch, even we put the 26mm valvular FX for this patient. So in this case, we won't do the bioprosthetic valve fracture for this patient. Next, please. The peripheral access both sides was quite normal. There was no significant calcification or tortuosity. However, through the 3D reconstruction of the aorta, we can see this patient has a significant horizontal aorta. So this will be the difficult point during this case. Next, please. So our plan to do, we would like to use the main access through right common femoral artery, and we will put a cerebral embolic protection device for this patient due to the aortic valve involved procedure, where we won't do the predilatation because of the valvular aortic regurgitation. So the valve we choose will be a Evolut FX26, and the ideal implantation depth is around 3mm. Thank you.
Okay, then I would like to ask the opinion from the panelists.
Anyone want to have comments? So I think this is a great case for the valve involved demonstration. I think the patient have the previous bypass, previous AVR, and I think I think very important that we need to identify which valve and then try to size defined by the valve app. Some issue about horizontal aorta, but I think otherwise risk of crude obstruction because previous bypass is low. So I think you have all the valve choice that you can use. Any opinion from any panels? Which I think on the list from the valve in valve app, you can use Evolut, you can use Sapien, you can use accurate any valve and any particular valve.
I think valve-wise, it is suitable for both balloon expandable and self-expanding. Since I saw the cerebral protection device, I just want to comment. For this particular valve-in-valve cases, although you will see that all the trials with the cerebral protection device have been negative so far, but this is one of the indications that I would definitely use a cerebral protection device for valve-in-valve. So I think it is very justifiable to use a sentinel embolic protection device for this particular patient.
I think at Sirat Hospital for bicuspid and for valve-in-valve, we always put the sentinel device.
I also had a comment for the cerebral protection device. It's not routine use, it was the recommendation, but for a special case, I think the cerebral protection is needed.
What is the patient baseline EKG? Any risk for the, I know that you're going to put the valve very high at 3 mm, but any baseline conduction abnormality that we would put?
We aim to 3 mm, yeah. But regarding the cerebral protection, in our center, we have analyzed the debris captured by the device and the same for the pathology. And we found that the most abundant tissues were valve tissue. The second was thrombosis. So I think for this kind of patient with degenerative surgical valve, we don't really much certain about the mechanism, but the patient has severe aortic regurgitation. So I think some of the tissue, valve tissue will be fragile. So if we want to use a self-expanding valve, we should be very cautious because we may need to resheath or reposition, and this may dislodge some debris.
Yes, since you mentioned about fracturing of the valve, can I ask the reason why fracturing is not needed in this case again? I can't really hear the reason.
Because we don't have 26 non-alone.
Oh.
Can you send us some of them? then we can do it.
but I would think, as we discussed this morning, the PPM is very important. So I think if the patient risk for PPM, I think you need to do whatever you could, like valve fracture. But I think we're not routine fracture the valve as well. If the patient, when we calculate the predicted EOA to the patient BSA, if it's not risk to any PPM, I think we just routinely just put the valve.
The other way is
measure the invasive gradient.
We implant the valve first, self-expanding, and then look at the gradient.
Yeah,
if the residual gradient is still significant, more than 10, maybe.
Exactly.
Then we fracture.
Yeah, I think it's very
we
important.
also can do the valve remodeling. So use probably use a 25 mm balloon to do the valve remodeling. No need to break it. Just remodeling it is also good. But for the, I think the Hancock 2 is cannot be can be broken or cannot be remodeling. But the other type of valve, I think is can break or remodeling.
I think back now you can break at I think 20.
Well, I think the things the most important thing we learn from the smart try is that for Oriental people, if you can put a 26 self-expanding valve and make the valve level, the opening circular, with good hemodynamics, we don't need the 29 or bigger valve.
Agree with that.
Is there any interesting point of the T? Can share to us?
Dr. Liu, can you show the T?
Here. On the screen is the lung axis of this patient.
And you can see the pathology of this patient is mainly the processes AR. And we focus on the original, where the AR came from. It seems like at least one of the leaflet is a little bit prolapsed, and the hemodynamic show the AR is the main pathology. And when we do the X-plan, we can see that at least 2 AR jets, one is between the LCC and the left cusp and the N cusp, and one is from the right cusp.
So maybe if there are residual gradient or residual leak, then we definitely will do post dilatation. Maybe with a 24 balloon. Yeah. Okay, let's get started. If there has been no other question.
Another thing I asked initial about conduction abnormality, because if the patient actually have no pre-existing conduction abnormality, and if the implantation depth, maybe not septum length is wide, I think in this case we might be using the pacing to the Y. And then with the Sentinel, I think my colleague also published using the one clip in the Sentinel. I think that will be, so if we don't expect any future heart block. So I think that we'll put in our practice.
Okay.
The valve checks.
The setup of the valve is good. So
this auto is a little bit horizontal, huh?
整个
Quite horizontal.
整个
我们用应该是
哦
看完 Any tip and trick for you for when you do with horizontal, when the
really
self-expandable, how you push and pull?
Yeah, push and pull. That we also try to use snare to adjust the direction of the device. Yeah.
Well, in this particular patient, because the mechanism of failure is regurgitation, we hope that we can cross the valve easily. Okay. Hold wire.
No. Professor, when you deploy the valve, would you position the 3 markers to the sewing ring or the which part of the surgical valve?
You mean the sewing ring?
Yeah.
You know, there are some tissues so below, outside the sewing ring. So usually we put the valve 2 to 3 millimeter deeper than the sewing ring. 进出进去. Okay. Luckily, we can cross the valve. Okay.
You don't use pigtail? There's no pigtail.
Oh, yeah, we do have pigtail.
One benefit with valve.
Actually, I don't really think that we need it.
Previous baptism as a marker. So I think that's make it convenient and less contrast use.
没有什么需要吧
Okay.
But you align, remove the parallax. Okay, we can get started here. As you can see, the head marker is on the greater curvature side. Make sure the commission alignment. Okay. Pacing. 等一下。好。There are 3 dots there, so make sure all the dots are below the sewing ring. 等一下。 还在上面呢。
There is
还没有，
some
等一下，
parallax.
搜一下，搜一下。哎，
Great benefit of Evolute. You can retrieve and deploy multiple times you like to.
Going to be a bit more slippery than the usual native aortic valve. Because there's no
Yes, definitely yes. We don't have calcium. 哎，你还没有搜到底，还没有嘛？来，你可以吗？下去一点。
So when doing the valve involve or multiple restriction, the particle caught by the sentinel are more. Yeah.
Right. Yes.
So, yeah. So.
Sometimes in our center, because of the, if we see horizontal aorta, and then if the valve is big and no issue, I think sometimes we do balloon expandable.
没关
I
系
think that's another option.
它还没有出来。总而言之，3个点要在那个下面。哦，那你出来了以后，你就对3个点。
Yeah, for it. Yeah. You can flex.
We are coming out.
I think it's, we can use the self-expandable, but I think you may have to get some technique to get like.
Okay, facing. Okay, remove the parallax. Okay, hold it. Okay.
Good position.
不要推，不要拉。Stop. Facing up. 照相。OK. 照相。转。Well, I think the position is fine, and the configuration is okay. Do you agree?
Yeah, again, the position is fine. Yeah, after deployment, I think the valve will tilt, and the depth at the LCC side would be decreased.
Yeah, it will have a downward displacement after final release. So please, 140.
140哦，140。
Slowly, slowly. Okay.
Batch.
One by one. Okay.
Very good.
As you can see, you are just
perfect
here.
position. Yeah.
And 3 millimeters below.
More coaxial now and the less depth at the left side.
This is the exact position we want to.
Yes,
be.
yes. Yeah, perfect position. Yeah.
不要推，不要推，往回拉，往回拉，再进去一点，把耳位到那边。对对对对对对。再敲，再推。不行，不行。来，哎。Okay. Yeah, sometimes you will encounter these kind of things.
Yeah. So from this case, I think best pre-deployment position of the valve is good depth at the NCC site and a deeper at the LCC site. And after the deployment, the valve tilt, then the whole depth is just at the right position. Yeah.
Expandable, I think you cannot control much. So I think the main focus is going to be on NCC. Make sure the depth is good, and then I think the valve itself will, because of tension, it will be reduced parallax by itself once you finally deploy.
我整个拿出来了。
对对对。
So how is the T now?
Dr. Liu, can you see the T?
Yes, the long axis shows is a great position of the valve, and I don't see any paravalvular leak using the X-plan swipe and check. But however, at the valve plane, it seems that it's not very circular shape at the valve opening level. So even it's a great position of the valve, but if you want to post dilatation, I think it will be fine.
So Professor Yin,
Yeah.
will you do the post dial?
We measure the gradient first.
Okay.
Or you prefer to do post-dilatation?
Because from the T image, the Dr. Liu suggests the post dilatation.
Okay, we do post-dilatation.
I think the depth, I think, is allow us to do it.
24. We use 24. Two flow.
EKG is good. I don't see any piercing, so I think you.
160也可以，因为 BP 要低一点，因为它就是打的时候不能动。
I would, as everybody mentioned, I think invasive measurement should be done before we leave the lab, because if any residual gradient left, I think we need to take care before leaving the patient out. But on this anatomy, bigger valve size, I think we should not have an issue.
So this is 24, 25, 24?
24.
Okay.
It is a true balloon. Do you use
true balloon?
True balloon, yeah.
True flow. True flow, not a non-compliant, semi-compliant. Okay, pacing on. Gradually, 慢慢打。Inflation. All the way up. 1, 2, 3, 4, 5. Okay, pacing off. 拿好。Okay. 拿好哦。Okay, please follow the echo.
Yes. Yes, Professor Yin. The result is great. The valve is look very circular now.
有。我知道。Okay, give me the pigtail.
Balloon, a perfusion balloon. We saw several small balloons making up a big balloon. So in the middle, it allows blood to flow.
Yes.
Oh, okay.
Yes.
Yeah, that's for the hemodynamic purpose. You are right.
Yeah.
Because we are not really much too deep, so a stable balloon is very important.
But we ever encounter when you inflate the balloon to high pressure, one of the small balloon inside ruptured. Yeah, that's one of the possibility. Yeah.
Sometimes if you put the true flow balloon too deep, the wrapping of the balloon will catch something. That may cause some problems. Yeah, go down.
So for this case, because the sinus is big and this is tall in short, so the coronary access won't be a problem, won't be an issue. Yeah.
Patient have bypass as well.
So bypass already, yeah.
Another. This one.
I think he's SD4, so I think next future valve you have a lot of plenty of options.
Yeah.
All right, 0. Okay. All right.
Very good.
Yeah, no gradient.
Yeah, very good. Yeah.
I'll be lower than the Arctic.
I think the result is good.
Yes.
So
Yeah,
we
beautiful.
can put out the pigtail and do a final angel.
Solid pressure is also good.
Yeah.
So not much regurg.
Yes. Yeah.
Conduction abnormality.
拿掉，直接拿掉。对。Okay. All right, we make a final angel. Okay.
Okay, go ahead.
All right, perfect.
Perfect. No AR. Congratulations.
Very
nothing.
good.
No,
Very good.
no leak. And the
Excellent
position
result.
is really good. Thank you.
Congratulations. Very good.
Thank you. Thank you. No. 下面往上提吧。
Is it your routine to still use the TEE during this valve-in-valve procedure?
All the TAVR procedure. We
All
do,
the TAVR. Oh,
yeah, we do-
okay.
we
So
do,
all under GA.
GA, yes.
Oh,
yes.
okay.
Because we are more reliable on the on the T. Yeah.
To the
我们可以转到这还没好哦，还没准备好。那any question or comment? Yeah.
Professor Cao,
Yeah.
and I'm cardiac surgeon Dr. Chen. May I have a question? If this case was not the severe aortic regurgitation, but the severe calcification of the valve leaflet with a severe AS, how could we modification this procedure?
There's aortic stenosis. We can do the bottom predilatation, BAV first, and then do the residual procedure as the AR. Yeah.
I see the slide jumping of the TAVI valve, especially at the LCC area. So could I to prevent this situation, or this is a normal condition?
Most of the case we implant the valve like this patient. The NCC part is good position. LCC part is deeper.
Yes.
And we ever try to adjust. We can try to adjust if we can get a better position. But most of the time, this is the common fashion of the valve pre-deployment.
Yeah.
So we believe that after deployment, the valve tilt and the site the LCC part will shorten.
Yes, I think in this case is a very perfect position, but I think just a little shallow in a subvalvular distance. So is the distance of the 3 millimeters enough, or we need to get more distance?
The depth, implantation
Yeah.
depth. Yeah. Normally we implant about 3 millimeters below the sewing ring.
Yes.
Yeah.
Yes.
So I think the depth is fine.
Is the depth will change between according to the leaflet calcification or the annulus calcification?
I think the key to get the depth 3 millimeters because you want to reduce the conduction abnormality.
Yes.
And I think on this case because of horizontal aorta, so I think the valve is initially will not coaxial because of horizontal aorta. So I think you try to control your release. And I think this demonstrates very well. But I think that because of the tension of horizontal aorta and valve not coaxial, that's why it valve is at the end of final deployment is flipped a little bit, but that's what we want to, because initially you can see the implantation depth on the left is very deep, but once it's co-aligned, it's become equal, a little bit less on the left, and I think that's a perfect deployment for this challenging anatomy.
Thank you.
What do you usually do if coronary height is a problem for valve in valve? Do you use like Basilica, Unicorn, or what would you usually do here?
We do less so-called chimney stenting. We don't do that. So mostly we do the leaflet modification, and we do quite a few cases of Unicorn procedure, and a few cases of Basilica. But I think Basilica is it's a little bit challenging. Although from the figure it looks quite easy, but actually it's not easy. It needs the learning curve. Before we succeeded, we failed for many times, and after a few times we succeeded. So it's a learning curve, and we do more the Unicorn procedure, yeah. And Unicorn procedure I think it's a good technique, yeah.
The valve in valve, when you have the low coronary height, I think as Michael mentioned, I think when you look risk of coronary obstruction, I think from VIVID you need to look at the VTCs. If it's more than 4, it shouldn't be any issue. But if it's less and coronary height is low, sinus is small, I think that one you probably need to get the preparation. And I would agree that I also prefer leaflet modification, but I think you have to get a good working team with your echo, because you might have to do good Basilica. You have to point the tip of the AL in the middle of the cast, and then before you get perforate and lacerate the leaflet. So I think this needs consideration. And also remember, because this is previous valve surgery, so the leaflet that you cut may not be exactly in front of the left coronary. So I think from the CT, you may have to look at and make sure that the coronary and that leaflet that you plan to cut is same aligned. Because if it is not aligned, even though you cut, it may not help.
So there's a retrospective study compare the chimney stenting and the Basilica procedure, and the results show the peri-procedure outcome. Chimney stenting is poor. It's poor, like acute kidney injury. But after 1 year, the outcome are similar of both group. So actually, probably there's no definite technique that which one is the best. But about Michael, how about your thought?
Both will work. We also prefer the leaflet modification only because like for younger patients, you think of the re-access. So chimney stenting will be very, very difficult to re-access the coronary. But with leaflet modification, maybe it's easier. We usually would do Basilica. We've not done Unicorn yet because we always look at the CT, as Nathan mentioned. Look at the CT and then make sure you go to the base of the leaflet and then make a reasonable cut and then assess with the TEE the results, and before we put in the valve.
The patient age and the complexity of a coronary is very important to make decision, because I think if the patient is younger age and or have the complex anatomy that you may have to go back in, then I think re-access is very important. Because if you put chimney, it can get away, but it's going to be difficult if you have to do something. So I think I would prefer leaflet modification in that case. But if the patient is very old and you might just get it done and maybe leave him alone and just a chimney may be okay.
But if you are doing, okay. Yeah.
in my center, I do pause, but I think you have risk and benefit. Because I think when you do pre, you can fracture, and then but you do post, you may have some injury to the leaflet. But I think I will look case by case as well. I think like this case is not borderline PPM. I mean, BSA is 1.6. You put 26 valve, so I think you probably don't need to do any. So I think I probably just invasive measure. Gradient measurement is my key thing that I have to do in mandatory in all patients.
Oh, I think the recommendation nowadays is do post, but frankly speaking, we are still doing pre. we just get the valve well prepared. Everything, check the valve first before you really do the fracture. And once you fracture the valve, get the balloon out as quickly as possible, and then get the device in as quickly as possible. The reason is we really scared of destroying the valve. We don't know the durability. For younger patients, if the durability decreases by 5 years, that makes a big difference for the patient if you post-dilate or after the valve has been put in and then you dilate, fracture the valve. We just don't know the long-term outcome, especially with a big valve. Because like if you use an F-volute valve, the biggest NC balloon that you can use, like a 34, the biggest NC balloon you use is 25. So most of the time, 25 true balloon is not going to break or fracture the valve. So that's our concern. If you use a bigger balloon, then it's not really recommended by Medtronic. So these are some of our concerns. So for now, we're still fracture first and then put in the valve. Cerebral protection devices. I saw most of your cases today, you use cerebral protection device. Yes. So, yeah. So is it your routine?
Yes, it's our routine, yeah. So
and the patients pay, or it is actually funded by the government?
Patient has to pay. There's no reimbursement. So, but patients are willing to pay that because they are afraid of stroke. Yeah.
Again, frankly speaking, we are still using it. 99%, I would say, unless for patients who cannot afford to pay. In Hong Kong, we just ask the patient, we show them the evidence, tell them all the trials are negative so far, but these are the things that we can capture. Every time we can capture something. And then ask them to decide whether they want to pay extra to get the cerebral protection device. I would say 99% they will go for the protection device, although the evidence so far has been negative. But for particular cases like valve-in-valve or very calcified bicuspids, usually we would recommend the patient to have this device.
So at least for the cerebral protection device, we have to select the patient. If there is a highly risk patient, we should strongly recommend the patient to receive the device. Yeah.
In the other situation, apart from the valve-in-valve from bicuspid, when you plan to modify the leaflet, I think it's a must. And in Thailand, we GDP is lower, so we still have to help the patient pay for the device. So I think we not routinely put in, but I think in the certain particular risk, we will do, and also a patient who can pay. So if they can pay for the valve, then I think we ask them. But if they have to use our fund to pay for the valve, then that will be some limited.
There's a new generation of surgical valve of Edwards Aspiris. It's a balloon expandable annulus, the design. So when you use when treating this patient with valve-in-valve procedure, would we choose a predilatation to how to predilatation to this annulus to an adequate diameter?
For predilatation, of course, we need to know the size of the annulus. So we choose the balloon smaller than the annulus for sake of safety. We don't use the balloon equal size to the annulus. So, for example, the annulus is 23 millimeter, then probably we can use 20. Yeah.
But you asked about the new design of the valve, right? Because I think with Edward, they have the valve that can be expanded. That may be compatible, I think, when you do future TAV in TAV, future TAVI in SAVI. And I think that in the patient with small annuli, I think you can valve that can be cracked and expand. That will decide. We don't have experience yet, but I know that my surgeon actually moved before because they don't want to reoperate, so they put mechanical. But I think with the new data with surgical in TAV, they put more bioprothesis and they put more of that. But they just put in, so I don't have that 10 years to do this yet. But I think that the one that designed for the future TAVI in SAVI, because the valve is designed able to crack and able to get the better EOA after you cracking.
Yes. To continue this question, if the patient is a small annulus, you are a surgeon, you will do the root enlargement?
Yes. Currently, we will willing to enlarge the annulus to at least 23 millimeter. Yeah, to put a further larger TAVI device. And the new design of the INSPIRIS valve can balloon break the annulus valve annulus to maybe 25 millimeter in a 23 millimeter valve design. So I'm wondering if we treat this patient, we will use a larger balloon to break the annulus before we implant the TAVI prosthesis, or we just put a self-expandable TAVI.
I don't have experience yet because our surgeon just put in, but I think when we look in the patient, we plan to look for lifetime. So I think our surgeon do the same, that if they plan for future TAV in SAV, they will put that valve in. But I would think by the time I have to do it, they probably have some protocol. I think that.
For this question, it's a root enlargement. Today we talk about the most important thing is patient prosthesis mismatch. And Professor Chen Ye did not agree the wide incision quite a lot. And clinical still have some concern in the wide incision. So that some of the surgeons in the United States use the Marucci procedure, but not the wide incision. And I think that we should watch for the wide incision for the Boyang procedure. And short term is good, however, long term is not. Yet did not know. And I have a question about another question is if we implant 23 valve, in the future, can we break the valve? No one can answer the question. So it's a big issue because Boyang tried to implant a 25, 27, even 29 valve in their surgical valve. However, it's useless. So the bigger is the better. I don't think the bigger is the better.
Actually, I have a question for the surgeon. So since you do most of the time root enlargement for small annulus, then you put in a bioprosthesis valve. If we want to do TAV in SAV in the future, and then found it to be like the valve is too small, like patient prosthesis mismatch, we want to break the valve. Do we have any concern? After root enlargement, the surrounding tissues will be weakened. When we do this valve fracturing, we will actually damage the surrounding tissue, causing more rupture of the annulus. I never asked this question, but just come to my mind.
Yeah, it's a very good question. Yeah, just like Chief Lee said, we have no definite evidence to prove it's safe to put a larger valve in the altitude.
Break the valve.
Yeah, break the valve.
Bigger balloon.
Yeah, bigger valve. So because I have no enough experience in the INSPIRIS post-dilatation to break the annulus. So I think we can put a relatively larger valve to initially, and then the next time TAVI we will choose not to break the valve advance. We put a adequate valve, like but not to break the annulus. Too aggressive, yeah.
I think Zhejiang is ready. Maybe we can go to the China Center. Professor Wang is actually going to show us a case of mitral tear procedure.
可以转到那个这儿吗？
啊，这是名字。把那个幻灯片打出来。
OK， 先宝 ，We can see you. Hi， 先宝。
书记在。哦。
Welcome and thank you for taking this this case up. Can you?
不要碰到你这样后面污染了，你为什么要往旁边弄
？Can you show your case first?
你后面是脏的，你手套不行。哇塞，你要给他们打个招呼 ，Michael Lee。Hi, Dr. Lee. Nice to see you online.
王院士你好，先宝。
哎，你好。
We have a group of panelists here in Taipei Valves. So we are very eager to see how you are going to perform this M-tier with the Chinese locally made device.
Okay, thank you so much for giving me and my team the opportunity to demonstrate the case. So first, I invite my colleague Dr. Liu to introduce the case. Okay, Professor Wang and Professor Lee and all of the panelists. Yeah, I'd like to introduce the case. Next one slide. Yeah, the patient is a 72 years old lady, and the patient has a history of the chest tightness and short of breath for over 3 years and aggravated for 1 month. The patient has a history of hypertension, and the echo showed that the patient had the DMR and New York function. Heart function is grade 3. Next one. This is the EKG. The QRS wave is narrow in the sinus rhythm. Next one. Yeah, this is the TE. Yeah, we can see right here the severe DMR. Yeah, this is the TTE. Yeah, and the left ventricle is not so enlarged, and the left ventricle ejection fraction is okay. Next one, please. Yeah, from the TE, we can see right here, the prolapse is majority from the P2 area, a little bit of P2 to P1 area, and the length of the leaflet of anterior leaflet and posterior leaflet is the posterior leaflet is 1.2 centimeter and anterior leaflet is about 2.3 centimeter. And the jet width is about 1.6 centimeter, and the mitral valve area is 4.4 centimeter square. Next one, please. And the coronary is good. So no need to intervention. Next one. So today, we'd like to use a long and wide device for this patient. And the puncture height should be higher than 4 centimeter. Next one. And today we will use the Dragonfly system, and Professor Wang leading our team to work together with the Belgian company together, the engineer together. So the design, so I will introduce So the design, I think the mechanism is quite similar with mitral valve. The mitral flip, however, there's some innovations, including the spacer, and we can lock at any angle from 0 degree to 45 degree. And also we can manipulate the system very precisely. Yeah, we can see the knobs there, including the stabilizer in the factory. So it's much easier for us to manipulate the system. Okay, that's all. The first one. Okay, now Dr. Liu has done a successful transeptal. So we can see the cassette in the left superior harmonic vein. So we try to get the.
And the puncture height is 4 cm, you mentioned?
Okay, the echo, could you show the puncture side? Yeah, about 4 centimeter. Okay. And the height right here.
Can you tell us a little bit more on Dragonfly? What is how is benefit compared to the current system with the encrypt and also with the
Pascal? Sorry, I can't hear very clearly. So your voice is not loud enough. So I think it's better to get your voice louder.
I would like to ask what the advantage of the Dragonflies compared to the current system in the market, like Metalcrypt or Pascal.
Very, very easy to manipulate. Dragonfly actually has 3 handles. One handle for big sheets, the middle handle for the middle sheets, also CDS for clip delivering. Articulating functions very well. Each handle articulating. Also, the clip part is quite different from the Dragonfly, but not different from the Magic Clip. Now we get the big sheets in. Okay. So can you see that? I can show you the Dragonfly system.
Okay.
The big difference is in the clip. The clip is actually it's not a spacer. Actually, it's a compressible spacer. So the spacer its design could be compressible. So depending on how much angle you want, you can release the clip, but keeping 2-arm angle between the 0 to 45.
So you can adjust the tightness of the grip, am I right?
Yeah, you can tightness. You can go to the end of you can tight to the end. Also, you can keep some angle. You could release the clip. So from 0 to 45 degree.
So easier to manipulate, I guess.
About the 10% of patients will need this function to keep the liquidity, to decrease the liquidation, but also we don't want to tight the liquid too much. We try to don't damage the liquid. Also, sometimes, some cases, if we tight too much, may cause the pressure grading, higher pressure grading.
Thank you very much.
And how many sizes do you have? Like for MitraClip, we have the NT, we have the XT, and then we have the W version as well.
For tricuspid, we have 6 sides. For the mitral valve, we have 4 sides. Regular length and regular width. We have a longer width. We have longer and wider.
Okay. So very similar to MitraClip.
Yeah, you are right. In length, I say we have 2 sides in length, 6, 9 and 12. Yes. So we have 2 sides in width, 4 and 6, right? Yes. Then crossover, so we have Yeah,
gradient. It's the gradient. So gradient.
Your bubble.
Yeah, a small bubble right here. It's okay.
And the guide catheter,
That was.
is it the same for mitral and tricuspid as opposed to mitral clip and triclip? We have different catheters for the guiding catheter.
Different. I think it's different, totally different.
It's different.
The design is very clear. Conception is very clear. Big sheath, middle sheath, and the CDS. So 3 handles, you can one handle, 2 handles, 3 handles. So just 4 direction, each handle. These 2 handles control 4 direction, right? Anterior, posterior, lateral, and medial. This also doing same thing. Anterior, posterior, lateral, and but this one is only you can rotate or advance or withdraw. So conception is very clear. Also, each handle is very good articulating. We can, so we don't move too much of the whole stabilizer. We can everything we can control by our by the roller. So now we are right. We have many. We still can out withdraw the. Can see that we have too many big sheets inside the left atrium, so we just withdraw.
Okay.
Okay. Now we have 1.5. Maybe we want to. Okay. 1.2 left. So now we move, we just, bend a little bit, but now we, 这个符号，这为什么会
？ACT。
Advance。你把那个 warfarin rim, could you show us the warfarin?
Yeah, right there.
Can you see that? We just
okay.
往前打的，这是 warfarin 吗
？Yes.
但它的左线没线上啊。
在下面。
Can
Okay.
you see that? We are ready.
Straddle.
然后往后打一点。
Yes.
And very 前打一点。
往后高一点。
Very easy and to target your leaflet.
往前，Yes.
这个还是要往后，不往后。
太多了，哇塞，超过12点了。好，
那你这个穿刺点还是矮了一点，
偏低了一点。
我把这加点一样。
Yes.
It's very close to the valve already. Very quick. Can you see that? The puncture side is a little bit low.
So. Sorry.
打开还是怎么样？它还会往 M 的来一点，或者我们加一点弯，它会抬起来吗？
它这可能更低了。
这个已经不能再往后了，
差不多了，
不能再往后了啊。
对，我们先打开，把 tension release 掉。但是现在有点 cross the valve， 我稍微打小一点。
just at the tip。
往下看一看。还行，往下还可以，我再转一点点，一点点
，clockwise
rotation。Yes, a little bit. Yes.
More.
Yeah, okay, more. 那再它过来了 ，OK。等它下去会转一点。
Maybe we need more medial. I think we need more medial.
偏一，2偏1一点。
你把 color 上看看。差不多，我看这是个比较 focal 的，是吧
？Yes。
你把他们学给它弄好一点好吗？对。看看那个，做一个 trajectory， 好像还可以啊。或者我们稍微做个 trajectory， 有点点来点去的。 我觉得我们还得应该
加一点，还要加一点
M，
对，加 M。
整个加点 M， 我们整个系统稍微再差不多，还是摆了啊，
还可以。
有一点这种，但是 device it is 本身的，
可以稍微往里面推一点点。OK。
Okay, go to the 3D and fast. 问他们的什么 ？So I would like to have your comments on the what kind of device do you want? What type of device? What size of device do you prefer?
I think if it is going to be A2P2 and it is a prolapse pathology in the center, usually we also aim at 12:6 as in this case, and probably we need a large device with a wide, large and wide, right?
Yes, long and wide.
Yes, we use a longer and a wide. 你这个12放准了，给它回过来一点。差不多的啊。
So hopefully one device will actually solve the problem.
这个圆没有放准，所以我们不太清楚这个12点是什么。Now we maybe too much lateral, but it's moving.
Yes,
moving.
差不多。
但是我觉得 too much lateral maybe. 啊，
箭手断在哪里？看一看。
箭手在这里。那刚挡住了。
啊？
刚挡住了箭手。
什么挡住？
器械挡住，箭手在这里。
就应该这个位置应该可以的啊。
对，是的。
下去吧。
OK, please.
你把它那个。
OK.
So we are going to the left ventricle. We are going inside.
Do you also have independent grafts for this particular device?
Yes. Independent. 看吗 ？Are you sure? 再看看这 orientation 看，就放这里吧。
OK.
Check the orientation. 那你回过头来 check orientation， 把这个移好。
先看这里。
What do you think of the orientation？ 它这个没有方正。
It looks okay, 12:6.
Do you think we need a little bit more the counterclockwise？ 差不多。
可能稍微回来一点点，我觉
得。我来。稍微要。下去一点啊，
下去再上来，
下去。但是这个区域要往后一点，
可能要往 L 一点。
啊，
往后一点 ，OK。A little bit posterior, yes。要再打开一点，
这打就不好转了。
OK。
要往后一点，我觉得还要往后一点。
OK。OK。
没有 hugging， 这后的还不够。可能他没切到，你没切到这个后，应该够了啊。hugging 基本上没有啊。
Yes.
So checking the orientation, please. 再上一点，再抬上去。应该回过来了，你看我这里已经回过来了。啊，
这一点。
太 M 了一点的。
对。
啊。
太 M 了一点。
那我们轻轻往那里推一点，还是怎么样？
对，我觉得可以先翻转一下，它可能过去了，可能现在有点翻转就过去了。
那翻转吗？
对，我觉得翻转一下，它就，再来往稍微 M 松掉一点点，这样就跟下面接触比较少。好了，应该过去一点了。
为什么？
好，我再往里边顶一点点。好，都在了。
有了。
看怎么样？现在有没有好一点？
哦，3D 看一下。
那我现在你看过来了，其实我们都没怎么动。
心理上有点感觉来。你把这个 X 光调整，给它那个 alignment 吧，能不能
来调一下
？alignment 调一下，
调了一条线。
哎，它这个圆始终跟这个没变。
嘴角可能有点歪的。
对，它把它动脉是在上面。本来这个 maybe too lateral， 你推了过头了。 你把 color 打起来看。
键数应该是断了这一边。
它偏1的哇，2偏1。
差不多吧，我们下去算了。
对，我看一下，我看2位看一下。
看有没有从中央劈开的？应该从中央劈开的。
就关键突锤是不是在这里？你老是切就切了走样了，按不在上面了。
我就切键数去的，就旁边一根键数的。
就是后叶够不够？
这个我拉起来。
再不用再拉了，不用再拉，你往后叶多一点，再拉就翘起来了。你往后叶稍微，我下一点，你往后叶稍微走一点，一荡最多了。
可以了。
好
，OK。
它还没有跳出来了呢。
我老师准备要下了啊。
好的。
So we could do independently, but we want to grasp together. 前沿会不会太多？
可以。
你再 check orientation。
好。
应该可以吧 ？orientation。你觉得
应该可以？
那我们收了。
你 color 看一眼
，color 够不够？好像又往 middle 走了。
你 color 看一下是不是分开的？
把模式再抬起来。
左右分开怎么样？还行，还是 L 字多一点哇？我觉得 L 字多一点，可能稍微再移过去一点点。
再移嘛？
否则等会 L 字可能还要参与拖，移一点点就行。
M 不要打太多 ，M 不要打太多。我下去，
你下去一点，我再推进去一点。
下一点。
往里面推一点点。
我就释放点 M。
好，释放点 M，OK。好 ，OK。
我就怕前也打不上来了。
那我往前先打一点。
显示清楚嘛？显示清楚啊，保住了。
后叶可能有点挂住了。
是的。
把这个简单事情复杂化。
后叶挂住了，后叶挂住了。
没关系。翻转一下，再往前打一点就行。
简单事情复杂化了。它总是飘来飘去的，所以也不可能100%有构筑在那上面。你往后前沿方向打。
往前，再往后往前。或者我们这个时候再关回来，差不多了。
没有必要做到。
好
，10全10美就什么都没了。
看前叶在不在？
好，
应该都在的。
都
在的，都在。我后叶确实前面有点挂。
我拿 3D 看一下。
前面前沿还经常掉来掉去的，前面是挺好的，前面那个挺好的，现在 too much 了 ，too many lateral， 别再动了，先别再动了，这个时候去调就等于0了，反而那个了，你看你搞到lateral去了，
方向转了，
这一定是出问题。它是那个半夜勾住以后就开始
历史有点改变了，
就开始整个方向就搞复杂了，把这事情，结束了已经。你往前也打打看啊。
往前好。
现在是不是勾在这里？你还不知道？
现在感觉松开了。
有点松开了已经。
松开了后叶。
So you want to go a bit more medial?
Yeah. Yes.
No. Yes, you are right. Initially, we want to be more lateral, but too much lateral.
Yes,
so, but actually, the previous position already very good. But we try to. 你往这边后来一点，
往前还往后？
往前。
往前好 ，OK。
好，别再搞了，别再搞了，你别再搞了。
我再确认一下。
都在那里。
OK。
往下一点。
好，你看方向各方面。
出来多少？应该出来重新弄。出来多少？
你 color 先看一下。
好的。
方向还可以。color 看是不是从中间劈开的？
那这米点多了。
米点多，
我们要不要看一下术前？我觉得
前面那个位置其实挺好，基本上它抓起来的时候，因为长的嘛，它自然拉住了。
王老师，我看一下这个图啊。
你现在肯定不行，你米点这边突锤到米点来了，你还在这边抓？
不是，我的意思说它的键数应该在这个地方断的。
那也是中间啊，也不可能到那边去。这里不是你突锤，刚才的地方比这个突锤高得多了。长江，能不能加一点？
那往外移一点。 往外移一点点，好吧？好 ，OK， 往外移一点点，王老师。
好，差不多。
好，差不多了，移过来一点点了。好，
感觉好一点。
对对对对，
有点好一点出来。再这样吧，看看吧，来继续看。
我3D 看一下。
那就比较麻烦，反复搞。还是来到了。
现在可能
过来一点了。
过来了。
偏来的了。
现在你就media 出来了，你是 color is on please。
差不多了。
有点多。
还是二维要不要看一眼？
我去二维看一下，我觉得可能还行。
那王老师，你看二维现在和迷点稍微多一点
点，但我觉得还行。
或者我们往迷点再移一点点。
移得过来吗？你稍微移一看。
你们下去，您下去，我拉一点点。
不用太拉下去，它这里宽。下去没有。
它有相互作用在这里。那我移一点点。
移了吗？
好，移出来了。已经移出来了，王老师。
是的，
我移了。
我也不要卷在那里啊。
你们往后，我要不要往后打一个还不打？
稍微要往后打。
好，可以，你拉起来一点，我往后拉。好，拉了，王老师。
够了，不能再太高了，再太高就没法弄了。
现在刚好。
那现在挺好的，两边差不多了，王老师。
让我3D 看一下。
方向要不要看一眼？
对，这个不要动。Any comments from our panelists?
We are seeing your very meticulous manipulation. So I think, yeah, a little more video is better like now, because before it was too lateral. And
you're right about the orientation. We need to change the orientation. 你把主动脉往上
，a little bit.
主动脉往上调啊，主动脉往上。
这边你这个层面是不是那个 probe 的位置？
等一下，我重新。
我现在把它选了，那要 counter。
感觉有点方向变了，
方向又变了。我们下去以后再选过来。
等一下，我看一下。
变了一点点。
Maybe a bit more counter clock.
So what do you think the orientation? What is your comment on the orientation?
Might need a little bit counter clock, just a little bit.
Yes.
OK， 那你回到 back explain， 回到 explain。差不多吧。
好，
我再看看，没回过来。
对，3D 啊
，3D。哎，跟键手可能勾在那里，我怀疑，所以就会出现这个情况。好一点 ，better，也没有太多的 better 啊，好一点点。
好了，
那我们回到二维啊。
回到二维，如果还好嘛，可以加了。
对。
还是本来应该再转过来的，那就算了。
你看看了是分开的。现在左右分开差不多，对吧？
差不多。
我们再来2次，再稍微转一转往这边。
差不多，王老师，我觉得。
差不多吧。
再准备下来了。
哦，那你把它固定了。
我固定了，好，下去了，摆动 bouncing 很好。
你是我看看。
那么就可以 close。
去看看这 orientation 吧，再看一下啊。
好。Check carefully。
应该差不多。
还可以。
我已经把它转过来。
他这个人嘴角本身可能是歪的，他嘴角歪的。
这样过来就好一点了。
好，那么可以试夹一下看看。
好。
好像还是比较歪啊。
那您可以慢慢夹，我松张力。这边看了
啊。
松一点点啊。
松的前。
好，可以。要么我们先看看反流怎么样。
我完全在同一个平面上。好，
先看一下啊，check一下。明显减少了，两边都有，对吧？
对。
加起来可能就没有了。好，再松掉一点点。
release tension a little bit， 不用再差不多了。
我不送了，
够了。不在同一个平面上，所以它切到这个时候，那个前一脑在摆。Check the regurgitation。
没有了，几乎没有了，
还是有点，
一点点，一丝丝了。
啊
Much reduced, yeah.
我再看，
这还没关紧。Yes, very good.
The patient will need to go to end
好 ，OK。
有点血的关系，要不然就一点都没有。
很好。
Maybe functional。
他嘴角是歪的，跟那个平常不一样。看有没有参与脱？
我看一下，我现在3位看一下，深度看还好。medial 一点点。
medial 可能是 central。
嗯，
它不是这个 central 不是脱垂的。
对。
拉回来了，
就一点点了呀。再看有没有参与脱。
We check
residual.
Yeah, very nice result.
Residual prolapse.
And the bridge looks good.
Yes. 参与脱没有啊？Yeah, no residual prolapse.
Very nice. Yeah.
And
you check the
then we see
gradient
the
as well?
check the pressure grading.
导播比较多。
对，导播它前面就多了。下面可以看。
今天说切好。可
能是4、5的样子。我们加的其实挺多的。4 gradient is
borderline. We can see the contrast, spontaneous contrast.
Yes.
A little spontaneous contrast we can see. 差不多就这个样子，不会。
Yeah. So then we will release the clip.
Blood pressure is getting up
a little bit.
What is about the left atrial pressure? Still high?
Yeah, similar. 这里有7啊，还这么多，那我们可以打开一点。
等一下，这边我再测一个。
我们就保持一点，不要到那么紧。
对，我们可以把它松开一点。
Function 是。
这个我再测一个。
再测一个。
你要取几个平均，因为它有房颤。
这个不是。
这是房颤吗？
对的，
它不是。
色藻的关系，你不要取色藻，不要取那个ventricular ectopy，你应该开心链头取。
对，我取了中间这个。
你取这个，你前后要没有藻薄的。
没有的。
我7就太高了。
我不会取，它是藻薄的关系。
6。
这个是。
能不能地方但没有藻薄，全稳定的？
哇，这3个都是豆里的。
来，你再来。
你前后影响还是有，你要连续一段时间没有。
对。你再重新来过，记过。
测这个没意义，你重新取一段。
What gradient do you usually accept?
Less than 4.
Less than 4. Wow.
好，取，你要取这段你就2.1。
Okay, so then we can see.
前后都没有影响。
So for DMR, so what's your cutoff? The gradient. Michael.
Well, we usually aim at like better results so that we allow a little higher gradient. 6 or 7 is, would be okay for us.
Yeah,
so we don't know about this device.
So we can just.
I don't know.
Yeah, so
we can try the clip function, a unique clip function.
Yeah, open a little bit.
Try to. 那我们把这个起来。
Any tip and trick? I mean, if you encounter with the gradient high, what can you do to reduce the gradient?
There's nothing we can do. If the gradient is too high, you cannot really put the clip there. So otherwise, you use
the position. Is this change? If you change,
you can try to change the little bit position. Yes.
So now we use the unique function. Only this clip has, we try to lose the 2-arm angle a little bit.
We can't do this with
45度
mitral clip.
来再看看，
This can control
This can control the tension.
how much.
我觉得还可以再松，我觉得没有松到多少。
我们先看一下，也可以再松一点。
Let's see.
Yeah, we can lose the.
因为你反流没有就行，我看。
对，
我们因为你这个角度。
那我先别看了啊，我要再松一点，你先不量。
好。
达到那个可以再松掉一点点。
我觉得没有松掉多少，这样差不多。差不多45度没有的，
它没有45度，
没有45度。
好 ，OK，
那可以吗？我们再松一点了，还是还能松吗？
我觉得可以松，但我们可以
先
先观察
on the clip and
先测一下吧。
hopefully will impact on
对，最后
the
你
reduction
完
of
全
the
释放以后，
gradient
它还
across
会再
mitral
打
valve.
开一点点。
反而是反流少，看。
对，现在反流差不多。Yeah, Professor Wang released the tension a little bit.
I released the arm. I just open the arm a little bit.
So
open the angle of the arm of two arms between two arms. Top
6. So we can open a little bit more. 来，我们再来 explain， 再松掉一点。
抓的半夜比较多，可能用个短的宽的。
这边看到右边，
用个短宽，好像反流多一点了。
反流有没有多起来看看？没有多起来吧？
我觉得多一点了。
没有啊，是
没有吗？
好，我那么停在这里，
差不多了，就
你担心反流多起来，我们看看。
就停在这里啊。你到11点发再看一下。
再看看啊。
你们现在认为打开多少度了？30度有没有？
它比原来我看看啊。
When you release
30度是没有，但至少张力跟原来比肯定是小了。
Let's say like get more MR.
The MR would increase a bit, maybe, yeah. But for this,
so you try to find a sweet spot between.
Similar.
With this device,
similar.
It's possible.
Regurgitation in the medial side, there
increase a little bit.
Increase a little bit. 是 increase a bit. 这只能平衡了，取个平衡了。 那问题是打开了会不会还要多？
打开了它可能还张力再松掉一点点。
有一点，
有一点也能接受。
We have to keep some residual, a little residual regurgitation, to balance the
gradient.
The gradient.
This gradient looks better. Still 6.
So then we can release. And then I think
the best you can do, I guess.
I think
you
6
release
is okay.
A little bit more MR. So I think this may be the sweet spot for him.
So you agree to release, right?
Yeah, I think
okay. Release.
Residual MR is reasonable and most mild, and then gradient 6 is okay.
Okay. So when we totally release the clip, then I think the gradient will decrease a little bit more.
就这个，你先。
那我们先。 比较测试，
它本身就要往后打了，我已经开了一圈了。
好，那再开一圈。
不用开一圈，我看我已经开了一圈了，我看半圈都够了。
可以，没问题。OK，
看呢？
好，没问题。好，可以。
再回半圈要吗？
回半圈可以。好 ，OK， 可以啊，这边反流没有多起来，对吧？
没有。
你这个压力，你再看，现在再 check 一下 pressure gradient， 说不定又下去了。
那我说我们开始放吧，所以打开多开一点点。 我放完以后就是5了，5到4。
Interesting case 啊。
Yes. OK。我放完，先不你等会你测一下。好。松的。
这个。 Fix the
handle. Okay. Yes. Okay.
Fix the handle.
Okay. Sure.
哦，这个
没问题。
那为什么这么说？因为我这边松了很多。
对。
所以你
线已经松了。
你线根本就不紧，你看这每根线都很松。
Yes.
所以我担心会不会勾得住来。现在有30 degree， 我们要不要再紧一点？
不要紧。看了看看，你现在没机会了。
再看看，
现在已经没机会了，但是你放心，没问题。 这就是它 unique characteristics.
Unique feature.
Yes.
Go for the lowering the pressure gradient. OK. 我们就这样啊。
对，不用紧，没问题。
你后面接牢，你后面接牢，
非常稳。
后面接牢，你不要急着让它缠起来。 你看，你就让它弹起来，你就三心二意在那。拉到上面来了，结果把下面拉了。
拉掉 H 吧。
啊，你就盯牢上面那个上。
OK。
在下面再盯牢。那我再拉，你就盯牢下面一根线。Go。
好 ，OK。好，是在这个。往外 ，OK， 这样。好。OK。Open。对，我要先转这个，转2圈。好。结果打了6千20度。
3、4、5。
好来
，roll please.
Yes. Okay, good.
Okay, good.
好。
Check the regurgitation.
So the MR is stable right here.
Very stable.
Yes.
Gradient will be lower once you
release it. Yeah, I think it will be lower.
那你不能测量色早它心打字就少。
对，这边你多记一会儿，
它的 pressure gradient 就会低。
你多记一会儿。
你 no because the ventricular ectopy is interfering the pressure gradient, so we don't want the. We try to record the long run EKG without the ventricular ectopies. Then we can match.
Now it's more stable.
That's more stable.
Yes. 我感觉可能还是有6。
At least.
可能心跳比较快。
对。
但这坡度比较陡。
So heart rate is still 6, and the heart rate is about 95. So if we use the,
I think we can lower the heart rate a bit.
yeah. So then I think the gradient will be better.
Yeah.
Okay. 那我出来了。
It looks good.
Very
nice result.
Thank you. Thank you all panelists and all of participants.
Thank you so much.
Very nice result.
Congratulations to you
Congratulations.
on the successful Taipei valves. Congratulations.
And we hope to see you next year here in Taipei.
Okay. Me too. My team too.
Okay.
Thank you. Bye bye. Thank you.
Bye bye.
Bye bye.
Bye bye.
Bye.
So we see it's a different device from our clip, mitral clip or the Pascal device. This is the Dragonfly, but the procedure-wise is very much the same. Yeah, very, very similar.
Okay, and it's time to change the
All right.
the panel.
Okay, thank you.
Thank you.
Thank you so much.
Roundtable discussion. Our topic is tricuspid valve repair or replacement. I'm Dr. Zhang from Zhenxin General Hospital, and my co-chairman is UC He, and we have Dr. Simon Lam, Yiting Cai, Bo Songcheng, Hui Minggu, Guo, 宜晨，还有这个 周体刘俊廷 panelist expert. The first topic is the transforming tricuspid therapy, early clinical experience with the EVOQUE system that will be presented by the Sam Dawkins. And Professor Sam Dawkins is the consultant cardiologist service at Oxford University Hospital and Cleveland Clinic, London. This is a video. The speaker is not online, so we will start the presentation.
My name is Sam Dawkins. I'm an interventional cardiologist from the UK. Thanks very much for the invitation to speak. In the next few minutes, I'm going to talk about our early experience with the EVOQUE transcatheter tricuspid replacement system. These are my disclosures. You've already heard a little about case selection, and I think this is one of the most challenging aspects of this field. How do we choose the right patient for the right procedure? I think it's helpful to break it down into these factors: the anatomical criteria, that is, can we do it? Risk stratification and futility, that is, should we do it? And the patient preference, which you will have encountered this in clinic. Why wouldn't you do it? Thinking about the anatomical criteria first, I start with the leaflets. So in this case, the leaflets are thin. The septal leaflet is quite restricted. There's a very large coaptation gap of more than 2 centimeters. This is a patient with free tricuspid regurgitation who would not be a good candidate for edge-to-edge repair. Pacing leads are another issue to consider. In this case, the pacing lead is passing through the tricuspid valve leaflet and also involving the papillary muscle. Here are some 3D views of the same patient and some transgastric views illustrating the difficulty. So this is a patient where edge-to-edge repair would probably not be feasible, but certainly wouldn't get a good result. So which approach should we consider? At the moment, most of us have access to TEER or tricuspid replacement, and very few of us have access to annuloplasty. For TEER, we consider the coaptation gap, the imaging, the presence of pacing leads, and the leaflet anatomy. And for replacement, the most common reason for screen failure is annulus size. This graphic just illustrates some of the considerations for case selection. For patients who have straightforward TEER anatomy, then that is likely to be the favoured approach for them because it's a very safe procedure with a growing evidence base. For patients who have anatomy unsuitable for TEER, then replacement can be considered. To give you some background on the evolution of the EVOQUE system, the first in-human case was in 2020. TRISCEND 1 and TRISCEND 2 have since finished enrolment. The device was CE marked in 2023, and we did our first case in the UK in December 2024. Here are some of the TRISCEND 2 data presented at TCT last year. This is the study design. Patients were randomized 2-to-1 into tricuspid replacement versus control. It was a comorbid group of patients with 20% or so of patients having ascites, more than a third of patients having a pacing lead. The device time was relatively short considering it's quite a new technology, at less than an hour. These are the safety outcomes. The cardiovascular mortality in the control group was... These are the outcomes. The cardiovascular mortality in the device group was 3.1% and the pacemaker rate was 24.7% in the device group. There was a substantial reduction in tricuspid regurgitation with more than 99% of patients having moderate or less tricuspid regurgitation in the device group, and more than 95% having mild or less tricuspid regurgitation. Obviously, the mortality outcome was driven by the procedure, but if you do a landmark analysis at 30 days, you can see the lines start to diverge with a numerically lower mortality in the device group. The same is true of heart failure hospitalization, with no significant difference between the groups, but a numerically lower heart failure hospitalization rate in the device group. As you would expect with this reduction in tricuspid regurgitation, there was a significant improvement in quality of life. The pathway in our hospital for patients referred to us for tricuspid valve intervention is shown here. We have a discussion in principle before we've met the patient so that we can then divert the patient to see an interventional cardiologist or a surgeon or both, or send them to have a screening day for tricuspid replacement. For the screening day, the patient comes to the hospital for the day, they're seen by one of the interventional cardiologists, they then have a detailed transesophageal echocardiogram and a planning CT scan. All of that imaging data is then sent to the Edwards screening team, who generally get back to us within a day or two to determine whether they're suitable for tricuspid valve replacement. When it comes to the procedure, patients are admitted the night before. Unlike TEER, where we try and diurese them fairly aggressively pre-procedure, for tricuspid replacement we are keen to have stability, so we try to have the patient euvolemic at the time of screening and then change very little between then and the procedure. Here's an animation of the EVOQUE transcatheter tricuspid valve replacement system. It's delivered via the femoral vein. It's released incrementally, with these anchors being positioned outside the native tricuspid valve leaflets. The valve then expands with the positioning being checked on multiplane echocardiography. And when we're all satisfied with the position, the ventricular release can be finished, followed by the atrial release and valve deployment. The procedure is carried out predominantly using echocardiography, and we use multiplane reconstruction, and it's perhaps worth looking at that in a little detail before I show you a case. The imaging planes are set up like this. On the top left we have AP with anterior on the right and posterior on the left. On the top right we have septal lateral with septal on the left and lateral on the right, and bottom left is a short axis transgastric view. This is the home view, and as we go through the procedure, periodically we do a spin where we move the green plane through each anchor and then look at the right-hand anchor in the top left-hand view to see whether the leaflet is engaged or not. And we do this at multiple stages during the procedure just to confirm that the anchors are outside the native valve leaflets. You saw the baseline imaging for this procedure a second ago with the pacing lead splinting the valve open. This is the EVOQUE system being delivered and steered down. This is the primary bend, which steers AP. There's also secondary bend to steer septal lateral. We're now releasing the anchors using the white knob, which we do in stages with a spin periodically to confirm that the leaflets are engaged. We're now in the final stages of the procedure, completing the atrial release of the device. It's a very stable procedure, very stable hemodynamically, and with this final release you can see the valve is sitting nicely in the tricuspid position, and we can then check the final result on echocardiography. So here are some transesophageal echo 4-chamber views confirming a trivial paravalvular leak on the septal side, and some short axis transgastric views. So the patients spend 2 hours in recovery before going up to the ward. They don't need to go to the intensive care unit, and this patient was sent home after 48 hours. Here's a reminder of the baseline imaging on the left with free tricuspid regurgitation, and the final result on the right with no residual tricuspid regurgitation. So in conclusion, the tricuspid valve is no longer the forgotten valve. We do now have treatment options for most anatomy. Access to these technologies is quite limited in most geographies, but where patients have debilitating symptoms despite maximal medical therapy, transcatheter tricuspid valve intervention should be considered. Edge-to-edge repair has the strongest evidence base and is a very safe and effective procedure, but we should be aiming to get a good result with at most moderate and preferably mild residual tricuspid regurgitation. Transcatheter tricuspid replacement is a good option for patients with anatomy not suitable for edge-to-edge repair. Thanks very much for your attention.
Okay, we will move our roundtable discussion. The case presentation will be presented by Dr. Chen Bo-song.
Okay, I will present this case. This is a 62-year-old female who presented with shortness of breath, dyspnea on exertion, and lower leg edema for years. her past history with type 2 diabetes and thalassemia. Besides, she had a previous operation history. In 2013, she received a double valve replacement, including an AVR with 70 millimeter St. Jude metallic valve and MVR with 25 millimeter St. Jude metallic valve, and AF ablation with atrial cryoablation. Before she admission, we can see the chest X-ray reveal the cardiomegaly with 2 metallic valve. The ECG showed a junctional region with rate around 75, and the TTE showed a good function of the aortic and mitral process valve, and a severe to massive tricuspid valve regurgitation. There's another side. We can see the T is a better view. We can see there's multiple jet at the tricuspid regurgitation. In this view, we can see there's 4 leaflets of the tricuspid valve, anterior, and the P1, P2, and the septal leaflet. We can see there's a relatively large gap between the posterior 1 leaflet and the septal leaflet. The maximal gap is 5 millimeter. We can see there's a central jet with a multiple direction from the central defect. To summarize this case, this is a 62-year-old female with a heart failure with NYHA classification 3 to 4. And she had a right side heart failure sign with bilateral legs edema, and she had previous left side heart valve surgery, including AVR and MVR with metallic valve. Besides, she had a severe right side ventricular dysfunction. Her tri-score was 4/12, and the prediction in hospital mortality is around 8%. Thank you.
Okay, Dr. Cai Ting, what will you do?
Okay, I think just like Dr. Stan Dankins said, the tricuspid valve usually is the forgotten valve. We rarely to do the tricuspid valve only. Usually we do this, but the tricuspid valve surgery with the mitral or the aortic valve. So for this case, the first thing I'm concerned is about what problem we want to solve for this patient, because I see he or she has the aortic valve replacement with the mechanical valve about 17. I think it's a little smaller. And in the same time, I didn't hear about how weight about this patient. So I think I need to figure out this condition and to evaluate what should we do and what should we can do for the tricuspid valve.
I think I completely agree with you that the prosthetic aortic valve of 17 millimeter it's small. So my question really is that apart from the right-sided problems, we have to ensure that the other two metallic valves are working fine. That's number one. Another the second point I really want to know is what's the PUMI pressure? Because if the PUMI pressure is elevated because of left-sided disease, and whether it is a dysfunctional prosthetic valve, then the treatment is very different. So those are the 2 points that I will make. The last point, probably in a patient with 70 years old, we mustn't forget the common problem, which is coronary artery disease. So right and left heart catheterization will probably be what I would look for.
Could you answer that, Dr. Chen Bo-Song?
The coronary artery, the coronary angiography is normal, and the right and the RVEF and the LVEF is preserved both.
What is the PAP, pulmonary artery pressure?
I forget the exact value, but the PAP is more than 40.
More than 40. Okay. So this case is relative small size woman. You can see the outer areas could insert the 17 millimeter outer valve, and the mitral is 25. It's relatively small. At that time, we do not routinely use root enlargement, but at present time, we routinely enlarge the outer root for at least 23 millimeter tissue valve or 21 millimeter metallic valve. Now is our policy in our hospital.
So a question, what is the initial etiology for the double valve replacement? Is it rheumatic heart disease?
Rheumatic heart
already at that time, already had right ventricular dilatation or annular dilatation? Because usually for those cases, they maybe already have an annuloplasty ring. Or is it sometimes that exists for that period of time and then it evolves? Or it's something that happens as a new component that gives rise to this TL? I think we want to know about that.
In our hospital, our policy, when you perform the left side valve surgery, once the tricuspid valve regurgitation is greater than grade 1, your mild tricuspid valve regurgitation with the elevated pulmonary artery pressure, we will routinely perform the annuloplasty for the patient. Yeah. So at that time, we didn't perform the annuloplasty. That means the tricuspid valve condition is okay. And Dr. Chen Bo-Song, could you present how did you do for this case?
Thanks for the discussion. Because the previous double valve surgery, the reduced surgery risk is relatively high. So after discussion with patient, we choose the TriClip operation with G4 XTW to do the TER from the to clip the septal leaflet with the P1 leaflet to minimize the defect of the tricuspid valve. So we can see this, the major defect was between the septal leaflet and the P1 leaflet. And after the TER, we can see the TR downgrade to the moderate. However, the lower leg swelling recurred after 1 month. And the TTE showed the septal leaflet cap may be lost with a massive TR recurrent. We can see this is a septal leaflet and the posterior leaflet, and This bouncing maybe is a lost clip with a massive TR. So we choose to perform a reduced surgery with tricuspid valve repair. And then we can see the cleft clip was lost and the septal leaflet was ruptured. This is in the surgeon's view. We can see the cleft in the septal leaflet was lost. And we perform a tricuspid valve repair reduced surgery to repair the septal leaflet rupture site and perform a P2 to septal suture with a P1, P2 edge-to-edge suture to close the major cleft. Finally, we use a 28 millimeter NC3 ring annuloplasty to reinforcement of the annulus and to reduction of the dilated annulus. The postoperative T showed a mild TR with a mean pressure gradient 2 millimeter mercury. And after discharge, we can see the TR remain mild with a mean pressure gradient 3 millimeter mercury.
Okay, Dr. Tsai, could you accept the result?
I think the imaging result is pretty good, but I'm curious about before and after the tricuspid valve surgery. Some data like the CVP, pulmonary pressure, and the patients some discomfortable condition like the pleural effusion, edema.
The major problem of the leg edema is improved just because the initial leg edema improved after the first triclip attention, so she discharged smoothly. But however, the symptom recurred, so we found the triclip lost, and after the redo operation, the symptom including the leg edema and the pulmonary effusion. There's no very significant pulmonary effusion before and after the operation. The major improvement is the leg edema improved.
Yes, yeah, this is Ivan from Hong Kong. Yes, first thing is I very much appreciate the decision to perform the repair, because right from the first slide, with the mechanical heart valve, I already can foresee that for the repair would be a much nightmare because of many of the acoustic shadows and also the challenges. Of course, some operators would choose to use the eyes with the TE to do that. But to me, if this is my case, I would go for the transcatheter replacement at the first place. Because nowadays, I would say that if the patient can tolerate anticoagulation, so this patient have to do anticoagulation anyway. And then if the patient has quite fair right ventricular good function, then probably I would choose the transcatheter replacement instead of the repair.
Well, because there's no transcatheter replacement in Taiwan currently, we only do the transcatheter replacement using the compassionate use. So routinely we cannot use TTVR. So in this case, we saw that the patient has received previous surgery. So redo surgery is difficult and carry a high risk. So we decided to do a clip first. So initial evaluation, we saw that the septal leaflet is over 1 centimeter, 10 millimeters long. So, and looking back at this case, because we opened up, the septal leaflet is only 5 millimeters long, because from the annulus to the tip of the septal leaflet, we think that we miscalculated, we mismeasurement, because why? Sometimes they are not in the same plant, and then we know that when you have a big right heart, the septal leaflet tend to tender into the right ventricle. So some portion of the septal leaflet will attach to the ventricle. It's not move. It's not moving. You cannot put a clip into that portion. So only the tip portion that you can clip. So you see that when we open up and see the clip only grasps a little bit of leaflet. So that's why when you have if the patient drink more water, the annulus dilate, because the clip only clip the leaflet. You did not shrink the annulus. So the annular dilatation, you put more tension on the leaflet tear. So the TR recurs, we lost. So we open up, with the surgery, we can put an annuloplasty ring. We actually active shrinkage the annulus, and we put less tension on the leaflet. So we do the same procedure. We do a edge to edge with a surgical suture. We get a better result because the annulus is active shrinkage. With the clip, the annulus is passive reduce. You put more tension on the leaflet. I think that's why.
I think it's a very challenging case, especially for the imaging point of view. But I'm thinking about the strategy to put the clips because it's very difficult to judge from the transgastric view where the leaks come from because sometimes you go a little bit off angle. I know it's very difficult to get a very good 3D view from TE because of double metallic valves. And I saw that the strategy is to put a clip in the posterior leaflets and the septal leaflets in this setting of 4 separate like portion of leaflets, but overall it's still due to white annular dilatation. So would kind of strategy maybe going back from the annulus towards the middle may be a better strategy, and some experience is to maybe more clips can distribute the tension, pressure for more robust long-term outcomes.
This case is an earlier case that initially that we saw that the major leak is from the septal posterior. Because initially we didn't see any leak from the septal anterior, so we decided to put a clip in the septal posterior. But looking back now, we can use the zipper method to reduce the tension on one clip.
Yeah, I think just highlighting the fact that when you see such an anatomy for tricuspid tear, you have a patient with 4 leaflets and you have a prostatic, mitral, and aortic. You know that these combinations, even if you have the perfect pictures on before the procedure on table, is very unpredictable. So I'm from Singapore, so we don't have eyes in Singapore, but if you do have eyes, I think these are the cases that you really want to have eyes ready if you are going to attempt to put in a TEER device.
For me, I think I would go for 3D eyes, as mentioned, maybe 3D eyes plus TEE, so that you don't have to move your TEE probe too much. And then probably I will use more than 1 clip just to stabilize the first clip. So it's actually more secure if you use 2 or even 3 if needed. Try to get a better result. Then you will have, especially when the septal leaflet is so short, only 5 mm. So I would definitely be more secure to add 1 or 2 more clips to this.
Thank you, your comment. And we will move to the next. Next speaker is UC He from Singapore. His topic is imaging in tricuspid valve. Please, He, Dr. He.
Thank you very much. Trying to find my slides. Okay. All right. Good afternoon, everyone. My name is Siwei. I'm an imager. I will try to give an overview of what imaging is required in patients with tricuspid regurgitations. I think it's important for us to recognize that we are quite used to categorizations of TR into primary, which is a leaflet problem. But nowadays, you have seen that with ICD leads or cardioimplantable electronic devices related TRs, it's actually categorized as a different category because of the management is different. 90% of the time, you are dealing with functional TR, and functional TR is divided into two phenotypes. One of that of ventricular functional TR, similar to what you get for functional mitral regurgitations, where you have RV dilatations causing tethering of the leaflets. And this is different from atrial functional TR, where the pathology is that of RA dilatations with tricuspid annular dilatation, wherein the leaflets is not tethered. And in that atrial functional TR, we actually have patients with RV that is not dilated. In fact, it's conical in shape. Why is it important? Because the prognosis is different. In atrial functional TR, it's better prognosis when compared to ventricular functional TRs. And then I talk about cardiac implantable electronic device related. What we need to do as an imager is that we need to identify whether the lead is inducing TR, meaning there's mechanical leaflets interference because of impingement or adhesions to the leaflet or the subvalvular apparatus. This is usually done using two-dimensional as well as three-dimensional echo. In this case, you can see that the lead is causing leaflet impingement to the septal leaflet, reducing the possibility of coaptation. So we, as the imager, needs to go through this and be very clear that the leaflet is not induced by the lead itself, or it is just associated as a bystander. Tricuspid leaflet, as you have seen, is typically anterior, posterior, and septal. The septal leaflet is fixed, while the anterior and the posterior leaflet can adapt to dilatations of the annulus. Sometimes they can even become indented over the years as they dilate in terms of tricuspid annulus. So septal usually is fixed. Anterior can have indentations, posterior as well indentations. As you know, classically, the typical three-leaflet pathology is only found about half of the population that was sent for tricuspid evaluation on TEE. The next commonest is what Dr. Chen has shown, which is 2 posterior leaflets and a total of 4 leaflet morphology. This has implications when you talk about edge-to-edge repair using the clip or the Pascal system. Imaging the tricuspid valve on transthoracic has to be done. However, it is not easy if you only do two-dimensional method, because there's no way you can visualize 3 leaflet or even 4 leaflets coaptation within one view. A lot of time we depend very much on the anterior tilt in the 4-chamber view or the posterior tilt. And this will help you identify whether it's septal anterior or septal posterior, depending on the amount of tilt as you do in apical views. We like to do 3-dimensional echoes even on transthoracic because we can see this very clearly, and you can then visualize the leaflets coaptations. None but not least, the most important for us is actually proper evaluation on transesophageal echoes. This is done on multi-levels. It's because the anterior leaflet, because the tricuspid leaflet is in an anterior structure. When you do a TE, the probe is through the esophagus, and this TE probe through the esophagus will not allow you to on-fast visualization of the tricuspid annulus, unlike that of the mitral valve. So we use multiple views. The standard or the home view for us is a mid-esophageal, where we try to locate the anterior pec muscles, because anterior pec muscles give caudate to anterior and posterior leaflets. Then we do a biplane imaging across the anterior leaflet. This will reveal the anterior septal coaptations, and sweep laterally, we see and review the septal posterior coaptation. By systematic approach of mid-esophageal, which is quite straightforward, you can then have a visualization of all the leaflet coaptations. A lot of times, such as the case was presented earlier, does have a left structure, and we want to go lower esophageal, where we only see the right atrium and remove all the LA structures, allow us to visualize the tricuspid valve much better. None but not least, transgastric view, it is key for us to visualize the leaflets as well as the amount of coaptations and where the TR gap is. A lot of time, we can do this at the 0-degree transgastric view where we do a biplane across the leaflet tips, and this allows us to see the leaflet tips very clearly and easily. Rotate to about 90 degrees allows you to see subvalvular apparatus, and this has implications, especially if you want to do tiered procedure where the clip may go under and you get caught into the commissures. So sometimes we rotate in the X-plane, allow us to see subvalvular entanglement or to avoid subvalvular entanglement. As I said, the implications for T-tier is that transgastric view is key for us to measure the leaflet length, the gap, as well as the orientating in terms of the clip positions perpendicular to the line of coaptations. We like to go to put a first clip in the septal anterior coaptation, especially in the case of a functional TR, where this will reduce the annulus. At the same time, we try to put in a second clip, if not another clip in the septal posterior coaptation, such that the key is to reduce the annulus and to improve coaptations. So I think transgastric view, it is key for us to orientate the clip to the line of coaptations before we grasp. Three-dimensional TE is actually the most important thing when we analyze or visualize the morphology of the tricuspid valve. This is a case of an annuloplasty ring with residual tricuspid regurgitation. Three-dimensional echoes confidently gives you information of the cause of the TR, which is in this case a dehisced ring. And in these cases, obviously, edge-to-edge repair is not something that we could do, and this patient was sent for a redo surgery. The difficulty about tricuspid regurgitation severity in the assessment for us as an echo person is that there are multiple ways that you have to look at integrated approach of tricuspid regurgitation severity. And to make it even harder is that the two-dimensional way as well as Doppler quantifications is very, very hard because of its limitation. As you can see, the tricuspid valve leaflet is complex, variable, it has regular, multiple jets, non-planar, PISA will not work, and it's a system on the right side which is sensitive to preload and cycle length, and it's also affected by how the RA and RV geometry is. And because that's the case, we tend not to be able to do PISA quantification well, and a lot of time we advise patients to have TR assessment during echo when the patient is in euvolemic state on stable or maximum guideline-directed medical therapy, and we would like to do it in quiet respiration without too much of respiratory variations. And we are now used to the 5-tier grading of TR, and this is done particularly using three-dimensional Doppler, where we can direct the vena contracta area doing a direct planimetry. This way allows us to do it without geometric assumptions. You can almost do it before as well as after a clip procedure. Usually after a clip, you have multiple TRs, and this can also be done by summations of the vena contracta area. And patients that's referred for symptomatic TR are usually very severe. They are delayed representations. So we have more than severe, and severe is now divided into 3+, 4+, and 5+. And this is how we can use our numbers of vena contracta area to differentiate the extent of severity of TR. RV functions is actually very important. As you can see, RV functions can be analyzed by multi-parametry approach, again with echo, but what is more important is to look at two-dimensional way of assessments, such as fractional area change, as well as three-dimensional echo. Sometimes free wall strain can also be a sensitive way to detect subclinical RV dysfunctions. Of course, we talk about RV-PA coupling. When it comes to non-invasive way, the ones that we rely most is actually a TAPSE over RE-SP ratio. However, this is not going to be very precise, especially you know that invasive PA pressure measurements is more accurate than the non-invasive that using echo. So we like to get an invasive PA pressure measurements, and then we can use that as the TAPSE over invasive PA pressure measurements. Cutoff of 0.3 seems to dictate worse prognosis in patients with TR. As you know, TR transcatheter tools or devices are not quite available in this part of the world. This is very nicely put forward by Kent, who is sitting here in our audience. What is available now in the Asia Pacific? And in Asia Pacific, the TEER device are really MitraClip, or what we call TriClip. And you may have Dragonfly that we saw earlier that works on the tricuspid as well, but these are all investigational. And then with the annuloplasty device, we can have the K-clip. Again, K-clip is something that string the annulus that reduces TR by leaflet coaptations. When it comes to transcatheter TV replacement, in Singapore, we don't have any of that, but I know in China as well, in Hong Kong, you are available to all these transcatheter TV replacement technique. So I think what is important for us is, as a group, when the patient refer to you in your center, you need to go through your multidiscipline heart team evaluations. Those with low risk should be reconsidered for surgery because that's the time-tested surgery and the outcomes. And for those who are high risk, really it depends on what is your center expertise and whether there are devices available. And of course, work with your imaging team, and in this case, not just TEE, but also a CT for transcatheter valve replacement kind of planning. This, you have seen it earlier. This is just factors when you decide in patients with TR, patients who has, well, I think the low risk procedure is really TEER, and TEERs are useful if you have good anatomy. What is good? Small gap, 3 leaflets, with good imaging, no leads. And those who are really clearly not a candidate for TEER will be the large septal lateral gap, as well as those with poor imaging, with ICD, with CITD leads, as well as leaflet that is not suitable to grasp. Then we really have to talk about replacement therapy. When it comes to CT measurements of TR, if you are considering TV replacement, then these are really what you looked at. You look at the annular size, you look at the IVC entrance, and you can also predict the fluoroscopy angle. Also, if you are considering annuloplasty device such as the K annuloplasty, you have to also do the RCA on the angiogram. Just one slide on imaging. When it comes to edge-to-edge repair, you really use 3-dimensional imaging tool, and in this case, we do a lot of MPRs. MPRs allows you to actually do and explain, if not off-axis orientation of the imaging, such that you are perpendicular to the line of coaptations. Sometimes in this case where you have left-sided by mitral valve prosthesis, imaging is really impossible despite the fact that you have done multi-level imaging. This is where we resort to eyes. Obviously, if you are in a country that don't have eyes, such as mine, you sometimes even reject the patients because we are just not confident. Sometimes you do transthoracic limited imaging to just make sure that the leaflets are grasped confidently besides TEE. This is just an example of how mid-esophageal TEE view are just not good enough for us to be confidently seeing that the leaflet are being grasped. 3-dimensional eyes is really helpful here. So I would like to conclude that deep understanding and visualization of tricuspid anatomy and RV functions is key for us to manage our patients for selection of appropriate therapies. And the future imaging may help us in the future, for example, computational modeling as well as AI-guided TR assessments and diagnosis of TR probably will help us very much to make our life much easier as an imager. Thank you so much for your attention.
Very nice talk, but our time is delayed, so we will move to the next speech, please.
Yes, so the next lecture will be given by Dr. Liu Jian, who I believe is a surgeon, and he is going to tell us about case selection for tricuspid valve replacement. Dr. Liu, please.
感谢振兴医院魏院长的邀请。那么我是来自于中国大陆广东省人民医院的心脏外科医生，我是一个外科医生，跟大家一起沟通一下。但是我们也做除了这个传统的心脏外科手术之外，也做这个介入的瓣膜手术。那么我们中心也做了比较多的这个3尖瓣 Lux 等这些一系列的瓣膜的一些手术。那么也想跟我们台湾以及东南亚的这个同道们一起探讨一下3尖瓣的一个介入治疗的一些选择。 那么到底是修复呢，还是置换？那么我们都知道，三尖瓣的疾病长期被忽视，那么被称为这个遗忘的瓣膜。那么在孤立性的这个三尖瓣关闭不全当中，它中重度的比例是达到了8.1%，那么大多数是跟我们房颤相关。我们也知道，严重的三尖瓣关闭不全会明显的增加死亡风险。那么目前来说，三尖瓣的管理还没有一个特别明确的、很合适的这样的一个体系。那么中国大陆陆芳林教授，那么联合多中心的专家提出了这个三尖瓣综合征这样的一个概念。那么因为我们发现，除了这个心脏的本身的问题，还可能合并了其他的脏器的这个影响。那么这个严重的三尖瓣关闭不全，它的生活质量是非常的差，心脏会显著的扩大，会有严重的那个胸腹水，那么合并的下肢的这种水肿啊、那个溃烂等等。那我们知道三尖瓣的解剖大家都非常的熟悉。那么对于三尖瓣的反流来讲，它对于这种前隔侧这种三尖瓣的瓣环的扩张是导致功能性三尖瓣关闭不全的最重要的因素。而外科治疗是治疗这个三尖瓣关闭不全的一个很重要的方法。那么尤其在这个左心瓣膜手术之后，我们做了这个主动脉瓣、二尖瓣，那么这个进行瓣膜置换手术之后，那么在若干年之后，它比较容易会并发三尖瓣的重度的关闭不全。但是这一类的病人，你如果再次去做手术的话，它的死亡风险相对来讲就比较高，接近最高能达到25%。在我们中心呢，也做了一些微创化的一些尝试，用腔镜的方法来减少心脏本身的游离，而直接切开心包来做三尖瓣的修复或者是置换。那么相对来讲，它能够降低这个外科手术的一个死亡的一个风险，但依然这一类病人往往是比较棘手。那我们也知道，不处理它的话呢，这个患者的1年的生存率也会偏低，所以我们会有什么样的一个方法去做呢？那么目前来说，这个在外科手术当中，置换还是一个独立的死亡的风险因素，所以我们尽可能的是采用成型的方法来做这个三尖瓣的干预治疗。而记录的方法呢，我们大家都非常的熟悉，包括了瓣环的成型，包括了这个瓣膜的置换，而瓣膜的置换又包括了异位的置换和这个原位的置换。那么针对不同的这个人群、不同的这个疾病的特点，我们可能可以有不同的选择。比如说右心功能非常非常差了，那么我们可能再去做个原位的置换，对于他右心功能的挑战是非常的大。而对这一类病人，我们又要改善，比如说他这个肝肾功能的一个严重的损伤的话，要降低他的静脉压力，那么有可能这个异位的置换也是一个选择。但是通常来讲，如果不是到了一个中末期的状况，原位置换可能是我们的更好的一个选择。而这个圆对圆的器械，那么对于包括像 Tracklip、像 Forma、Pascal 等等，能够去降低我们瓣叶的对合的间距，能够减少我们这个三尖瓣的一个反流。那么目前临床应用也是非常的广泛。那么不同的介入策略对这个理想的解剖还是要求会不一样。对于这种瓣环的扩张，那么我们是直接的去进行，包括这个 child line， 包括这个我们cardio implant 等等，以及 cardio band， 这些都是进行一个瓣环的扩张，是模拟外科的我们瓣环成型手术植入一个新的这个人工瓣环，去缩小它的一个这个对合的间距。另外一个就是器械方面的瓣叶方面的一个器械，瓣叶方面器械就是说我们通过瓣叶的一个对合，用这个前夹等等装置去增加我们瓣叶的对合，增加了瓣叶对合之后呢，来达到减少甚至消除三尖瓣反流的一个目的。还有一个就是我们的异位的这些置换。那么原位置换目前来讲，全球只有 Evoke 是正式获得了 FDA 的一个批准。那么像这个 Luxvalve 以及 Luxvalve Plus 等等，这些也正在进行一个临床试验。那么我们知道，在香港、澳门、台湾等等这些地方，以及欧洲也在进行一个商业化的一个应用。 也取得了非常好的一个效果。而三尖瓣治疗来说，我们看一下这个全美的数据库，2016年到2020年期间，那么我们看，不管是这个在全因死亡率，在这个并发症、住院时间，甚至是治疗费用方面，这个三尖瓣的介入修复似乎都要优于三尖瓣的外科修复。那么因此，这个2021年的欧洲指南那个首次推荐在有丰富经验的心脏瓣膜中心，对于有症状并且是外科手术高危，同时解剖条件合适这样的一个功能性三尖瓣冠不全患者，可以考虑经导管的一个治疗。这个治疗当中也引用了这个 Loose Valve 当时的1年的这个随访研究的一个结果。那么 TriClip 是一个倾向性评分匹配的一个研究 ，TriValve 以及是群。那么它总共的去纳入了268对，那么经过充分的倾向性评分匹配的这样的一个患者，那个一组是器械组，一组是药物组，平均年龄是77分。那么 Euroscore 的评分也是大于12分。与单纯的这个药物治疗组相比，器械组那么可以提高术后1年的一个生存率，那么能够降低心衰在住院的一个比例，那么取得的结果还是比较理想。那么但是它是一个行政医学证据，还不是足够的，所以这个 TriClip J4 那么又进行了一个 TriLuminate 这个 RCT 研究，那么它的1年的结果我们可以看到，总共纳入的350例患者当中，这个 TriClip 就器械组能够在超声的结果，也就是说三尖瓣反流严重程度的改善上取得了非常好的一个效果。但是呢，它在硬中点，在包括全因死亡或者是三尖瓣手术需要再次的三尖瓣手术，以及心衰再住院率这方面没有一个阳性的一个结果。那么所以目前来说，对于这个 TTR 主要的获益是集中在这个三尖瓣这个反流程度的改善和生活质量的改善上面。那么它对于这种硬中点的改善，目前还没有一个阳性的结果。所以我们也可以理解，因为很多的三尖瓣的这个病人，他的病程是比较长，进展相对是比较缓慢，可能我们在1年的时候不一定能够得出死亡率等等方面的一个显著性的一个差异。那么这个 G4 的这个数据目前看起来，TriLuminate1年的这个结果在安全性方面还是非常优异的，在改善生活质量方面也得到了这个临床的认可。那么这个 TriClip 是一个类似于我们外科的 case 三尖瓣修复手术，就是环缩我们的后半环。那么这个器械呢是总共纳入了这个96例的重度的 TR 患者，那么平均年龄是72岁 ，Euroscore 的评分是10分。它的主要的有效性终点为术后1年的时候 ，TR 严重程度至少降低2级。那么主要的一个安全性终点为术后1年时间的全因死亡率。结果就是我们会发现86%的患者，他的一个 TR 的严重程度至少是降低了2级。那么1年的全因死亡率是只有5.21%，是目前这些临床研究当中应该是最低的一个临床研究。而 Pascal 系列它也进行了一个前瞻性、多中心跟单臂的研究。1年随访我们会发现，这个有36例的患者，总共36例患者中有31例，它是能够达到中度或者是更低的三尖瓣冠不全。而纽约心功能分级，它是绝大部分的病人是能够改善到1级或者2级。6分钟步行距离能够增加94米 ，KCCQ 的一个评分总体能够提高18分。那么这个但是在全因死亡率跟心衰再住院率比例的方面，它的优势并不是特别的明显。那么 Evoke， 那么是我们目前来讲 FDA 批准的唯一的一款这个商品化的一个器械。那么它是由牛心包瓣叶跟这种无创伤锚定的这样的一个支架来组成的，它不是完全依靠镜像支撑力来稳定这个 device， 那么跟主动脉瓣 TAVR 这一类设备并不太一样。那么因为 然后 CHEST 的研究它是目前样本量比较大的，那么176例的这个平均年龄78岁这样的一个症状型 TR 的1年随访结果。这个研究呢使用了这个筋骨系统，那么它比这个其他的录入相对来讲，它的创伤会更好，更小一点。那么对患者的这种并发症的发生率似乎会更加的低。那么它的器械的成功率可以达到94%。那么1年的一个随访结果显示，那么能够明显的改善3年半的关闭不全，那么改善临床的症状和生活质量。那么这个作用并且能够得到一个持续，那么全因死亡率跟心衰再作用率分别是9.9%跟11.6%。那么因为这个研究它不是一个 RCT 研究，它是一个单臂的前瞻性的研究，那么所以它又进行了一个 CHEST-N2， 那么这是一个随机对照研究了。那么它的一个总的入组病人是392例，其中有267例的患者是分到了我们的器械组。那么有133例是分到了药物组，两者基线平衡的很好，平均年龄是79岁。那么有95%的病人是合并了房颤，那么有38%的病人是有起搏器或者植入式心脏除颤器这样的一个病史。这个研究当中，患者的平均的手术时间是大概1个半小时，那么平均的器械植入时间是大概1个小时，平均住院天数是3天，93%的患者是顺利出院。1年的随访，我们会发现器械组有72.6%的患者他没有残余的3年半反流，有22.6%的患者有轻微的反流，3.8%的患者有中度反流，和1%的患者有重度反流。这个结果是也显著的优于这个药物治疗组。那么在1年的时候呢，有66%的这个患者呢 ，KCCQ 评分呢至少增加了10分，然后那个79%的患者至少减少了一个纽约心功能分级，17.6%的患者6分钟的步行距离至少增加了30米，那么平均是增加了23.2米，这个结果也是显著的优于对照组，但是它依然在全因死亡率和心衰再住院率这方面没有显著性的差异。那么它的安全性和有效性终点，那么还是比较的理想，所以它能够在第一个获得美国 FDA 的一个认证获批上市。那么这个 LuxValve Plus， 那么它是一个 Travel-2 研究，那么评估 LuxValve Plus 颈静脉系统植入3年半的原位置换系统。那么它跟这个 Travel-1 的最大的区别就是它的入不一样。那 Travel-1 的主要就是从胸壁切口，那么通过右房来植入，它需要外科来操作。那么因为往往这个3年半重度关节不全的病人，他可能合并了肝肾功能的不全，那么凝血功能往往是比较差的。那么这一类病人，他如果我们通过胸壁切口、心房切口，那么依然有可能会增加他相关的手术风险。所以这个研发了一个经皮的颈静脉的一个系统来进行一个这个3年半的一个植入，瓣膜是一样的。那么它这个有效性结果是在30天的时候，那么98%左右的患者是没有或者是有轻微的伴奏反流，在6个月的时候，7%的患者是没有中度及以上反流的，在1年的时候，依然有95%的患者是达到非常好的一个效果。30天的时候呢，有80%的病人心功能能够提升到1到2级，然后在6个月的时候92%，1年的时候85%，那么这个结果还是比较理想。在30天的时候 ，KCCQ 的评分平均是提升了15分，6个月是20分，1年是21分。那么 Travel-2 的研究，它1年的随访结果还是展现了 LuxValve Plus 在中长期的这个优秀的临床表现。那么在进入更长的临床观察期之后，那么如何保持较低的这个安全事件的发生率，还是需要继续的一个进一步的观察。那么最后再跟大家一起回顾一下我们这几个临床研究，包括了 TrackLip 的倾向性评分匹配研究， TrackLip G4 的 RCT 研究，那个 Pascal 的这个随访研究，然后 Evoke 的单中心的前瞻的单臂的多中心研究，以及 Evoke 的 RCT 研究， LuxValve 的这个目前的2个 这个前瞻性多臂单臂多中心研究，还有目前正在中国大陆进行的这个 Travel to RCT 研究。那么我们也期待他们的结果是否能够推动我们三尖瓣治疗的一些变革。最后小结一下，就是对于这个三尖瓣疾病，我们确实是在过去的很长一段时间里，那么似乎忽视了三尖瓣，因为它的整个的病程进展是非常的缓慢。然后呢，等它到了非常严重的程度，又鉴于它有一些多器官功能的一些变化、复杂的这个病理生理的改变，那么包括外科手术为数据评估的方法的局限，所以三尖瓣治疗目前来讲还是没有一个特别公认的这样的一个指南或者是方案。那么在器械治疗方面的话呢，除了外科手术，那么我们也在考虑这个经导管治疗。那么从指南来说，对于有症状的手术高危，那么结构条件又合适的这些病人，使用经导管治疗都能够起到一个不错的一个效果。那么解剖结构对于这个选择理想的三尖瓣介入治疗策略和介入治疗器械，那么这个两个选择来说是非常重要的。那么最后我们也看到了，不管是在全球还是在局部，那么这个三尖瓣介入治疗目前是处于一个相对比二尖瓣、比主动脉瓣起步更晚的阶段，但是我们也看到它的一个庞大的一个病人的群体，以及它需要治疗的这样的一个需求。所以，随着我们的更多的这种有这个创新性的器械在进入到我们临床的应用，我们也希望我们能够有更好的对我们这个严重的三尖瓣关节不全患者的综合的治疗的一个措施。那么非常感谢这个振兴医院对我们的邀请，那么也在这个过程当中学习了非常多。那我今天的汇报就到这里，谢谢。
Thank you so much, Dr. Lien Jin, for a comprehensive talk on tricuspid valve replacement. Let me invite the last speaker for these sessions. That is Dr. Creed Durong-Pitsi-Koo. He's a friend. He's a pediatric cardiologist with lots of experience also in transcatheter valve intervention, and he's from Siriraj Hospitals from Thailand. Dr. Creed, please.
Good evening, and thank you so much. Thank you, CV and organizing committee for inviting me for this wonderful talk. I try to cover the topics in the overview on the challenging. Our experience is more or less based on a TriClip. We have done around 60 of them. My background are congenital, so around 1/3 of our TriClip have ASD device. So it's a little bit challenging for imaging, but my second part of the talk will focus on one patient that we did the TriClip and has some problem and have to go off surgery, and I'd like to show you something on the result after the surgery. So I think the first challenge is the amount of numbers of patients that we are going to encounter. Tricuspid has been known to be a neglected valve. It didn't cause a lot of obvious symptoms. It started to see hospitalization recently, and a lot of time we get sent by a specialty like the EP, like atrial fibrillation, after they finish treating the patient and they still have some right heart symptoms. So this is something that we have to keep in mind, that number of patients are actually not small. It's a between aortic and also mitral. So this is a very good article that by Rebecca Hahn just recently published, and try to focus. I think the 4 things that I can conclude it, and a lot of speaker has done a lot of good job of. First, we need to understand anatomy. Tricuspid is totally different than the mitral valve. Secondly, I think quantification is still an issue, both in the regurgitation itself and also in the right ventricular pumping functions. The third is that who will benefit on this intervention whatsoever, either the clip, the repair, or the replacement. And I think we need to refine the surgical, since there are still some gap after the interventional treatment that patients still continue to have a right heart. I understand that we're going to have another talk on the optimal timing for tomorrow. We can discuss it. So we know that there's multiple etiology, and people started to focus on the atrial. TR, which is more or less from the atrial fibrillation. So a lot of time, I think two colleagues that we really have to involve. One is the EP colleagues, the other one is the heart failure specialist. I think this becoming a lot of challenging. I remember so many times. So in our hospital, we need to send all the patients for the heart valve team. And a lot of time, 1/3, they will come up to me and say that, did you consult EP yet? Did your heart failure specialist already optimize the GDMT yet? And I think we never know that when it's enough that after all of the other causative of this symptomatic of this patient is done, that again, this patient will totally benefit from the tricuspid intervention procedure. This is more or less that CV have done a good job of letting them know that there are several mechanisms. I will just skip. Second point that I like to focus is the quantification. So we understand that the ERO, which is a regurgitation orifice, is something, and the vena contracta is something that we are readily available and in use in many hospitals. But one of the studies just come out 2-3 years ago and try to focus on the angulation or angle, that adjustment on the vena contracta. And if you look at the last slide here, you can see that in each category, severe, massive, or torrential, there are at least around 10 either millimeter volume on the regurgitation according to each category. So when they look at that and they say that a lot of time we have seen that mild or moderate or severe, sometimes we are totally underestimated the regurgitation in this group of patients. So this is second of the challenging that first we need to understand etiology. Second, we need to understand that quantification are not that straightforward. And this is normally, and the third one is obviously during the procedure. This is a standard view. I like to show you, this is coming from the Philips. We just come back from the Philips. This is a next generation echo navigator that will actually improve it by put a marker on the device and you can track the device. So this is something that can overcome a lot of problem with the imaging, even in the eyes. We have done around 10 eyes out of our 60 patients. I have to say that I saw problem around only half of them. The other half, it doesn't matter with or without eyes. We still have to go back with the TEE. So I'm still not, we don't have 3D eyes yet. We only use 2D eyes. This is the one. Now, I'd like to get you the patient. So we had one 89 years old patient, has a lot of underlying, have hypertension, dyslipidemia, and have a coronary artery disease, already have bypass, have atrial fibrillation, and had, as you can see on the X-ray, he had 2 pacemaker. One is abandoned leads, the other one. So obviously imaging on the tricuspid is going to be worse. And this is the procedure that done, as you can see. This is the first procedure, and then we try to, so we did 2 clip procedure about 1 year apart on this patient. And this is the eyes at the left upper corner here. It didn't really help me that much. So eventually you end up putting 3 clip. And the right lower corner picture is a massive regurgitation. This is only 1 month after the 3rd clip. So something must really going wrong. I understand that in Thailand we have probably, from what I know, that we only have 3 Lux valve procedure and around 4 or 5 Trix valve. So eventually patient end up having a surgery. This is a surgeon note, had some tear in the posterior leaflet and put the valve, epic valve in. But interestingly, I like to show you this. So I went to talk to pathology and see that what is that valve look like. Where we take it out, you can see that in the middle here, this is a fibrosis around the clip that we has been doing. You see that on the right side, the valve looks a little bit shiny, looks a little bit thin when compared to other valve, right? So we look at it. First thing, my pathologist explained to me that there are some calcification in the valve. This is something that I have, honestly, I have not looked into the pathology before. So part of the valve, it's already calcified. So that's been, but I tried to discuss and she told me that it's difficult, but she don't think that the valve can move, put it this way. So adenoplasty effect is not gonna work. with this stiff of the valve with the calcification. This is around the clip. You can imagine and you anticipate the fibrosis. The other thing is a myxomatous degeneration that we have seen in this group of patients. So I think we are not really, so we talk about anatomy a lot, but I don't think we really look at the tissue quality a lot in this group of patients on the clip. But I think this group of patients, if we have a way to identify it right beforehand, we might be able to explain that the clip or the tricuspid valve repair won't work. I try to put this in the GLIDE score. Obviously, this is not a favorable patient on this one. So my challenging is that so far we have problem with we have some discrepancy in the quantifications. We understand anatomy. A lot of patients, let's say 80 or 90% have a reasonable image. We still have another 10 to 20% that had a not so reasonable image, and we clip it. But I think we are missing something on the part of the anatomy or histology or quality of the valve that we have not looking into. Thank you very much.
Thank you, Dr. Creed. So what he has highlighted, apart from all the challenges, is the last part, which is tissue quality. And I'm not sure who is here, but any of the imager or even the surgeons can tell us that tissue quality assessment pre-procedure is almost impossible. Yeah, we can, as an imager, see the movement and the thickness, but it will be very impossible to say that that's fibrosis, and even calcium appreciations on echo is just bright. And that can really be compounded by increasing the gain. So we used to really appreciate tissue integrity just based on the movement and the thickness. So I think that part that you said about tissue characterizations is really difficult. I'm not sure whether any other people has...
Maybe one thing, there's a paper, but I'm not quite sure, but I think we are looking at the photon counting CT, which is a CT that had a very, very slight, and they are really can separate. My concern, I think myxomatous chain is not that surprised. My concern is if you had a calcification, which is, I have not seen a lot. Personally, I have not seen a lot and not anticipate this. My concern that we really need to look. If the we know a lot on the calcify on mitral valve, but calcify on tricuspid valve, I don't know. I have not seen a lot. So I think we might have to look into that.
But we have to know that tricuspid valve is always thinner than the mitral. So whenever you do tricuspid valve intervention, we try to optimize the imaging, optimize the position, and maximize everything before we really do the grafts. So once you do the grafts, try not to release and do it again, if possible, of course, because it's always a balance, a trade-off between losing the valve or even break the valve when you have to do a lot of grasping.
May I ask the panel, my challenging now is that most of, around 20% of my patient 2 years after clip, it's progressing, right? We understand that we're not going to stop diuretic, but I don't know what is in your experience now. If you get, let's say, mild or mild moderate as a result.
I'm cardiac surgeon. In our cardiac surgery field, once you perform the mitral valve repair, you did not perform the angioplasty, the durability is bad.
I think it's a common problem. So we now focus on the index procedure to optimize it as much as possible. And possibly in the view of transcatheter treatment, we could have hybrid therapy, maybe add a transcatheter valve or things like that. So I think this is the limitation we have right now.
Understood. I don't know, Simon, several of my patients, we clip SIP on the AS, everything looks fine. 6 months, PS, it started to leak. This is something that out of the blue for us.
I think we get that experience as well, but then I think it needs more time to know. But for example, if the atrial dilatation still continue to progress due to arrhythmia, for example, then we cannot stop that from dilating. So I think we treat at the valve level, but a lot of things that we really don't know. Thank you for your experience.
Okay, we will close this section. We will transfer to Dr. Chen Yicheng to chair this section.
This section with Michael Lee, Tsai Yiting, and we have a expert of Simon Lam, UC Hall, and Ivan Wang, and Xiongmin Chen, Xiong Daifu. Okay. Let's start this session with Simon Lam's overview.
So thank you for your introduction. So it's just an overview of on the topic of mitral valve repair surgically or transcapsularly. So we know it's very complex valve. We cannot just look at this valve as look at aortic valve because it's so complex. Overall, we want to preserve the geometry and the physiology around. And we know from surgical experience, always think of repair first. And the last thing that you think of is replacement. Because native valve works better than artificial valve. Less endocarditis, less affecting heart function, better quality of life. And so repair always has the first choice. And also a better preservation of left ventricular function from animal study, also from human study. So what are the options? So usually the sequence for mitral valve repair in a surgical point of view, first of all, assessment. You look at the valve and you think about commissuroplasty, suture, endoplasty, whether you want to add Cody, maybe this is a case of Cody rupture, then you need to Cody, and leaflets, you may want to have patch augmentation, and you may do leaflet plication. So you can see that the surgical repair in one go, you involve different aspects, unlike transcatheter. Transcatheter, you need to maybe cord insertion, maybe you can do edge to edge, but surgically you can do a lot of things in one go. So we know we need to preserve chordae. This is good for valve function, good for LV geometry, and ring valvuloplasty is commonly performed nowadays, especially if the etiology involves functional dilatation of the mitral annulus. Chordae repair, in case of a ruptured chordae, is always good to put chordae to fix the pathophysiology. So patch augmentation would be important because sometimes not only the chordae are degenerated, the leaflets you may need to put patches to augment it so to get the best results. So what about transcatheter? So it really depends on what is available in your toolbox. For example, in between we could do off-pump neocord procedure. I think it's also do quite a lot in Taiwan nowadays. And mainly is to do assessment of the anterior and posterior leaflets to see whether it is a good anatomy. The best anatomy is the posterior leaflets at P2. So it's best to treat if there's central prolapse, long leaflets. When you add chordae to the leaflet and you pull and fix on the apex, that actually could mimic the outcome for surgical cord implants. So you can see the actual procedure is to do apical wound. It's a very clean procedure, and to give heparin or echo guided. And during the procedure, you will look at the leaflets. You target your cord device, crossing the mitral valve, grabs the posterior leaflets. You can see that the right-hand side, the leaflets are pulled down by the chordae. You can see immediate improvement in hemodynamics, and usually it is very, very reliable and predictable. And usually we give 2 or 3 cords to improve the sustainability. So CLIP is a well-known device which is proven in clinical trials and in clinical experience. It works well no matter it's a functional type of mitral regurgitation due to left ventricular dilatation. Usually you need to do multiple clips for that purpose, or it's due to degenerative etiology, like in this one, is a patient with prolapse. And with advancement in clipping, and people are doing more tricuspid, so mitral become an easy job nowadays. But you still need to do very careful assessment, especially we usually rely on multiplanar assessment. when you go to the commissures for clipping. So Pascal is a good device to use as a option for edge-to-edge repair. The two options include one is a spacer and one is a smaller one with the ACE device. Just now we have seen the Dragonfly device, which technically, procedurally is similar to what we do for edge-to-edge repair, but for clip itself, there's a spacer that you can control the tension before the final release. Especially for patients with functional etiology, I think transcatheter works quite well, and also those patients are usually sicker and may not be good for surgery. So I think now we also with data backup, we're doing more and more tier for patients with secondary ML or atrial functional ML. So lastly, there are lots of options that come and go, including annuloplasty, because we're working on the leaflet levels, but we're still lacking devices that we can fix the annulus. So there had been Cardioband, but at this point, it's still not very sure whether this is the future yet. We have techniques, maybe can like doing something on the leaflets, including anterior leaflet augmentation. So overall, it depends on what your surgeon's experience, what's your heart team experience, and in our institution, so with patients with mitral valve disease, if it is fit for open heart surgery, then you can consider sternotomy type, or you can do MIS, minimal invasive surgery. It also works very well with robotic surgery. And if the patient is having high risk, advanced age, or even moderate risk, especially those who are functional etiology, then you need a TE assessment, whether they were eligible for transcatheter treatment with MitraClip, or in between you can choose transapical off-pump cord implantation with new cord. And also other factors that you want to take into consideration include, there may be not just one single valve, there may be multiple valves that are involved. Transcatheter, maybe at one time you can treat one, but definitely you can stretch the limit doing concomitant valvular implants, valvular repair at the same time, but it depends whether the anatomy are suitable. Second is AF management. You can do a mitral valve surgery with a beautiful, successful MACE procedure, but you can also argue, nowadays you can do MitraClip plus PFA together. But in reality, it depends on availability of device, approval, reimbursement process, institutional experience, physician's preference, and many other factors. So just a glimpse, because of the limitation of the transcatheter techniques, TMVR is on the horizon, but it still carries its own intrinsic problems. So thank you very much. This is just an overview of what we could do in our toolbox, no matter it's treating the patient surgically or transcatheterly for mitral valve pathology as far as repair is concerned. So thank you very much for your attention.
Thank you. We will do the panel discussion at the end. So let's start the next speaker, Xiongmin Chen. Dr. Xiongmin Chen, his topic will be on optimizing the image in mitral repair procedure.
Good afternoon, Mr. Chairman, ladies and gentlemen. And my topic is the perioperative transesophageal echocardiography during mitral valve repair. I mean, in our hospital, we do mitral valve or all the valves. The transesophageal 2D plus 3D is a must. So I'm in the OR almost every day. So I'm going to present one case, just show how important is the 2D and the 3D. Now, that's next. I'm going to use the QLab to show you. First of all, this is the patient just operated about 12 days ago by Dr. Chen, our chairman. And this is a 50 years old gentleman. And from this view, you can see the 2D colors is right here, and this is the 2D. You can see some, leaflet, something funny over there. And also you don't know what's going on. But you look at the right side of the color panel, you'll see pretty significant mitral regurgitation. That's why he needs surgery. First I thought maybe this needs a replacement, but we'll see what's going on afterwards. Now let's go to the next slides. This is the 3D. We'll see a little more details. So the 3D can do lots of things. So I'm using the QLabs and see what we can do. So we go to the QLab inside the 3D. First we decrease the gain, and then we're going to increase the smooth, and then we're going to enlarge it, magnify it, and then just rotate a little bit, and we can see here and here. You can see a ruptured chordae is right here and also here. This is the aorta. Always we put on the 12 o'clock, okay? It's the anterior leaflet and posterior leaflet. You can see the ruptured chordae here and also here. This is the ruptured chordae of the commissure side. This is the A3 chordae rupture 2, okay? Very nicely appreciate from this view. And then we go upwards from the downwards, from the looking from the through the left ventricles, aorta still on the top at 12 o'clock, right here. And you see the anterior leaflets right here, right there. The chordae you can see there, and the chordae from the commissure is right there. The chordae ruptures right there. Okay, let's go to the next one. Now, if we put the color, the 3D colors on, you can see all the flow from the left side, from the right side. This is the A3, or you want to call it P3. P3 down the bottom. A3 is right there. You have a little drop out there, and the LD valves on top of it. Okay, pretty significant. The mitral regurgitation go all the way from here to here. Okay, let's go to the next one. This one is we're looking from the bottom. You can see flow accelerations right there, and those are commissures from here. Go all the way from LV, go to the left atrium. Very significant mitral regurgitation. This is the pre-op. Now let's go to the next one. And then we use the NPR mode. Dr. Chen asked us wants to measure the size of the mitral valve. We do whatever we can. So you can see this side, where you trace the mitral valve area, we got the 4.23 centimeter squares. So this is normal, okay? All right, next go to the next one. This is the post-op. So post-op, because it's still on the pacing, so you can see the post-op, the septum is on the paradoxical, little paradoxical motion. You can still to repair the site. You can see the Dr. Chen put 2 rings there. It's the coronary arteries right there. It's the circumflex right there. LA is on top, and the LV is here. RV is right there. Okay, next one. You can see the color, a little mosaic pattern, because afterwards, just after the surgery, a little bit after surgery, the anesthesiologist would like to put about a little higher dobutamine plus dopamine right there, inotropic agent. So the ventricle and atrium contrast a little pretty strong. So you can see a little mosaic pattern goes through the mitral valve. You don't worry about it. The peak gradient is only about less than 5. All right, let's go to next. So now we have much to do the 3D again. So you see, if it's a patient on pacing, I always use in the 6 beats. All right, we can get a 43 megahertz per second. So you can see nicely. On top is the LD valve. On the bottom is the mitral valve. You can see Dr. Chen put the mitral, the ring over there, and you can see the suture line there, and the anterior leaflet, posterior leaflet. There's some drop out there. So okay, next one, we put colors on, and then the colors, you see just the width of MR. I think this will go away. This only you appreciate because color Doppler is so sensitive, so I just completely ignore this. So this little bit drop of MR, so ignore it. And some drop out on the anterior leaflet too. All right, it goes next. So this may be the last one now. And then afterwards, we trace the mitral valve areas. It's still 3.01 centimeter squares. So the follow-up from the 2D is very nice. So the patient has no symptoms, so it's doing very good. So I think this is the last one. So the 2D and the 3D is a must during the mitral valve repair. Thank you for your attention. Thank you.
All right, thank you. Next, we are going to have a case presentation. Yeah, by Dr. Cheng Chen Yang. Please go ahead.
Yes. Thank you, Chairman, and all the expert panelists. My name is Chen Chen Yang, and it's my pleasure to present our case for you today. The patient is a 57-year-old male patient, and he has a history of hypertension, which is managed medically, and insignificant coronary artery disease. He presented initially with cough, dyspnea insertion, and orthopnea for about a week. He initially went to another institution with evidence of fluid overload and pleural effusion. After they diuresed the patient, they did a cardiac echogram and told him that he needed surgery. And he came to our hospital for a second opinion. Let's take a look at his transthoracic. His transthoracic shows a pretty good heart function and with severe MR, both on personal long axis and apical four-chamber views. Looking at his T, you can appreciate that on the 3D echo that he has ruptured A2 and A3 chordae with flail of the A2, but especially the A3 segments. So he has severe MR in this case. Taking some quantitative readings, his vena contracta is about 1.17 centimeters. His EROA is 1.91 centimeters squared, and his mitral regurgitant volume is 254 cc, so quite a severe mitral regurgitation. On the bottom left, you can see that his atrial height is at least 3.5 centimeters. This is actually underestimated a little bit, but we have at least 3.5 centimeters of atrial height. And his overall his area, mitral valve area, is 4.23 centimeters square. So this is our patient. Overall, he's quite a robust, healthy patient with severe MR at the A2, A3 rupture chordae with flail. That is his etiology. So it would be very interesting to see how our panelists of experts would tackle a case like this. Thank you.
Thank you, Dr. Yang. Maybe we go ahead to invite our next speaker to see how he's going to manage this patient. Dr. Hong Yan Kee. Dr. Hong here, before we have further discussion.
Thank you. I'm Hong Yan Kee from Tri-Service General Hospital. According to the case presentation, we know this is a young male with hypertension and a severe MR. Okay. So I'm a surgeon, and we usually for young adults for severe MR, we want to restore the valve function. So firstly, we need to know what's the anomaly. Like the mitral valve anterior displacement or elongation of mitral leaflets, or excessive AML area, or passive muscle anomalies, mostly some degeneration or stomatous change of to restrict the valves. And our repair goal is to restore a large surface of leaflet coaptation and also preserve the leaflet mobility, and to restore the physiological annular geometry with the remodeling annuloplasty. So according to this patient's condition, according to the Carpentier's classification, this should be a type 2 severe MR with the flare of the A2, A3. And I think it has indication for surgical repair. For surgeons, our repair techniques including resection of the prolapsed segments and maybe triangular quadration resection, then placation of flare leaflets, then artificial chordae or chordae transplant, and also annuloplasty with the prosthetic room. So, and consider the surgical approaches. Now we can choose the median sternotomy or minimal invasive thoracotomy or robotic assisted repair. According to this young patient, I think he is suitable for all of these approaches. And for this case, flare of A2, A3, and maybe posterior medial commissure with severe MR is type 2 severe MR. And according to history, maybe he has also some hypertrophy condition. So for this case, I will see the condition, maybe a triangular resection will be performed, then possible commissuroplasty for the commissure. And we'll see if the coda transfer or new code implantation is needed. And finally, I will do a ring annuloplasty to restore the physiology, geometry of the annula. This is my repair plan.
Okay, thanks, Dr. Ke. After the open surgery about the mitral valve, the next speech we will invite the Dr. Bin Wang to talk about how I do about the transcatheter. Please.
Okay. Thank you very much. So it's my honor to be here to attend in the TAVI valve, and it's my pleasure to discuss the TEER candidates. I suppose that this gentleman should be a low-risk patient for open heart surgery, but from the anatomy assessment, I think the regurg are involved, the posterior medial commissure, and consider the patients with the more than 4 centimeters square annular area. So I think it is possible maybe for these patients to follow the TEER procedure. But I think the open heart surgery should be the first choice. And if the patient with some other comorbidities or with some other the high risk aspect, maybe I think the TEER procedure should be considered. As for the TEER procedure for these cases, I think the several things we need to focus. The first is the area, because the patient's flare is involved commissure. So I do think we don't worry about the gradient after TEER procedure. And another thing is the height, puncture height. From the TE image, you can say the puncture site is maybe 3.5 centimeter. But I think we have some space to more posterior to get more higher to facilitate the TEER procedure. I think if 4 centimeter we can achieve is very easy. It's more maybe easier for the TEER procedure. Maybe 1 or 2 clip for these cases is I think is possible, and I think maybe we can achieve a good result after the 1 or 2 clip. This is my opinion. Thank you.
Okay, thank you, Dr. Bin Wang. We have the last topic. The Dr. Chen Yang will give us the talk, please.
Oh, yeah. Thank you. Following up on these 2 strategies, at the end, what did we do? Because this patient is a patient at our institution. So, as mentioned before, he is a relatively young patient with low risk factors. So in the end, we advised him to undergo surgical treatment for his mitral valve. Surgical treatment would provide him definitive repair of his mitral valve. Now, this is a low-risk patient, and this is his first time undergoing a cardiac procedure. So he doesn't really have any high-risk factors for redo surgeries and other comorbidities. And his valve is quite a friendly valve. There are no high-risk anatomical features such as annular calcification, leaflet calcification, or fibrotic chordae that may cause restrictive motion. So we have quite a lot of tissue, especially at the A3 segment, where we can manipulate it and maybe repair it quite well. And in surgery, we have a vast armamentarium of tools and techniques at our disposal to provide to use all sorts of techniques on his mitral valve to get it as best a shape as we can. And in addition, we have the best exposure, especially to that commissural lesion, which is right off to the side. And I didn't mention it just now, but he also had mild tricuspid regurgitation. So in our institution, we are quite aggressive about treating tricuspid diseases quite early. So with surgery, we can treat his mitral valve and also do his tricuspid valve at the same time. So our approach is a median sternotomy, and we did a biatrial approach to his left atrium. Actually, his biatrial approach is mainly for filming purposes. Otherwise, the lateral approach via Sondergaard's groove is perfectly acceptable as well. So these are our intraoperative pictures. On the top row, on the top left, you can see the ruptured chordae. This is about at A2. And on the top right photo, you can see that thickened chordae that has ruptured. That's the commissural chordae that has also ruptured. So after we got our annuloplasty sutures in, you can appreciate on the left, bottom left photo, just how big and loose that A3 segment is. So you can imagine that when his heart is beating, just how much that would flail. So on the bottom right photo, maybe you can appreciate that our first move is to put our annuloplasty sutures in for exposure, and then we put in 2 sutures at the A3 segment, a little bit to the lateral side towards the PM commissure. So these 2 sutures, what they will do is mimic what MitraClip could possibly do, which is to clip the A3 segment, maybe not all the way, but a pretty good bite, and see how that will fare. But after suturing these 2 sutures, you could still appreciate that at the even more to the PM commissure, there still is quite a loose bit of A3 segment that doesn't look quite right. These are our intraoperative video. On the left, you can see that the segment is still flail over there, and after filling the left ventricle with saline, you could see that there's a big jet at the middle of the valve and quite a lot of leakage at the lateral part where the flail segment is as well. So after that, we would do a magic stitch, a commissuroplasty at the PM commissure, and then tighten up that A3 segment on the right video. Now, after pumping it full of saline as well, there still is a little bit of jet left right at the center. That will probably be managed well once we get our annuloplasty ring down. So this is after we finish our annuloplasty ring. You can see what a nice repair that is. We have the traditional smile that we ought to see on our mitral valve. And then let's talk about our annuloplasty strategy. Our strategy is to downsize the annuloplasty ring by 1 size. That is to get the coaptation zone down underneath the annular plane so that we can, the mitral valve functions well. This is another case operated at a separate institution where they only did edge-to-edge repair, and you can see how much tension there is and how fibrotic that valve has become. So back to our patient. This is our postoperative T. You can appreciate the valves moving quite well, good mobility, and without mitral residual regurgitation. Our residual area is 3.01 centimeters squared, and our pressure gradient is 7 at the peak and 3 mean. So overall, quite a tidy procedure. Thank you.
Is any comment from our panels? This is a commercial flare of the mitral valve. So I think if we put on a clip, it's very difficult to treat the commercial because it's very difficult to put the commercial down. Is any other panel have a different?
Congratulations for the very good result. But I think the idea is very similar with the mitral clip, right? So as we are surgeon, as we open, go inside the heart, did you have any tool or to evaluate the mitral orifice is large enough for the normal dynamic, hemodynamic?
We try to do an anatomical repair first. Edge to edge is a functional repair. You don't want to see mitral regurgitation. But we try to do anatomical structural repair to preserve how the mitral valve look like. And but for commercial regurgitation, it's difficult to put neo cord because commercial cord is different. It's one cord, and you have several branches on the different levels. So if you put one single cord, it's not enough. You have to put 3 or 4 cords. I think it's you waste of time. So you just do a magic stick, close the commercial, use a commercial plastic. But once you put the commercial plastic like this, magic, you reduce the area. The more stitches you put, you reduce more area. So that's why I choose a reduced ring to reduce the AP diameter to put the different tension down. So if you have too much tension, you cannot open the valve. So that's my strategy.
So I think it's very reasonable. It's definitely a surgical case because Transcatheter, at least at this stage, cannot achieve this. And but we still have patients who are not open surgical candidates, and sometimes we try our best. I think we should keep in mind Transcatheter is still good for, maybe not for this age, but for a certain group of patients. But what we could do is try to decrease the regurgitation as much as possible. So, but there is a commercial prolapse is difficult for SGS repair or new cords, as you mentioned. But sometimes you can do hybrid. I would do cord on the commercial, but there's a large component of functional MR as well. You can see the jet is actually very wide in the middle. So maybe just fix the cord at a commercial and then wait TDMT and then see if the functional element goes away, whether we put in additional clips. But you can also save for transcatheter mitral valve replacement. So there are lots of options. But this is definitely a surgical case.
I read on the papers that some people treat the commercial prolapse with a clip plus a plaque, a cooler on the commercial. Any comment on that? That's stable.
Yes, but I think nowadays the clip can do the work, so there's no need for the plugs. But balance between gradients, residual leaks, and hemolysis risk, a lot of things should be taken into consideration. Yeah.
Yeah, I think the imaging-wise, as you can imagine, if it's a commercial, the subvalvular cords are really very tricky. So in patients who are really high risk, we may attempt, but if you get caught a few times, you will be really, really reluctant to try it again. So I think it's just a lucky that commercial can be done. A lot of time we are not really doing commercial. We are probably going to A3, P3, and then try to grasp as much as possible. But I think just a bit of caution for someone such as this is a low risk. I think we should really respect the valve as much as possible.
So there's a question.
Yeah, great talks. Can I just ask the surgeons regarding this mitral valve repair? Because For us as interventionists, when we get the repaired patients back because of regurgitation, right? Once you've downsized with a ring and you put neocords and you've kind of restricted the valve, right? It becomes very difficult to do a transcatheter repair sometimes. So I'm just wondering whether the surgical tips and tricks or your toolbox allows us to think about, like you do the first repair, right? But think of whether if it fails in future, is there any way we can make the original repair more optimal for transcatheter treatment in future? Say, for example, not by augmenting leaflets rather than restricting the valve. I mean, in terms of surgical techniques, is it something that you would think about to make future transcatheter repairs for failed repairs easier for us?
Well, if the repair valve, for example, you put a ring in, but in the future, if a recurrence mitral regurgitation or even mitral stenosis, you can put a valve in ring. I think there's no problem that if the leaflet is restriction or not, because you just open up. If it's a question is that the length of the anterior leaflet. So when you put a valve in ring, you push the anterior leaflet into the LVOT. The only thing that you have to consider is the LVOT obstructions. So sometimes a LAPERM procedure will be needed for valve in ring. But otherwise, so far that you cannot put too large ring because the commercial transcatheter valve, you have a certain size only. So any other ring larger than 38 millimeter, I think it's a question of further transcatheter procedure for valve in ring. But otherwise, I don't think there's a limitation to do a future procedure.
Do you have an age limit for surgery for the mitral valve repair?
I don't think the age is a major consider, but I think the morbidity and the general condition of the patient will be the first consideration. The patient is 93 years old and he can walking around. I think it's still, if it's a surgical candidate, I think it's still suitable for surgery. I think age is not limited, but morbidity of the patient and the frailty of the patient.
And your first choice still repair?
Well, always a repair consider first.
All right, I think we should close the session. Yeah, okay, thank you. We close the session and looking forward to the next session. Thank you.
So let's move on to the next topic. So I'm Kentaro Hayashida, co-chair this session with Dr. Zhao, Dr. Benary, and we also have the expert panelists, Dr. Kai, Dr. Huang, and Dr. Lee. And this topic covers, this session covers the hot topics in TAVR. I'd like to introduce the first speaker, Dr. Ole De Backer. and he's going to talk about lifetime strategy of younger low-risk patient with aortic stenosis. So Ole, if you're ready, please start.
Yes, I'm ready. Thank you, Kentaro, for the introduction. I hope you can hear me loud and clear and that you can see my slides as well.
Yep,
so
perfect.
indeed, this is, okay, very good. So this is more to give an introduction to the aortic stenosis part. And this presentation in the next couple of minutes is going to focus more on lifetime strategies for younger low-risk patients with severe aortic stenosis. So if we look to first, let's start with the European guidelines, which we know are going to change in 2 months from now in the ESC meeting in Madrid in the end of August. So in 2 months from now, there is going to be a change in the guidelines for valvular heart, the management of valvular heart disease. So it's interesting to see what's going to happen. But in the current guidelines, we still have the 75 years cutoff. Recommending TAVI for patients of 75 years of age or older. And otherwise, if it's younger patients, you would still be recommended for surgery. In the American guidelines, it's a little different. There we have class 1 level A recommendation for TAVR if you're above 80 years. If you're in this very large range of 65 to 80, they leave it open. They say, well, it can be surgery or TAVR, depending on the life expectancy, the durability you expect from your device. And then if you're lower than 65 years of age, they recommend surgery. But as I think all of you know, this is not actually what is followed in the US. If you see here in the US, if you're above 80 years, clearly almost 100% of patients are treated with TAVR. If you're in the range between 65 and 80 years of age, it's 90%. Yes, 90% of American patients will be offered TAVR. But even if you're less than 65 years of age, in quite a lot of states, there is already quite a lot of offering of TAVR for patients. Up to 50% of really young patients are offered and treated with TAVR. On which paradigm, or which pre-assumptions was this theory based in 2017? So the first guidelines, we have the European guidelines. Well, that was all the rationale was TAVI is good for patients more than 75 years of age. They have roughly 10 years of life expectancy left, maximally. So TAVI is fine. If you go for younger patients, you should go for surgery. However, nowadays, we have actually data, for example, from the NOTION trial, we have up to 10 years follow-up data, where there is data that shows that the durability of our TAVR devices is actually really good and maybe even outperforming surgical, the durability of surgical aortic bioprosthesis. So this whole rationale and thinking has been thought over and has caused a paradigm shift, I think, for many operators, for sure in the US, and probably is also going to affect the European guidelines in 2 months from now. And that's why we can also consider TAVR nowadays in younger patients, up to 70 or maybe even 65 years of age. Because if you do the TAVR and you need revalving, you can relatively easy do a redo, a revalving or a redo TAVI, and then you can treat your patients in this way. So if we look to what happens in Copenhagen, where I'm working, well, we see, of course, the same trend as most of you have seen. You see in 2012, that's now more than 10 years ago, you saw that surgery was the primary treatment option. And then TAVI was just coming forward for the elderly patients. In 2017, we were equally large as the surgical part. But nowadays, this is already data from 3 years ago, we are clearly much larger. We treat many more patients as our surgical colleagues do. And that's because we penetrate more and more into these younger patients of up to 70 or sometimes even 65 years of age. This is data from 4 years ago. You see this, we monitored all the patients that were discussed at the Hearty meeting in my hospital, and we're responsible for 3 million people. So we know there's only one hospital to go for these 3 million people to be operated or to get TAVI, and that's our hospital. So we can monitor everything what happens. There's about 1,000 patients with valvular heart disease. 2/3 of these patients have aortic stenosis. 1/3 of patients have other diseases like pure aortic regurgitation, mitral regurgitation, tricuspid regurgitation. Yes, but 2/3 of your entire clinic of patients with valvular heart disease are typically aortic stenosis patients. And if you saw the decisions that were taken in 2021, that mean it went 456 patients went for TAVI, 200 patients for surgery, and then a few were conservative or follow-up. But of course, our surgeons are still operating on more than 200 patients. There is, for example, all the endocarditis are out of this analysis, which is around 40-50 patients a year. We have the congenital patients. So our surgeons have a volume of around 350 SAVR, and we do nowadays 550 to 600 TAVRs a year. So if we look to the distribution, this is the age. You see, if you're a patient above 75 years of age living in Denmark, or in the Copenhagen area, it's almost for sure, 95% sure you're going to be treated with TAVR and not surgery. Also, if you're between 65 and 75 years of age, this block here, well, it's already 50-50. Yes, even despite the European guidelines, which recommends only TAVR above 75, we treat already 50% of the patients between 65 and 75 with TAVR. And we have good arguments for that. You see this here in the top box. For example, patients who had prior cardiac surgery, for example, a coronary bypass surgery with a lima behind the sternum. Our surgeons are not very happy to reoperate on those patients. Also, patients with severe lung, liver, or renal disease, for example, an eGFR of 32. Our surgeons know that's not a particularly good patient for them. We are much quicker and much better with our TAVR and will less likely damage the renal function or the liver function of these patients. Also, some patients with morbid obesity, severe LV dysfunction, active malignancy. In that way, we can speed up the cancer treatment, mobility issues, prior chest radiation, like non-Hodgkin lymphoma patients. So these patients, these younger patients we are treating already these days with TAVR in Copenhagen this is justified. We have good reasons to offer them TAVR and not surgery. Of course, one thing which is important to realize, if you go into the younger patients, you see that here in the darker colors in the middle, these are bicuspid patients. So the more you go into the younger patients, 70, 65, and for sure below 65 years of age, the bicuspid rate increases dramatically. I know, of course, in China, Taiwan, and Asia, you have a lot of bicuspids already. This is slightly different in Europe, where if you look to a population more than 80 years of age, typically there's very few, only 3-4% of bicuspid. But as my hospital, for example, we are treating already quite a lot of patients between 65 and 75 with TAVI. Our volume of bicuspid patients last year was exceeding 100 patients as well. This was resembling 15% of our entire TAVR volume, but we are having a lot of bicuspid patients already. However, do we have good data on TAVI or TAVR in bicuspid patients? Well, we have to be a little bit careful there, I think. If this is from the Notion 2 trial, that was a randomized trial in younger patients, they were all between 60 and 75 years of age. They were randomized to surgery or TAVI. As long as you see here in this figure, as long as the patient had a tricuspid valve, actually these outcomes of TAVI and surgery were equal. Yes, they were equally good. There was equipoise for TAVI and surgery for these very young patients between 60 and 75 years of age, as long as they had a tricuspid valve. However, if there was a bicuspid valve, we saw that actually surgery had a tendency to perform better, or at least in this trial, there were better outcomes overall seen for surgery. If we dive into the details of this trial in this younger, low-risk population, because this population, you see the average age was 71 years of age. This was a truly low-risk population. STS from score of 1.1. None of the other trials, such as the PARTNER 3 or the Evolut low-risk trial, they had this low STS risk score. They had typically STS scores of around 2, still or 1.8. This is a true low risk, very robust young patients. You see, these are the events. Either the black colors are mortality, the dark red are disabling stroke, the light red are non-disabling stroke or TIA. There are 3 interesting observations for me in this trial to learn from. First, in the tricuspid arm, you see that outcomes overall were excellent with both surgery and TAVI. However, surprisingly, we saw in the TAVI arm, we start to see a couple of late strokes, which the surgeons don't, which we don't see after surgical aortic bioprosthesis. if we did a deep dive, when we did a deep dive on these late strokes, we see actually this is all related to transcatheter aortic valve underexpansion. We have two underexpanded Eckert valves. We have an underexpanded SAPIEN valve, an underexpanded Portico valve. So it seems that if we're treating younger patients, even in tricuspid cases, if we leave our transcatheter aortic valve behind underexpanded, we expose these patients to a higher stroke risk. So this is a field which should definitely be further investigated in the future. So we should probably optimize our TAVI implants more than we do these days. If we look to the bicuspid arm, there are also two interesting learning points. First, we saw two mortalities by TAVI in the bicuspid arm. These were two bicuspid type 2 cases. So nowadays, I think we have really good arguments to say if we see a type 2, Sieverts type 2 bicuspid, this is high risk for TAVI, and probably these patients are better referred for surgery. Also, these two mortalities were linked to balloon expandable valves. So if you have very nasty looking, highly calcified anatomy, maybe consider more a self-expanding anatomy instead of a balloon expandable. And then we also had, unfortunately, some periprocedural strokes in the TAVI arm for bicuspid. You see the surgeons had truly excellent outcomes. They only had one mortality periprocedural related, and otherwise they didn't have any further mortalities or strokes. We had 3 strokes periprocedural. They were all linked, or at least 2 of them were linked with multiple valve repositioning. So this was indeed where there was chosen, opted for an Evolut platform, for example, but there was repositioned, the valve was repositioned several times, more than 3 or 5 times, and by the multiple repositionings, there was induced a stroke. So one of the cases was also with an infolding of the Evolut where the valve was multiple times resheatheded, pulled out, a new valve was put in, also multiple times repositioning, and then finally there was a good valve result, but the patient had a stroke. So these are the learnings in this Notion 2 trial in young low-risk trials. So then zooming a little bit out and thinking about what should TAVI offer when we're treating young low-risk patients. Well, we have more than 20 years of experience with TAVI. I think we have become pretty good over the last decade to optimize procedural success, to really manage our vascular closure, to bring down the paravalvular leak, to choose proper valve for obtaining the best possible valve hemodynamics. And also we have developed implantation techniques so we can reduce the pacemaker implantation rate to as low as possible. But if we're treating younger patients, there are a couple of other aspects to consider. We have to think of lifetime management of these patients. We have to think of coronary access, of commissural alignment, of valve durability, valve thrombosis, and also redo TAVI options. So very short, in these last 5 minutes, I can go touch on these aspects like coronary access. I think coronary access these days should not be a big issue anymore. Also, even for platforms such as the Evolut, where it's typically historically been more difficult with because of the tall stent frame and the small stent frame cells. Now you have the Evolut FX Plus, for example. It's an easy platform to implant with commissural alignment. You have these bigger cells. Also SAPIEN, other platforms like Navitor, or you have some other platforms in Asia too. I think nowadays we are getting better in implanting these devices with commissural alignment. We also understand better which techniques to use to do coronary access. For example, we have to adapt our guiding catheter choice. We can use some J-wire to cross the lowest diamonds. We can do coronary wiring from a distance, and it's almost always advised to go with a guide extension catheter. If I do PCI, either in my procedure together with TAVI or post-TAVI, I will always use a guide extension catheter. Commissural alignment, this is what we want to obtain. Yes, nice commissural alignment. We want to avoid to implant a commissural pulse just in front of a coronary. Why? Because it obstructs the coronary access, but especially, even more important for me, it obstructs good options for redo TAVI very often, because then you cannot do any leaflet modification in the future, and then you can make this patient totally unsuitable for redo TAVI. So that's why I really try to go for commissural alignment. As said, with most of the devices, you can do this nowadays. I can do this definitely with Evolut. I can do it with Navitor also, which you can actually also torque. Sapien is not there, but this has then a shorter stent frame. Yes. Valve durability, I think the younger patients you treat, the more important it becomes that you have data on valve durability. This is, for example, I showed you before, this is from the old core platform, which has excellent, truly excellent 10-year data follow-up. We have to be seen, we have to be careful, we have to see and wait whether this is valid for all the valves, including all the new devices like MyValve, VitaFlow, all these Hydra. We have to wait and see, and Venus. We have to wait for the durability data of these devices as well. And then, of course, if you think about durability, we also have to think how long will our patients typically live? What is the life expectancy still of these patients? That's also important to have a knowledge about this. Well, if you have a high-risk patient of 80 years, this median survival of this patient will be for sure below 6 years. If you have an intermediate risk patient of around 75 years of age, these patients have typically a median survival of 7 to 8 years. But we also, if we look to low-risk patients, low-risk young patients, so a 70-year-old low-risk patient with severe aortic stenosis, which is coming to you for treatment for his aortic stenosis, well, these patients have, in average, 12 to 13 years of lifespan left. Not all these patients become 90 years. So probably if we give this patient a valve which lasts around 12 years, which many of these TAVI devices probably are likely be able to offer, then we are good to offer this patient a lifetime treatment with one single valve, and this patient will not need revalving. Valve thrombosis, it's also an important topic. Valve thrombosis, this is the leaflet thickening or the leaflet thrombosis. You see this actually only in devices, TAVR devices with intra-annular leaflet position. So Sapien, Navitor, for example, they are pretty much affected by it. I've never ever seen it, to be honest, or extremely rarely in valves with a supraannular leaflet position like Evolut in the past, Accurate, for example, or some other supraannular devices like with VitaFlow, for example. So supraannular leaflet position, it's not so much important for me for the hemodynamics. That's because you also have intra-annular devices, TAVI devices with intra-annular leaflet position with great hemodynamics. So great hemodynamics has nothing to do with supra or intra-annular leaflet position. You can totally forget about this. This is not the case. It's not linked to that. But the intra-annular leaflet position is definitely associated with a higher risk of leaflet thrombosis. And then finally, the redo TAVI options. Of course, if you start to think of redo TAVI, this is a complex field. You have to know new terminologies like nail skirt length, leaflet overhang. What happens with the hemodynamics if you put one TAVI in another TAVI, or you put a Sapien in an Evolut, high or low? What kind of sizing do you have to do? Do you have to downsize or keep with the regular sizing, annular sizing? There's a lot to learn there still, but it's also important that you understand the different devices and the different combinations. And I would say the best marriage typically is a tall stent frame and a short stent frame, and a short stent frame in a tall stent frame to do the revalving. That's my take-home message in short. There is also simulation software coming, which shows you, for example, this is FEOPS, where you can do revalving simulation, and then you can look on what is the risk for my coronaries to obstruct or to have sinus sequestration with a low or a high Sapien implant. Here you see, for example, with these color codes indicated, is there a risk is my VT valve 2 aortic distance becoming smaller or than 2 millimeter, yes or no? If that's the case, you have to think of coronary protection, either with chimney or with leaflet modification. I do a lot of Basilica for TAVI in surgical procedures, but if I do redo TAVI, I most of the time do Unicorn, not Basilica, because it's typically not protective enough. With a Unicorn procedure, you really disrupt the entire leaflet and then put your second TAVI valve in. So as you see, to finalize, I think you have to think of multiple other aspects if you do TAVI in younger, low-risk patients, not only optimizing the acute outcomes, but also think of the lifetime management of these patients. So what is the future of TAVI? Well, there's a lot of different questions to be answered yet. Are the European guidelines, for example, are they going to push the cutoff for TAVI to 70 years of age? What about TAVI for pure aortic regurgitation? There are specific devices for that. How do you interpret the data from the early TAVI, offering TAVI for patients with asymptomatic severe aortic stenosis? I have a lot of discussion in my in my region, in my part where I live, to trust these data or to really integrate these data in my clinic. I have a lot of clinical cardiologists who are still pushing back on this and don't refer patients who are asymptomatic, but we have to open that discussion as well. What about TAVI for young bicuspid patients? Are we ready for that, or do we wait for more dedicated devices? What about the durability, class effects, redo TAVI options, or maybe TAVI in the future with no conduction disorder? I think it should definitely be possible. Like we had already a couple of years ago, the Centera device from Edwards Lifesciences, which was going almost to 0% pacemaker. Unfortunately, this device was discontinued, but I think in the future we could still probably do better also in that field. So with that, I think I want to complete this presentation and I give the word back to you in Taipei.
So thank you very much, Ole, for your fantastic lecture. It was so comprehensive, and I really learned a lot. So any questions or comments from the panel? So I have one question. So if you were the chairperson of the European Guideline Committee, what is your recommendation for the new age cutoff point for the new guideline in your country, in Europe?
Yeah, good question. Look, I think what I hope I will see in the European guidelines is the following, that there's not so much focus only on age. Maybe that in general they say, okay, there's enough data to justify lowering the age cutoff to 70 years of age. Yes, I think. But that there becomes also more emphasis on looking that they demand a cardiac CT for every patient with severe aortic stenosis before being discussed at the Heart-E meeting. And that you have to take into account also the morphology of the aortic valve. If this is good, nice, suitable for TAVI, you can go for TAVI. If it's a very highly calcified bicuspid case and the patient is 72, I think it's more reasonable to send this patient to surgery. So I hope less emphasis on age only, bring in the cardiac CT for every Heart-E meeting discussion, and then balance the age and the anatomy of the valve, tricuspid, bicuspid, and the suitability for TAVI. I think that's what I hope to see in the European guidelines.
Yeah, your opinion is well taken. So not only age, but also the procedure feasibility is quite important to move forward. Thank you so much for your great lecture.
Thank you. Good meeting, still.
Okay, the next speech will be delivered by Dr. In-Ho Che. He's the professor, Department of Internal Medicine, Seoul National University College of Medicine. Dr. In-Ho Che is a distinguished interventional cardiologist based in South Korea, affiliated with the Seoul National University Bangdak Hospital with over 25 years of experience. He is specialized in intervention for coronary carotid, renal aortic, and peripheral disease. So, Dr. In-Ho Che, please start your speech.
Thank you, Chairman. In-Ho Che. So I'd like to talk about the low coronary height during the TAVI procedures. Fortunately, I didn't have any case who had a coronary occlusion during the 7 years of my experience among the all 400 cases. But there are definitely high risk for the coronary occlusion and the TAVI procedure. If the coronary occlusion occurs, the early in-hospital mortality is 10 times higher compared to the patient whose coronary are open widely. And then 1 year and point, the mortality is more than 4 points higher compared to the control group. So the coronary occlusion is a very, very disastrous condition, as you can see here. So if you use tall THV, for example, Evolut valve, you have to familiar with this device, especially in the length of the ceiling cuff. And then so you have to very cautious of the sinus of Valsalva diameter and then height of sinus of Valsalva, not to occlude the coronary arteries. So usually anatomic factors are coronary height and then sinus valsalva height and the cusp length, and then VTC. These are the risk factors for coronary occlusion during the TAVR procedure. So if the low coronary height plus wide SOV or STJ and the high coronary height with the narrow SOV STJ, the coronary perfusion is not that much compromised, but the low coronary height plus narrow SOV STJ is a very high risk for coronary occlusion. So, but the height of coronary artery and SOV diameter and residual SOV is the weak predictor for coronary occlusion. As you can see, the low sensitivity and specificity to predict the coronary occlusion during the TAVR procedure. But from this trial, you can see the cusp height and with the coronary height, cusp height is longer than coronary height, and valve to coronary distance less than 4 millimeter, or cusp leaflet calcium volume larger than 600 cubic millimeters are the very it's a good predictor for left and coronary artery occlusion with a higher sensitivity and specificity. So you have to analyze the CT angiogram very carefully. If the patient like this, it's a very high risk for the coronary occlusion because of the valve leaflet length is more than around the 15 millimeter. The coronary left coronary height is 9.9 millimeter. So if you are using the Navitor 25 millimeter, it's questionable. This is a really high risk for the coronary occlusion during the TAVR procedure. So in this case, prediction by coronary angiogram, simultaneous aortogram during the predilation balloon. First of all, you have to find out the en face view of the left coronary ostium like this. And then during the predilation balloon, you can see the valve leaflet move to toward the left coronary ostium, but the coronary flow is patent. So in this case, you can safely put the long THV in this patient without any compromise of the coronary flow. And then TAVR and SAVR procedure, the most important thing is two things. VTC less than 4 millimeters, and whatever the stainless or stented surgical valve, the externally mounted leaflet is the most important predictor for coronary occlusion. In this case, we can use chimney technique. We place the stent inside the coronary artery, and personally, I prefer the advanced the guiding extension into the coronary artery rather than advancing the coronary stent here. But anyway, if the coronary occlusion occurs, the chimney stent and the kissing balloon, and this is chimney technique. And then you can use the basilica technique to modify the leaflet. So from one study, even though it's a retrospective comparison of chimney and basilica, so 168 patients was randomized to chimney stenting and the basilica technique. The 92% was valve in valve, mean age was 80 years old, and then 64 was female, and then mean STS score was 6.4. Regarding the procedural complexity, the contrast dye was used more in the chimney arm, and then C protection device was more frequently used in the Basilica arm, but the procedure time was similar. The procedure outcome in the chimney group, the more higher frequency of severe AKI and a significant PVL and more DAPT population in the chimney, but then the disabling stroke was similar. And then 1 year outcome, the CV death 6.7% in chimney, a little bit higher. The MI was 3.8% in Basilica, a little bit higher, but the MACE at 1 year is 19% and 20% is quite similar. So at least 1 year outcome is comparable and the chimney and Basilica technique, but we need long-term data. So in my case, I didn't have a true Tabin server, but as you know, the cover procedure was done frequently in 20 years ago in Korea. The CT angiogram, the cover ring at the sinotubular junction compresses the sinus valve on the left side, and the height of extended left coronary cusp with calcium chunks was relatively higher than that of a coronary ostium. So in this case, it is not good indication for the Basilica technique. So I used the chimney technique, chimney stent technique in this patient. So safely doing the procedure and Tabin cover procedure. And then coronary occlusion during TAVR has a higher mortality in all situations in TAVR native valve and TAVR TAVR SAVR also. And then review your patient clinical anatomical status thoroughly, and it is very important to predict the coronary occlusion by CT measurement and also simultaneous aorta and coronary angiogram during the predilation. And if the patient had a high risk for coronary occlusion, the SAVR is maybe the option, and the short THV, for example, Saphion, is preferable. And then if you choose chimney or Basilica technique, I think we had a similar short-term outcome. So thank you for your attention, and please see you in O and the ENCORE-SOUL 2025.
Thank you for your excellent talk. Is there any question or comment from our audience? So kind of a question, because the 1 year outcome of the chimney stenting at the Basilica is similar. What's your preferred technique? Which one?
So I didn't have experience with the Basilica because I'm just preparing the Basilica technique for possible the leaflet modification in the TAVR or Tabin server. But so for me, it's more unfamiliar with the chimney technique.
Okay, any questions for the Huang?
Different valve, where the risk is the same for such high risk of the coronary occlusion patient, using different TAVR valve.
Short valve is more safer than the tall THV valve, so, but it depends on the patient anatomy. So not much dependent on the valve type.
Thank you. We need to move on to the next speak. Yeah.
So I'd like to introduce Dr. Wachin Badari from Thailand, and he's going to talk about self-expanding patient selection.
Thank you. So in this room, who put more self-expandable than balloon expandable? No, you're not. Okay. All right. This is my true disclosure. At our institute, we use 87% self-expandable. We have not put a single balloon expandable in the bicuspid valve yet. So why patient selection matters? I think appropriate valve selection will influence your procedural success, will influence your complications rate, and also probably influence long-term outcomes, whether it's durability issue or future redo TAVI. This is everyone will know. Balloon expandable, you have one-time shot of deployment, quick but non-recapturable. You forcefully open the valve. Intraannular leaflet design usually result in a smaller effective orifice area. Short height has some advantage, as you just heard, and oversizing is not a must. Versus self-expandable, some designs are repositionable and recapturable. Some with supraannular valvular design, which result in a larger EOA, which may result in a better durability. A taller frame and the cover part can prevent future coronary access, although as we just heard, we're getting better with that, and valve designs allow us to do that easier and easier these days. But oversizing is a must, so that gives us a higher rate of conduction disturbance. So key features of self-expandable valve, it's nitinol frame, it gives us a gradual expansion. So as long as we don't push them with post-dilatation, it would expand as much as its opening force would allow them to, which each self-expandable valve has different opening force. And also radial strength is also different, but usually most of them will further expand over time. The supraannular leaflet will result in better hemodynamics, repositionable, recapturable in some of them, and we could do commissural alignment in some of them as well. So these are some of the patients that we usually elect to go with self-expandable. The LVOT calcification, the balloon expandable can cause annular rupture more often than the self-expandable. Both platforms can result in paravalvular leak, so we don't think there's any different. Somehow, the self-expandable, you have to oversize it, and if the degree of oversizing is too much, then it can result in the conduction disturbance and requirement for permanent pacemaker. The small aortic annulus is another patient selection criteria that we usually go with self-expandable supraannular leaflet design because it results in the less likelihood of severe PPM and better hemodynamic outcome, although we don't have a clinical outcome benefit yet. These are some of the things I mentioned this morning, that these self-expandable, they all have a better hemodynamic outlook compared to the balloon expandable, although the clinical outcome may not play out and allow us to see them yet, including the SMART trial. The composite clinical endpoints is the same between the SAPIEN and the Evolut platform in a small annuli, but the valve performance and hemodynamic favor self-expandable. Another situation will be valve-in-valve. So the valve-in-valve, we face two potential issues. Coronary occlusion is one, and post-procedural gradient or mismatch is another one. The predictors for coronary occlusion, as you can see, the surgical valve type, especially the external mounted leaflet like the trifecta, the small or narrow sinus of Valsalva, low coronary height, and the short distance between the valve frame and the coronary or SCJ. And the use of balloon expandable has been documented in literature that cause more coronary occlusion than the self-expandable. But I think that can be misleading because that depends on the degree of oversizing of the self-expandable as well. The post-procedural gradient, usually the predictor for high gradient would be a small surgical valve to begin with that we normally see in our population. Use of balloon expandable valve and whether or not we do the balloon, the valve fracture. The valve-in-valve meta-analysis comparing the two platforms result in a similar clinical outcome. But this particular clinical study missed one of the arm, which is a redo salver. And that may turn out to be a better solution than the valve-in-valve. We have to see. The LIGHTEN trial is a valve-in-valve, a randomized trial in a small bioprosthetic valve. That is the valve that is less than 23 mm, comparing balloon expandable and self-expandable. Again, you get a better hemodynamic with self-expandable, but clinical outcome, whether it's hard endpoint or quality of life or symptom, they're the same. Okay. This is some of the patients we did a long time ago. One day we have 2 valve-in-valve, and we elected to go with self-expandable in 1, Perimount 21, and balloon expandable in 1. And this patient, although with a smaller valve, we at that time wanted to learn how to fracture the valve. So this patient, we fractured it before, and once we successfully fractured it, we upsized the valve from 20 to 23. And we got the gradient down to 0 at the end of the procedure, only for it to increase to 24 on the next day. This self-expandable, we got the residual gradient of 16. So this one, what happened, this follow-up CT showed leaflet thrombosis, and that, which actually disappeared after a period of anticoagulant. But anyway, since then, we've been using self-expandable for valve-in-valve. Hasn't gone back to balloon expandable yet. So this is the situation. We have to be cautious about self-expandable valve. Patient at risk for conduction disturbance, this is straightforward. Patient with pre-existing conduction delay, or the patient that somehow the valve size that fit has a large degree of oversizing, especially with the LVOT. Patients who might need coronary intervention in the future, so commissural alignment is critically important. The patient who might need a redo TAVI, i.e. a young patient, so commissural alignment and the plan to have a neo-skirt plane in relationship to coronary risk plane is crucial and has to be part of the decision making. Patient with severe LV dysfunction, poor reserved, very high LV EDP, this is a setup for a crash during the procedure, especially if you occlude the orifice for too long or have to do a repeated rapid pacing, which sometimes we need to do with self-expandable valve. Now, the situation that we still don't have the answer, which platform is better than the other, is the bicuspid aortic stenosis. The advantage of self-expandable, it's allowed gradual expansion, so it reduces the risk of rupture, especially the one with heavily calcified valve or LVOT. It can recapture, it can be repositioned, it also can resize when you, resheath it for 2/3, and then you think you need to change the size, you still can do it. So you recapture, you take it out, and you put in a different size. Disadvantage, sometimes it doesn't expand like you want it to be. It requires adequate predilatation, and enfolding can occur, especially in bicuspid with a large self-expandable. The other situation that we have to be very meticulous about is the consideration for future redo TAVI. So most balloon expandable, most people use balloon expandable because it has a short frame. The next valve can be balloon expandable or self-expandable. Position of the first valve can be easily done to have a neo-skirt below the coronary risk plane. For self-expandable, a tall frame valve, some people use it because they believe in its superior hemodynamic performance and may result in more durability outcome. But you have to make sure that the commissure is aligned, and also, if possible, the neo-skirt plane should be below the coronary risk plane. I'll give you one case example that we did last week. We had a 62-year-old man, businessman. He doesn't have a lot of comorbidity. Came in with symptomatic severe aortic stenosis. He has a type 1 bicuspid with fusion between the right and the left. You may not read it, but the perimeter is 84. It's 23 by 29. Okay, and it has this chunk of calcium here. The LVOT is, the minor diameter is slightly smaller than 23, it's 22.5. The long diameter is about the same, 29, 30. The SOV is very large enough to accommodate any valve. STJ is large. And if you do the measurement like we used to do in the past, measure it at the 4 millimeter and 8 millimeter above the valve, the intercommissural distance is about the same or slightly flare up. But the opening is smaller. But again, if we go for the self-expandable nowadays we use annular sizing, and this will fit Evolut FX34. Now, you may wonder why we mention self-expandable. This patient has this calcium down into the alveoli, 10 millimeter depth and 6.9, 6.8 thickness. Has this calcified raphe, but only halfway, not all the way. His calcium at the valve is 5,000. Okay, but the severity of AAS is only like at the cutoff between moderate and severe. The other good thing is that his STJ height is very high, 28, 27, and the coronary height is also very high, 19, 20. The membranous septum is also very long, 6.9. So we pre-dilate with 22 balloon for 26 annulus because we didn't want to injure the calcified LVOT. Then the Evolut FX 34 went up, and we had a pretty good commissural alignment. We think the head marker is where it should be, both in the LAO projection and the cusp overlap view in the front. Then luckily the valve expand well after the adequate pre-dilatation. As you can see, this is cusp overlap, and when we move to the LAO projection with parallax correction, the position is good. We didn't have to recapture and reposition it, so we just one attempt and final release. But then we still have like slightly more than mild paralytic because of that calcium, we think, and he's 62. So we post-dilated first with that first 22 balloon pre-dilatation, still leak, 24, which is the maximum for the 34. And it's a semi-compliance balloon. It's still leak. So we use a 26, but move down towards the ventricle, try not to touch the leaflet, thinking, and then this is the end result. We got a bigger frame and mean gradient of 5 at the end and a trivial leak. I forgot to mention why we went for TAVI in this 62 years old patient. He absolutely refused surgery. We have one cardiac surgeon and 3 interventionists talk to him about the unknown future. He said the future is the future. He doesn't care. He wants this to be done easily and go back to work. The same day we had another gentleman, 70 years old, type 0 bicuspid. His son happened to read about Notion 2. And he decided to go for surgery. Anyway, so take-home message. We usually match the valve to the anatomy and the patient profile, i.e. the age. Self-expandable has a strength and limitation as mentioned. We have to balance the risks and the benefit as mentioned above. Thank you.
So thank you very much for a fantastic lecture. So I really learned a lot from your lecture. So for the sake of time, we need to move forward.
Okay, thank you. So the next presentation will be delivered by Dr. Tsuyoshi Kaneko. The topic is TAVR explained and state of the art and the impact of the valve design. Dr. Kaneko, please.
Hi, this is Yoshi Kaneko at Washington University in St. Louis. Thank you very much for the invitation. I'm sorry that I can't be there in person, but I will be talking about TAVR explant today, and these are my disclosures. So this is the aortic valve universe slide in the United States. The number of surgical aortic valve replacements being performed are listed in this graph. These are total AVRs, but the number of TAVRs has really been growing over the past few years. And these include a lot of low-risk patients. So this is a forecast of valve-in-valve in the future. TAV-in-TAV is projected to increase exponentially over the past 10 years. And the outcomes of TAV-in-TAV has been reported to be very good. This is looking at the TVT registry outcome for balloon expandable valve. I'm pretty sure there's another talk for TAV-in-TAV. However, some of these patients do require TAVR explant. In the reports of TAVR explant, these are relatively older series now, but from 2020 to 2021, the outcomes of TAVR explant has been reported to be not quite good. The mortality was somewhere between 12 to 20%. This was the latest series looking at all surgery after TAVR from the STS database. And in this graph particularly, the surgery after aortic valve replacement after TAVR, which is depicted in this graph as blue, is the number of TAVR explant being performed. It is the most rapid growing surgery in the United States. And when we looked at the mortality of these TAVR explants, the TAVR explant mortality was 14.1%, which goes along with the historical reports of the explant outcomes. So I'm going to talk about a couple reasons why TAVR explant will be needed despite these high-risk features. Number one is the endocarditis. The endocarditis risk is relatively low in the series that's been reported. However, the mortality has been extremely high. You can see that the in-hospital mortality varies from 16 to 64%. And this is a case of endocarditis that I performed. I'm not going to go into the details of this, but what we had to do was that we had to take out the aortic valve and then had to reconstruct the aortomitral curtain and then replace both aortic and mitral valve. So this was a TAVR explant, double valve replacement with reconstruction of aortomitral curtain. So this becomes a much, much larger operation, and you can predict that these outcomes can be worse compared to the standard TAVR explants. However, in one of the largest series reported looking at explant TAVR registry from 2009 to 2021, compared to BVD, biprosthetic valve degeneration TAVR explant, endocarditis explant had higher rate of stroke, but similar rate of cumulative mortality, meaning that having endocarditis versus just standard structural valve degeneration had no outcomes in terms of mortality, although the stroke risk was higher. What about the second scenario when TAVR explant is needed? When the patient is not a candidate for redo TAVR, then those patients will require TAVR explant. This is a paper that I've shown so many times from Dr. Ochiai in JACC Interventions. Whenever you have a risk of sinus sequestration from the second valve, as you can see here, it will occlude the flow into the coronary artery, and they will not have a blood flow, therefore will result in massive myocardial infarction. And the risk of this sinus sequestration is not trivial. When you look at patients that are unfeasible for TAV-in-TAV based on some of the simulation have shown that the risk is somewhere between 24 to 40% depending on the type of valve that is utilized. For those cases, you do not have to worry about sinus sequestration if you're doing a TAVR explant. As you can see here, the old valve or the TAVR valve is removed, and as well as the native leaflet, and then after that you just perform a standard aortic valve replacement. Therefore, there will not be any sinus sequestration. So for these cases, TAVR explant will be necessary in the future. The third scenario where TAVR explant is needed is patient prosthesis mismatch. this was the paper that was shown from the SMART trial by Howie Herman, and it looked at the bioprosthetic valve dysfunction in women through 12 months, and this is moderate to severe patient prosthesis mismatch at 30 days. You can see that even in balloon expandable valves, there are 35% of patients who require PPM, and even for self-expanding valve, 11.2% had prosthesis patient mismatch. Therefore, these patients will end up with some degree of PPM. This is after the first valve procedure. So if the patient had PPM, what about the second valve? This is one of the patients that I've treated. The first valve, the area was very small, got a 20 millimeter sapien valve. Look at the second valve that is being implanted when you calculate the area. It was 188 square millimeters. It is the Russian doll effect. The more you put in, the smaller you're going to get. So the second valve will definitely be smaller than the first one. Therefore, we'll have a higher risk of patient prosthesis mismatch. In those cases, what you can do is you can actually go for surgery. This is a case that I performed. You can see that these were self-expanding valve that was explanted. And after this, the root enlargement was performed using a Y technique, and then place a larger valve. This patient ended up with a 25 millimeter valve, which will allow adequate sizing in the future. The fourth scenario is if you have concomitant valve disease. Patients who have aortic stenosis have high likelihood of having another valve disease. This is looking at mitral regurgitation. There's about somewhere between 8 to 20% of patients in the PARTNERS trial that had moderate to severe mitral regurgitation. The population that we're seeing more and more is the ASMS population. This is more common in elderly with other valvular disease. There's about 10 to 20% of patients who also have MS, likely from MAC, and these will progress in the future. When we looked at the TAVR explant from the STS registry, about 20% of patients required aortic or aortic root procedure, and 25% of patients required either coronary artery bypass grafting or mitral valve surgery, meaning that these patients require a lot of concomitant procedures which will not be addressed just with redo TAVRs, and surgery is needed. The most important thing that we need to emphasize is that yes, there is a short-term mortality risk with TAVR explant, but when you look at the outcomes after 30 days, their outcomes are the same. Therefore, we have to choose the right therapy for these patients whenever the explant is needed. We have been working on a lot of education. There has been a webinar, there's some section with TAVR explant within Vinny's new valve-in-valve app for redo TAVRs. And most recently, we published a paper in JTCVS about more of the operative techniques to really streamline and come with a consensus. And this is part of the paper that we wrote about a CT assessment. How do you assess the CT when you get them? These are some of the things that we look at. The second component is where to make the aortotomy. It is very critical where to make the aortotomy, especially for self-expanding valve because of the hourglass nature of it. And then we looked at some of the techniques of how to really lower the risk of injuring other structures. So valve removal for self-expanding valve, balloon expandable valves. And then we spoke about some of the techniques
this allows us to
removing the self-expanding valve, as you can see. So these are all the efforts that are being performed to lower the mortality. So take-home message is that TAVR explant has 14 to 20% operative mortality. TAVR explant is needed for endocarditis, patient prosthesis mismatch, and concomitant surgery. TAVR explant mortality is expected to decrease with surgeon education and dissemination of the technique, lower patient risk coming at the time of TAVR, and better surveillance with annual echocardiogram. There has been some data from single institution showing that lower mortality has been seen in the recent series, so more to come in this field. Thank you so much for having me.
Thank you, Yoshi. Any question or comment from any of us? How low do you think the mortality with TAVI explant will be? Is it going to be like a redo surgery or native? Oh, okay, so it's a pre-recorded. Let me introduce the next speaker. Next speaker is Dr. Marco Barbanti from Italy. He will talk to us on redo TAVI, optimizing outcomes through valve selection. Dr. Barbanti.
And for me, it's a great pleasure to join once again the Taipei Valve Summit this year, 2025. My talk will focus on the redo TAVI procedure. We know that there are some new horizons of TAVI therapy, and some of them is for sure the treatment of bicuspid aortic valves. But I think some of the most important topic of this therapy is first to guarantee the repeatability of the procedure, and the second one is to avoid any kind of interference for future core intervention. But for sure, for this topic, for this talk, we're gonna focus on the repeatability of the procedure, also called as redo TAVI. We know that bioprostheses do not last forever. This is a lesson that we learn from surgical experience, and of course we are just adopting this also in TAVI field. We know also that a lot of young patients are receiving TAVI even more. This is data from the US. Which are quite surprising, to be honest, but basically that says that in 2021, 48% of patients aged less than 65 requiring aortic valve replacement actually received a transcatheter aortic valve implantation. So this is once again after the introduction of the last guidelines on valvular disease in the United States. And of course, we know that as long as we move towards a population younger than 65, we have to expect to face patients in which life expectancy overcome the life expectancy of the valve we are going to implant. So it's absolutely mandatory to think that procedure not just as a single procedure, but a combination of procedure that could cover the therapy of more or less 20-25 years of age. The redo TAVI procedure at the very beginning, when we started doing some anecdotal case, it looked like, to be honest, quite an easy procedure. It was considered easy because we had big fluoroscopic markers. We know that in the case the valve was well placed, we know where to put the valve, where to implant. So it was really perceived as an easy procedure. But to be perfectly honest, this is not the case, and we're going to show this why. I think it's important to start from some concept. I try to figure out a conversation here throughout peers. While a physician would just say, discussing a potential redo TAVI patient, saying that the index transcatheter valve failed, we're going to use a short interval approach. The VTSTJ is borderline and the NSP is above the CRP. We should consider leaflet modification with low implant and moderate leaflets of rank. So we can easily understand that there are some new concepts, new words that we should get used in order to understand very well what's going on, how these procedures should be tackled. Because of course is to tackle a redo TAVI procedure is completely different animal as compared with TAVI for native valve or also for TAVI in SAVR. We know that these procedures are increasing, that's for sure. We saw up to 2021, we had a small, a tiny, but remarkable and progressive increase in the numbers of procedure. For sure, this is expected to increase exponentially because the use of TAVI even in lower risk in young patients. And according to the new dictionary in reduced TAVI procedure, I think what we should really pay our attention is a new concept in terms of CT measurement, like a VTC, which is the valve to coronary distance, VTSTJ, which is the valve to sinotubular junction distance, VTA, which is the valve to aortic distance, which is the shortest distance, but also some other terms such as the neoskirt, which is the area of the transcatheter valve cumulation covered with leaflets and or the skirt of the valve, the neoskirt plane, which is the level of the neoskirt for a given combination between valve and the aorta, and the coronary plane, which is something which is the plane of the lowest coronary ostia, and other terms like leaflet overhang and sinus-valsalva sequestration. Also, we know that we don't see the valve in our hands when we are treating a patient, so we have to be very confident about the different landmarks of different procedures, of different valves, sorry. So we know that some valves may have nodes, may have a commissure tab. We have the inflow, which is the lowest part of the valve. We have different types of geometry of valves. For example, this is an accurate, which is not in the market anymore, but still they have some peculiar fluoroscopic markers, which are the upper crown, and also we have different valves like this, like a tuning force and inflow. What is important, the first approach is try to assess the feasibility of reduced TAVI procedure, which is not guaranteed in any type of valves. So first of all, the three components you have to assess when you assess the feasibility of reduced TAVI procedure. For sure, there is a sinotubular junction width, which for many years has been quite a neglected measurement, but in TAVI field is very important. It's very important to consider also the transcatheter valve leaflet 8 when these are intraannular, supraannular. And also it's very important to consider the implantation depth, because the implantation depth may completely change the scenario we are looking at in case of a reduced TAVI procedure. But as I said before, we have to really understand why this reduced TAVI procedure may be challenging. And it might be challenging because one of the new complication, which is the sinus-valsalva sequestration, because we know that when we put the valve inside the first index valve, we have all the leaflets folded up by creating a cylinder, and then we creating a barrier towards the aorta. So in case you might end up by sequestrating an isolated sinus-valsalva and then resulting in obstruction of the flow to the coronary. And this is something that can be common. This is a simulation-based study where actually in 23% of patients where the second valve was simulated, we can observe a very high risk of coronary obstruction, whether you might have an unknown with a unknown risk and only 6% with the declared low risk of a coronary obstruction. I said before that any valve has its own characteristics. So we have a different leaflets 8, which matters because one thing is one valve such this a short frame where in case you folded up the leaflets, it reach 22 millimeters at most, and you have valves supraannular in particular that can reach also 31 millimeters. So it may change completely. But also the implantation is important because the neoskirt plane, it may be different in case we implant the valve in a higher position, in a lower position, so we can just play by selecting the second valve. And why this is important? Because we can really tailor our approach by implanting the valve at different, this is a case in SAPIEN in Evolut, but we can just aim our valve at node 4, node 5, node 6. Of course, we can just create different NeoSkirt aids. This is the NeoSkirt aids in case of implantation of at node 4. This is the implantation of the NeoSkirt aid in case of implantation node 6. And of course, in case we implant low, in this case, we have to consider a new entity, which is the leaflet overhang, which is the portion of the leaflets of the index valve, which comes above the second valve. And so this is something that can be considered only when the index valve failed with a regurgitation, not with that stenosis, because otherwise we're going to have a stenosis above the new valve. And I think this paper by Giuseppe Tarantini in JACC Intervention 22, sorry, it basically summarized the steps to consider when you have to select a patient for a valve infarct procedure, which starts really for a very accurate and deep assessment of the CT. If feasible, it's better to have also the baseline CT before the index TAV, but it's very important to have a base CT with the index TAV, the generated valve in place. And of course, the second step is to assess the risk of coronary obstruction. So you have some green line and red line, particularly when you have a risk plane VTSTJ, which is short, or the THV design is supraannular, supracoronary. The implantation depth is high, and you have a moderate severe misalignment, and you choose a supraannular valve as a second valve in a high implantation. You have all characteristics for high risk for coronary obstruction. Then you can decide the sizing, and also I don't want to go through this, but I think also the label size, but more the label size, also the CT sizing is very important, because differently from TAV in SAVR, you might have a actual size which is different from the label size because some kind of under expansion of the index valve, and also you have to assess the valve positioning and considering some kind of leaflet overhang. This is just an example of an accurate valve which they generated with regurgitation. We had some issues with the valve, sinusobasalval obstruction, so we decided to implant the valve with the top of the SAPIEN valve in correspondence of the upper crown. So we created basically a kind of leaflet overhang with no obstruction of the coronaries, and also with quite easy access to the coronaries, as you can see here. Here we go. So in conclusion, we can say that reduced TAVI procedure at the moment are rare, but they're expected to increase in the next years. Procedural planning with CT has required for sure a novel nomenclature, and a deep knowledge of the generated THV feature is mandatory to plan the procedure. Short frame balloon expandable valves seems at the moment the best platforms to perform reduced TAVI in order to reduce also the NeoSkirt plane, and also implantation technique depends on the mechanism of failure and THV aortic root anatomy interaction. So thank you very much for your attention.
So this is a pre-recorded one, so we proceed to the next presentation. The next speaker is Evan Wang. The topic is timing of intervention for AS patients combined with a CAD. Dr. Wang, please.
Yes, thank you. This is Ivan from Hong Kong, and for the interest of time, I will try to keep the presentation short. And the topic is for the timing of intervention for AS patients combined with CAD. So I guess we focus on the timing for the coronary intervention. Okay, so likely it's the timing of the PCI for patients with aortic stenosis. So of course there are a few guidelines for this the management of the CAD in patients with severe aortic stenosis, and we all know that for the prevalence of the coronary artery disease. So across all the TAVI trials, so you can see roughly the prevalence is about 50%. So about half of the TAVI patients would have the coronary artery disease. And of course, you may appreciate that with the latest trial or the newer trial with a low-risk category, the prevalence of the coronary artery disease would be much lower than the very high risk or the inoperable patients. And of course, we all know that what would be the effects of the AS or the aortic stenosis on these coronary anatomy or the physiology. So one can consider that the aortic valve stenosis would be the most obstruction or the most obstructive lesion in the coronary because it's the upstream, the most stenotic lesion. So you can see that with this tandem lesion, it would affect the subsequent or the downstream perfusion of the coronary or the coronary perfusion pressure would be affected. And also the coronary microvasculature, and also the increase of the LVEDP, so increase in the left ventricular diastolic blood pressure would also affect the back or the backflow or the backward expansion of the backward expansion wave of the coronary blood flow. So all these factors we have to consider when we are dealing with the coronary artery disease in patients with severe aortic stenosis. And of course, up till now, I guess there's no one no one would say that which would be the best timing for the PCI in patients undergoing TAVI. And to be honest, at the time when we wrote the guidelines, so there are many different or conflicting evidence or data to say whether we should perform the PCI first before the TAVI or after the TAVI. So quite some of these studies actually would say that there are no much difference comparing the outcome when we perform the PCI before or after the TAVI. So that's why, so when we consider whether we have to perform PCI before or after TAVI, there are many different factors that we have to consider. For example, the complexity of the PCI, the complexity of the TAVI. So usually I would balance this. So for example, if you're dealing with a very complex TAVI and a relatively simple PCI, so perhaps then you would probably perform the PCI first before the TAVI, because you have the coronary stabilized, and when you perform the TAVI, maybe you have a less chance of the coronary risk. But on the other hand, for example, if you have very complex PCI, then probably, and you have to perform the PCI first. So there are many different factors that would affect your decision. And of course, some operators nowadays would prefer to do it in a single procedure. So it's a combined PCI with TAVI. Of course, you have a lower cost or the lower procedural time when comparing to two procedures, and you can use the same arterial access. And so there are many factors that we have to consider. And there's, I guess, it's no one single evidence that would say that which one is better than the other. And of course, we have to all know that there are the leaflet height of these different devices when we are consider doing the PCI. And especially what be more important is if we have done the PCI before the TAVI. Because if someone do the PCI before the TAVI, then you have a substantial risk of the coronary access or because of the risk of the ISR of the in-stent restenosis. So even if you do the PCI before TAVI, you still have to consider the risk of the coronary access. And of course, this one Ola has shown you before. And but you just have to consider in the right panel is that if the coronary ostium is right behind the commercial pulse, so I would guarantee you that the coronary procedure would be quite challenging because you won't have enough the guiding catheter support. You won't have very coaxial delivering of these balloons or the stents. So you just have to imagine. So if you have to consider the PCI with the commercial misaligned device, then perhaps you have to go in with the side stroke, and you have to have different or the guiding extension or different techniques compared to doing a PCI in a commercial aligned valve. And of course, I won't go into the details, but that's different of the self-expandable valve. As previous speaker mentioned, you have different ways to achieve the commissural alignment. But the most important way is still you have to confirm it in the cups overlap view. So in the cups overlap view is the only view that you can confirm whether you have the commissural aligned or misaligned valve. And with these, the guideline actually have no concrete evidence on whether the timing of the PCI. But we can say that the latest evidence that adds to this view is this data from the Notion free trial, which was published last year. So we can see that it's quite a simple design trial. It's a RCT and with a severe AS undergoing TAVI with coronary artery disease. So it's a 1-1 randomization. So one arm is a conservative management for the coronary part with TAVI. And the other arm is the PCI with the TAVI. And the primary endpoint is the MACE endpoint 1 year after the TAVI. So quite interesting point is that regarding the timing, so we all know that the timing for the PCI, in this Notion free trial that the PCI timing, indeed, most of them are before the TAVI. But some of them you notice that the PCI was performed during TAVI and even some are performed after TAVI. So the Notion free trial was not investigate the timing of the PCI, it's just that whether you perform the PCI in these patients would have any benefit compared to those treated with conservative approach. So you can see that for the primary endpoint of the MACE outcome as compared to the medical treatment conservative arm. So patients with the coronary artery disease will have the PCI done. So they have also the clear definition of the coronary artery disease. So in this study, they define patients with coronary artery disease as the lesion with a positive FFR of more than 0.8. Or if you don't use the FFR, then it's angiographic. So angiographic, you have the stenosis of more than 90%. So of course, one may argue that the accuracy of the FFR in patients with aortic stenosis is still debatable. But nevertheless, they use the FFR cutoff or the angiographic cutoff. So you can see that we do a PCI together with TAVI in these severe coronary artery disease patients, you have a lower MACE outcome. So the conclusion from these, the latest evidence from this Notion free trial is that the PCI together with the TAVI, they don't specify the timing of the PCI. It's just that if you have severe coronary artery disease, still you have to do the PCI associated with a lower incidence of the MACE outcome compared to the conservative management for this coronary artery disease. So that's it for my presentation. Thank you.
Thank you, Dr. Wang, for your excellent talk. Because we are far behind the schedule, can we proceed to the next presentation? Thank you.
Okay, next topic will be conduction disturbance by Dr. Ying Xiang Li from Taipei.
First of all, thank you for the opportunity to talk about something linked to my background and EP doctor. And this is my first time to talk about this issue in Valve Summit. And here I would like to go through with two cases, my personal cases, to talk about this issue. Here is my first case, very impressive to me, because she is a female at the age of 64 and quite typical aortic stenosis with unstable angina and also have mildly reduced ejection fraction. And our first case was quite successful. Here you can see the pressure gradient is good and the ejection fraction is good. But, you know, at that time, and also the first case, so I think the implant depth is not so optimal. So we got an left bundle branch block at the end. And during the following 3 months, the patients suffer from repeated dizziness, shortness of breath, and syncope in the ambulance, and then also recurrence in the restroom. And finally, we witnessed her asystole. And you can see the tracing is complete AV block, but just without any escape bits. So at the end, we implant a pacemaker for this lady. And here you can see the result. Only 1% of pacing is needed for this lady. But even this few need, this low need for pacemaker could also kill this patient as well. So that's our first case from TAVI procedure. And this is a beautiful picture. I guess you already read this 4 times. And the conclusion I have, I modify it. The original is AV block is quite common after SAVOR and TAVI. But I think after years of workout, now we already reduced the percentage. But so far, I think left bundle branch block and also AV block is still not rare enough after this procedure. And this is the study many years ago. Just want to show you that pacemaker doesn't matter after TAVI. But I think at that time, because all of these patients are actually quite old and multifactorial with the risk factors. So I think as an EP doctor, maybe because of the patient population and also all of the procedure at that time could not show the negative outcome from left bundle branch block. And here is the new guideline. You can see that we are shifting our patient population from the very elder to quite younger. So this is the latest data from meta-analysis showing that I think that's quite common sense in EP society, but maybe it's quite new here. New left bundle branch block is harmful to our TAVI patients, and also new implant of pacemaker is also harmful to our patients. You know, in Taiwan, the presence of left bundle branch block could help you get rid of military responsibility. So left bundle branch block is quite harmful, even you are at age of 20, okay? So, but come back to our case. In the next 2 months, the patient still suffer from respiratory distress, and then even mechanical ventilation. And there was no conclusion in another hospital because this is the echocardiogram. Looks quite normal, right? The contractility is not that poor, maybe even better than the previous one. But actually, when you look at it carefully, the septum and the posterior is always on the same direction. So this is a case with obvious LV asynchrony. The ejection fraction is actually less than 35%. So that's why the patient suffer from repeated respiratory failure. We can just call it HFrEF here. And here we can show you a variety of mechanisms of harm from left bundle branch block. But I think the major one is always left ventricular asynchrony. But if you don't pay attention to it, usually we will ignore it. And here you can see that the left bundle branch block could be the cause of cardiomyopathy, and also could be one of the reasons to get our left ventricle worsening. And go back to our first case. You know, many patients can get benefit from TAVI. So you can just feel the patients get improved, but you never know the benefit was already attenuated by left bundle branch block because you have no randomized control trial for the single patient. And here it's very interesting, or you can say it's very embarrassing for us at that time. We have to repeat all of this expensive procedure during 5 months. We always say we need to do something more for this lady. And at that time, we also give our, not at that time, 2 years ago, we also shared the same case in our AP Society to have a question. What would you do in the modern era? The answer would be conduction system pacing. So here you can see we will use physiological pacing at the His bundle or left bundle error pacing. It's much easier, but not that easy as you think. Because the left bundle branch, we have variety of the pattern. I personally think it's much more than these 5 types. And because there is multi types of the left bundle, so actually the result is just based on chance. And you can also add on NCRT plus physiological pacing to help your patient. But here you can see this is our first case. Even with CRT, the QRS is even wider than the left bundle branch block. But we were very fortunate because LV pacing alone, you see here, the contractility is better than this asynchrony type. So we just lucky. And I think the final cause from conduction disturbance, here I would like to share the emerging issue is the TR, tricuspid regurgitation from our lead. This is another case. We just treated him 6 months ago. You can see this patient suffer from atrial fibrillation even after 2 times of AF ablation. And the reason is because the pacemaker for six-sinus syndrome caused tricuspid valve deteriorated. And the TR, AF, and right heart failure is just like a vicious cycle. If we want to treat it, we need to know the mechanism of the relationship between the lead and the tricuspid valve. But here you can see just like left bundle branch block. It could be the cause, but could also be one of the reasons to get it worsening. Even the lead-associated TR, you can see even the lead didn't touch the valve. But I just give you an example because we never know the real causality. If there is adhesion to the chordal tendon, the valve will be deteriorated after years of pacemaker lead. I just gave you the example. This is our second case because we use our eyes to displace the lead. Here, you can see the lead is here. We think it's impinged to the tricuspid valve, but after we remove it to the center, the regurgitation looks the same. So we can skip the think about lead extraction. We just do TriClip for these patients. And after 1 year of waiting, the TR improved to about minimal. And here you can see it's very interesting because the atrial fibrillation becomes easier, becomes slower. So we can reclassify this atrial fibrillation to atrial tachycardia. So finally, how we eliminate this atrial tachyarrhythmia? We just do post-field ablation at the roof and mitral isthmus. But if we do not treat TR, I think the enlarged right atrium cannot make it so easy to treat these patients. So come back to our issue. When talking about conduction disturbance, I think the only one we can modify during the procedure is the implant death so far. So what we need is maybe to think more, to pay attention to this, and maybe we have different choice just before you getting into the hybrid OR. The balloon expandable valve so far have better results regarding to this issue. But you know, our patient always have multiple factors we need to think. So maybe the valve of choice is not the only reason, but regarding conduction disturbance, this is the final result for your consideration. Thank you.
Thank you very much. So for the sake of time, I think we should move on to our last lecture, which will be given by Dr. Tianping Zhao on the topic of coronary reaccess after TAVI. Dr. Zhao, please.
Thank you for your introduction. So this is our last talk for today, so I'll make it quickly. This slide has been shown by Dr. Wang, so I'll skip this slide. And the coronary cannulation after TAVR, and there are selective cannulation and the semi-selective cannulation and the impossible cannulation, especially for the self-expanding valve, and selective cannulation and semi-selective cannulation for the balloon expander valve. And the factors impacting coronary access, including the anatomical and the device and procedural factors, including the ST junction dimension, sinus height, and the leaflet length, and the buckness, and sinus of Valsalva width, and the coronary height. And for the device and the procedural part is commissural tap orientation, and the sealing skirt height, and the valve implantation depth. And the selective coronary cannulation can be achieved 95% in the patient receive SAPIEN 3 valve, and 71% for the patient receive the aligned supraannular valve, but only 46% for non-aligned supraannular valve. So the predictors of impaired coronary cannulation after TAVR, including non-aligned supraannular transcatheter heart valve, and the transcatheter heart valve and the sinus of Valsalva relation, and the sinus of Valsalva height. So the commissural misalignment increased the barrier to the coronary access. The commissural height of the different transcatheter heart valve, there are about 15 to 22 for the SAPIEN 3, and 26 for the core valve, and 28 to 31 millimeter for the accurate neo, and the 26 to 29 millimeter for the portico. So this commissural alignment, we can the guiding catheter can easily engage the coronary arteries. If there is a commissural misalignment, the guiding catheter is quite challenging to engage the coronary arteries. So the commissural alignment use cusp overlap view is quite important. This is an example of Evolut R or Evolut Pro, and when the device, when the valve cross the aortic valve, the head marker should be at the center front. And for the accurate neo or portico, the post should be at the left side of the heart. So the commissural alignment steps, the step one is the flushing post should be at the 3 o'clock, and we can check the head marker at the outer curve, the aortic arch. And then the pre-deployment, the head marker should be at the center front. And after deployment, the C pedal should be at the left side of the image. So it's high implantation of the transcatheter heart valve a better choice. It's about the PPI versus sinus sequestrations. If we implant the valve higher, there's a potential risk factor for sinus sequestration, including the long coronary sinus Valsalva or small sinus inflow diameter. The valve to ST junction is the short or short ST junction height or higher implantation depth. And for the self-expanding valve with a higher implantation technique using the cuspid overlap view, and the implantation depth target at the 1 to 3 millimeter. And we can see the 30-day PPI rate is 0%, it's very good. And the new onset, the persistent left bundle branch block is quite low, it's 4.2%. But the risk of sinus sequestration in TAVR is very high, and it is 64%. So the implantation, high implantation may compromise the coronary access of reduced TAVR. And there's another factors like the factors, including the VTC less than 4 millimeter, or the VT-STJ less than 2 millimeter. These are also high risk for coronary obstruction, and or VIV in failed bioprosthetic valve, especially the stainless bioprosthetic valve, or the supraannulus bioprosthetic valve, or the externally mounted leaflet of a bioprosthetic valve, like mitral flow or trifecta, or surgical bioprosthetic valve implanted in tilt-oriented toward the coronary ostium. So the coronary risk in reduced TAVR and the neo-skirt height is an important issue. It's also the risk plan is even higher than the first-time TAVR. And the anatomical factor, including the coronary height, VT-STJ, VTC, and all commissural alignment, these are also very important. And for the coronary ostium above the neo-skirt, if we put the short in short or toe in short, I think the coronary access are okay. There's no problem with the coronary access. If the coronary ostium below the neo-skirt and the YSTJ, if we put the short in short or toe in short, I think there's feasible. Or if the YSTJ and the large VTC, and we put the short in toe, it's also okay. But if we put the toe in toe, it's a problem with coronary cannulation. If the coronary ostium is below the neo-skirt, and with a narrow STJ or small VTC, whatever the combination is, short in short, toe in short, short in toe, or toe in toe, the coronary cannulation are infeasible. So we can use the in-phase view to help selecting the coronary arteries. So an in-phase view enhances the understanding of the three-dimensional anatomical orientation. We use two angiographic projections. One is an in-phase view. The other one is a perpendicular view. It's like a LAO. So we use these two views to cannulation the coronary artery. Is more easy. So we can also use the C-TAP on the Evolut Pro to guide the cannulation of the coronary ostium. And the C-TAP provides a marker for the location of one of the commissures. Then we can localize the C-TAP, and then we can draw a virtual triangle indicating the location of the commissure post. Then by avoiding the triangle apex, engaging the ostium become much easier. So this is an example of CAG by using the in-phase view and also perpendicular view. And the left coronary artery is normally at the top of the enhanced view, and the RCN is normally at the bottom of the enhanced view. So we have a case of 85-year-old female TAVR on April 2024, heart failure admission. He has calcified osteo left main stenosis, poor renal function. And we use Jenkins 3.5 French via right groin and ECMO via left groin because there's osteo left main disease, and because the valve was implanted with commissural alignment, so we can easily engage the left main ostium, and we can show the left main ostium which is very calcified. And RCA was fine, so we use 10% dextrose to do the OCT because the renal function was very poor. And from the IVUS, we can show the osteo left main was very calcified, even the calcified nodule. This is OCT also showing the osteo LRD heavy calcification. And we can use the 1.75 millimeter per at 180,000 RPM and then 140 RPM. This is angiographic and showed the left main ostium, the calcium was abraded partially. By the OCT, we can show can get the extraluminal by the burr, and the calcium was abraded. So we continue to use the 2.25 and 160 and then 140, and this angiographic. This procedure is guided by the OCT. You can see the calcium and further ablated. Then IVL4, and we can implant the Megatron DES, and then the NC balloon. This is final angiographic result. so we can complete the procedure. So the tip and trick for the balloon expander valve, I think this is similar with our daily practice for the coronary intervention. But for the SEV, it's suggested to proceed from the left radial or femoral, use a J-wire stiff angle glide. You can do the baseline angiogram to understand the coronary anatomy in relation to the transcatheter heart valve, and use a smaller catheter like a J03.5 instead of J04, and use a J-tipped wire to help the catheter positioning and the manipulation. And we do the non-selective angiography followed by selective wiring of the coronary ostium and the use of Geislin catheter. So this is our data, and this is the retrospective data from 2015 to 2023. We have a totally 787 patients receive TAVR, and 80 patients receive CAG after TAVR, and 35 patients receive PCI, 19 with balloon expander valve, and 16 with self-expanding valve, including 2 cases of CoValve and CoValve. So the result can show the result show the vascular access or lesion type and lesion location. In use of the extension catheter, there are no difference between the self-expanding valve or balloon expander valve, and the PCI procedural success is also similar with both group. So we have 2 cases of CoValve and CoValve, and one is impossible to engagement. This is the implantation depth was high, so this cannot engage the coronary arteries. The other one we implant deeper, so even with CoValve and CoValve, we still can do the PCI. So the first one is commissure misalignment, and the second one is commissure alignment. So we use the FIT technique. First we do the flushing, and then wiring, the fission wiring, and then extension catheter, and then do the stenting for the procedure. So the conclusion is coronary access can be challenging after TAVR, and the first TAVR procedure matters, especially for the further future coronary reintervention. Assess the root anatomy in detail to avoid the coronary obstruction during the TAVR, and apply the FIT technique for PCI after TAVR. In first view, may help choose correct frame cell for selective coronary access. So thank you for your attention.
So thank you very much, Dr. Tsao, for your fantastic lecture. So I have one question. And nowadays, so we just started using Evolut FX Plus with large hole. And do you think this new feature will make our life much easier?
Yes, yeah, okay. I believe that if FX Plus, good alignment, and then the PCI won't be a problem in the future.
Okay, so very good, the patient selection, as well as the that valve choice is quite important. So thank you so much for a fantastic talk.
Thank you.
So now, so we reached to the end of this session. Thank you so much for the joining this session until the end of this day. So I hope you will have the very good dinner in Taipei. Thank you so much for attending this session.
So this has been a truly inspiring and informative day. I'm sure we all have learned some valuable insights, not just on technologies and techniques, but also on how to serve our patients through thoughtful decision-making and innovation. May I invite everyone to applaud Dr. Ying-Wei Xian for the closing remark.
Okay, today's meeting has come to an end. I really enjoyed the program. And I believe all of you also enjoyed the didactic training, live cases, interactive sessions, and the case discussion. I believe you will have a very fruitful day. Tomorrow we will have a more exciting program lined up tomorrow. So I hope all of you can join the meeting tomorrow too. So don't forget, tonight we will have a welcome dinner. As every year, I hope you enjoy it. Thank you very much for your participation. Thank you.